have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future. With patient safety and quality healthcare. We are CAHO. Your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety. Setting up standards, won't ever leave no stone unturned. With passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation. We have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future. With patient safety and quality healthcare. We are CAHO. Your healthcare companion. Standing right by your side.
Thank you, Jesse, for that wonderful anthem. It reminds us that cow is at our back. Thank you. So can I request everyone to have the cameras on? Thank you. So welcome to the program on enhancing clinical communication skills. Although this program we planned for clinicians, but all are welcome, and I think we have participants from other departments also, like quality, nursing, administrator, and it's wonderful to have a mix of people that really enhances the benefit of the program. So before we go ahead, I think I would request Dr. Vijay Agarwal to say a few words to the participants and inaugurate the program. Thank you.
So good morning, everybody, and welcome to this very, very important program. And thank you, Dr. Indu Arneja, for asking me to be a part right in the beginning. So, friends, we all know, I think the Kaho anthem will remind you about all the qualities and the mission and of Kaho. And I can say that restoring the trust of the community has to be one of the most important function today of the healthcare professionals. I've been saying, you see, the kind of advances that we have made in the healthcare in the last 100 years are really phenomenal. Lots of diseases that we could not think that can be cured, or today, a number of us in 80s and 90s are living very active life. It's all because of the advances in healthcare. But in spite of those advances, if you look at and you go to any party, you go to any community, the trust between the community and the healthcare professionals has been going down. And as if there is no kind of an end. And I feel that one of the most important aspects that is not being taught in our curriculums, respectively, whether it is medical, nursing, or anything else, is the communication. I think the art of communication is not only important in our professional lives, it is very important even in our personal lives, right? So I really congratulate Dr. Indu Arneja for relentlessly trying to bring up this particular subject and trying to train the trainers, trying to teach people. And our request will be that let us try to imbibe all that and convert it into an impactful action in your organization. And do let us know in whatever way you think Kaho can support you in your mission to improve clinical communication, governance, or any other part of safety. Let us try to move from just being an accredited hospital on paper to be accreditation ready every single day and to become a high reliability organization. And for that, I feel communication will remain a cornerstone of our knowledge. So over to you, Indu, for taking it further. Thank you. Thank you so much.
Thank you so much, sir, for your very clear message that we really need to work towards quality, and communication plays a very big role in creating the experience of quality patient care. Thank you for your words, sir. Thank you. So, welcome, friends. Welcome once again to the program. It's Enhancing Clinical Communication program. You have already been shared the reading material and also the program schedule. But at the same time, the real learning will happen when you will all participate. Just being mute spectator and attending it as a seminar will not be a good idea, because it's all through learning by doing. So there'll be a lot of activities, there'll be a lot of participation, role plays, videos, discussion, question answer. So I would expect everyone to give 100% attention and participate and come up with your understanding and learning and your doubts also about communication, whatever clarifications you want to make about it. We can all discuss during the program. The program is very tightly packed. We have actually picked up 5 topics, although the list is very, very long. But we thought that these are the 5 topics that will help all of us to at least be ready to understand what is communication and why communication. So the first session is all about helping us understand that communication is not just about niceties. Most of us think that it is soft skill training, but first session will open your mind to the fact that it is not soft skills alone. There's a lot of clinical communication that happens between us and the patient, and also between us as a team member, and how the failure to communicate effectively can impact patient safety, outcome, diagnosis, treatment, medical error. All that is related to communication. The first session has been planned keeping that in mind, so that we all are on the same page and we are clear about the fact that it is not just soft skill training, but it is a lot more than that. That's first session. The second session is about what are the essential skills in patient management. Many of you may be very experienced, very knowledgeable, already practicing those skills. But just to bring everybody on the same page, we'll be discussing a couple of skills that if we all imbibe, and not only imbibe but demonstrate and also train our staff wherever you are working, with your nurses, with your doctors, with your housekeeping staff, everyone. I mean, those essential skills that I'm going to share with you are something that once you will train your staff in doing that, you will see there'll be a huge change in the work culture of your organization. So second session will be about what are the essential skills in patient management. The third session is about how do you go about handling difficult situation, and that's also particularly on managing aggressive patient party. We all know that's one challenge we all are experiencing day in, day out. As long as everything is going well, patient is well behaved, we are very happy, everything goes well. But the problem is the moment patient becomes uncooperative, or they are aggressive, or they are demanding, that's where the real challenge lies. And we actually are not very clear about how do you go about managing that situation or de-escalating that situation. So in session 3, we are going to talk about how do you first of all identify the situations that can turn into an aggressive outcome, because that's possible. Second is, if we are able to identify that there's a risk of violence or aggressive reaction, how do we mitigate at the earliest so that we can de-escalate and manage the situation in the best possible manner. And we'll be doing a couple of role plays also around it, so that we learn how to actually handle somebody who is acting very aggressive. The next session, that is session 4, will be about breaking bad news. We all know we haven't learned formally how to go about breaking bad news. So we'll be learning some protocols, some deeper understanding of what are the steps to breaking bad news, so that you can train your people, you can empower your staff how to go about breaking bad news. And although we know the breaking bad news is primarily done by the doctors, but at the same time, the staff plays a very big role. Nurses and other support staff really play a very important role in keeping this situation within control, and there's an expected behavior from them in that period of time. So what is their role and how they can really help to everything happens smoothly, because that's one challenging situation. There is always a risk of aggressive reaction or some extreme reaction coming from the patient party. So we'll be talking about that. And the last session is about disclosure of medical error. I know we don't like to talk about it, but then we all know errors happen. Most of the times we don't know how to go about discussing it with the patient party. Mostly the focus is on covering it up, but a lot of time the situation is such that you can't just cover it. You have to come out and you have to speak to the patient and the family, and that's where the real skill of communication comes in, where you are able to demonstrate that, I mean, you haven't done anything willfully, or it's not your negligence or ignorance that has led to patient harm, but you are with them and you want to really make sure that the damage can be minimized, and whatever support is required, that can be provided. Again, all this what we are going to talk will be related to Indian healthcare delivery system. Although most of the learning comes from the Western world, because they are the one who are practicing it in a more advanced level, but we have tried to customize the content and the interaction in the Indian context so that we can actually use it in day-to-day functioning. So these are the 5 topics we will be covering primarily in the program. And of course, in between, you're free to ask questions and have discussion. But before that, I have some technology reminders for all of us, so that we all know that this is what is expected from me. So give me a second to share my screen to take you to the technology reminders. I hope my screen is visible to all of you. If somebody
Yes,
can.
ma'am.
Great.
Yes, ma'am.
Thank you so much. Yeah. So very clearly that I want to message all of you is, please make sure that you are not only physically present here, since you have enrolled it voluntarily, so you should be mentally, physically, socially, spiritually with me, and that will really help enhance your learning. So make sure that you rename your login ID with your official name, because I may be calling you by your name, so it's better if I know your official name and I address you with your official name. Throughout this session, I expect you to have your video on. There can be instances where you need to have the video off, but that should be just for few minutes. But otherwise, it will be really helpful if you keep your video on. That's going to actually enhance your learning. Because I have seen when you have your video off, there's a possibility of mind wandering somewhere, or you may start thinking of something, or getting engaged with other things, getting distracted. So when you keep your video on, you are on the camera, and that's why you are focused on what is happening. Preferably keep the gallery view so that you can see everyone, and you are able to interact also with the other members. Then keep your device on the mute mode, because I know many of you may be joining from your office. So naturally, there will be some interaction at your office, or even when you're at home, there is a possibility that some noise around you can come in. So please keep your device on the mute mode, but whenever you want, you can unmute, and whatever you want to say or ask, please feel free to unmute your device. So if you're moving or changing your place, at that point, you can stop your video. If you're interacting with somebody, at your workplace or at home, momentarily, you can stop your video. In case there is some phone call that you have to receive, you can switch off your video, but that should be only for a couple of minutes, not for very long. And then, of course, I will be asking you a lot of questions, and I will be asking you to respond to the questions in the chat box, because I want everybody to participate. So whatever question I ask, I'll be asking you to respond in the chat box. So make sure that answer whatever is being asked in the chat box. So there are some group agreements that I just want to revise for all of us. Although I know we all are professionals and very experienced, knowledgeable, but just to make sure that we all follow these ground rules. As I said earlier, also, active participation is the only way to learn together. I have sent you material. You can go through that. I'm sure a lot of material is available, even online, but that's not going to help you. The real learning is when you participate, when you ask questions, when you answer questions. That's where the real learning happens. And everybody has experience and everybody is here to learn. So we have to make sure that everybody gets a chance to contribute. A lot of time when we are experienced and knowledgeable, we tend to speak more. But as a result, what happens, people who are new or not very sure of their answer, they may hesitate speaking. So we'll make sure that everybody gets a chance to answer the question. And when we are, as I said, that we have a mix of group. Mostly we have doctors, but we do have some people from the quality department, some administrators, some nursing officers. So we have to be mindful of their presence. And when we speak, we have to make sure that everything, we maintain the decorum of the program. And please speak for yourself rather than generalizing for anybody. Whatever we discuss here remains here, because a lot of time you may discuss a situation in your workplace. So we are not going to talk about that after the program. That's going to stay in the program and finish it here. I know trust is earned and it takes time. You are meeting me for the first time, so naturally you will have a couple of doubts and questions in your mind, but I'm sure slowly we'll be able to earn the trust, and we'll have more confidence in each other. Please keep your phone on silent mode. If you have an urgent call, please mute your device and switch off your video while attending the call, and keep your call very, very short. Otherwise, I would normally suggest that if you can avoid taking the call, that will keep you focused. This is regarding the time management. As I said, we have a very packed schedule with a lot of important content. So make sure that we follow the timeline. I've shared the schedule with you. I have also mentioned the time that we want to devote to each topic. So please be mindful of the clock, because a lot of time when we are discussing or when we are sharing our opinion, we don't realize that we are actually overshooting the time. So as a result, the other topics may get, neglected. So we'll make sure that we cover the topic within the stipulated time. We'll be having, kind of a tea break and lunch break, which I've already mentioned in the group, but I'll just make announcement once again. So make sure that we don't, waste time. We come back after the break and we start immediately with the discussion or the program. And each minute has to be valued, because when we are 1 minute late, we are not 1 minute late. If we are 30 of us, then we waste 30 minutes. That's how we have to value time, and make sure that we come back and join as early as possible. And I've sent you course material. Please read it whenever. Of course, you will be reading it after the program, which I understand completely. But do go through your notes and keep a copy and a pen also ready with you, because there'll be a lot we'll be discussing which you may want to note down. You could even take a printout of the booklet that I have shared with you. That will help you in just one second. So that will help you in revising your notes. Yeah. Okay, that was about the technology reminders. We have discussed the program, we have discussed the topics, so I'm not going again to the topic. Regarding the breaks in between, the first break, that is tea break, we will have around 10:30 for 15 minutes. Then we will have lunch break around 1:30 for 45 minutes. And the third break will be tea break around 3:30 to 3:45. So the program will be from 9 to 5 p.m. Any questions you have about it as of now, please feel free to ask me. My gentle reminder to all of you to keep your camera on. That would be really wonderful if you can have your camera on. Okay. So going ahead with the program, Okay. Dr. Girish, you have not received the course material. Is it okay if I send you during tea break? I will send it. Whoever has not received the uh, study material, please message me. You can message me directly or you can message me in the group and I will make sure that it is emailed to you during tea or lunch break. Thank you. So going ahead with the first topic of the program, and that is uh, what is the importance and relevance of communication. So my question to all of you is, why all of a sudden communication has become such an important integral skill of the patient management? I want you to write in the chat box why all of a sudden communication has become such an important and integral, part of the patient management.
Ma'am,
Right?
patients these days have become very demanding. So they need to know what is happening with their physical health, financial status, and everything. So in corporate world, we need to explain each and everything and to safeguard us also from the medical legal aspects, because that's when the documentation part comes into play.
Wonderful. So that means patients have become demanding. Okay, I agree with you. What do others say? I mean, if you want to unmute and speak, even that's okay.
Earlier, I'm Dr. Girish. Earlier, I think we all, when we were trained, we never had, we look at our professors, how they communicate with the patients, and accordingly we do. If they are arrogant, we'll also become arrogant. Now, the last 5 years, the Kalamazoo, that is where Kalamazoo, where that particular format is being introduced and being taught in the medical curriculum from the first year to the final year. And they have found majority of the unrest that is occurring between the doctor and the patient, or because of the patient due to various reasons, is due to the lack of communication.
I completely agree. So that means we didn't have the right role model because they were not trained. It's not their fault, but they were not trained. They were not told what is the importance of communication because patients never demanded it. Like Dr. Shishak says that it was never demanded, so it was not provided. Now they are demanding, and if we are not ready, that's where the conflict lies. And if we upskill our medical, graduates in communicating effectively, I think this trust issue can be looked after. Like Dr. Tushar has mentioned about the trust issue. I completely agree. I think that's another reason why we need to now communicate and make sure that they feel being heard and feel being informed about what is happening. Dr. Tanushri has mentioned patient needs to be a part of their treatment process to enhance adaptability. So clear communication will help that. That's such a wonderful, thought process, Dr. Tanushri. So that means we are not unhappy with them asking for communication. See, when we say they're demanding, or when they're now they're asking more, so there's a feeling that there's a resentment that, oh my goodness, now we have to communicate because they're asking us to communicate. But how beautifully you have mentioned that patients need to be a part of their treatment. Definitely. So if I'm a patient, I would definitely want to know what treatment are you planning for me? What are the options available for me? Which is the best suited option for me? So considering all those things, definitely my doctor need to interact with me. So if that interaction happens, that not only brings clarity to the patient, but also between the doctor and the patient, there's more clear communication and both are on the same page. We come from an era where the doctors were like practicing more like paternalistic style of medicine where doctors decided on the behalf of the patient. So as a result, patients are okay, they were happy. You decide, and also patient used to say, "Doctor, साहब आप बताइए क्या करना है? Doctor, साहब, you decide what I need to, should I get the surgery done or should I get the wait for the treatment?" So it was fine, but now things have become very different. Patients are educated, they're paying for service, they have access to knowledge. We all know that they can go to AI, they can go to Google, they can go to Meta. On WhatsApp, you have that facility available. You just have to message on WhatsApp, what is this disease and what are the treatment options? You get a answer to it. So naturally, if they have access to information, they want to clarify, they want to ask us. And that's where the real conflict lies when they come and ask us a lot of questions. By the way, how do you feel when they ask a lot of questions? Are you happy or unhappy? Write in the chat box. Write in the chat box. Are you happy or unhappy when they ask a lot of questions?
Sometimes we feel they don't do much and they're trying to buzz on us.
So we feel they don't know, but they are trying to boss us.
Yes.
What do others say? What do others say? Is it the same way you think? Oh, Dr. Shraddha says irritated. Absolutely, Shraddha, I agree with you. That's because we come from a point of view where we never thought that we can be questioned. We should be answering. Why should I?
Please না ফেটে চলে যাবে
So why should I be answering? Why should I be explaining? I am your well-wisher. I know my subject. I know it. Maybe you know your subject, but maybe the patient knows their circumstances, their family dynamics, their social system, their body, how the body responds to the situation. So why not come to a level where we act as an expert, subject expert, but we facilitate decision making? And that's where, Shraddha, we have challenge in practicing shared decision making. That's what is being asked now. They talk to your patient, explain to them, give them options, tell them what are the risks involved, what are the benefits, and then decide. Let them decide, and then you help them decide. So our role from decision maker has come to, you know, facilitation of decision maker, and that's something we are not very happy. So I agree with you. We feel irritated. Wonderful. Dr. Rima says we feel like we are being judged. So true, because we feel that oh, why are you questioning my knowledge? And a lot of time when they say, can I take second opinion? Can I take Ayurveda help? Can I try naturopathy? We really get buffed. We really get unhappy with it. What is this? You can't be, talking to me like this. What if actually they are not judging you, but they are expressing their apprehension? Everybody wants to get well soon at the earliest. So they want to try all possible ways and they want to know, am I on the right track? Is there some other option available? Can I try that so that I recover faster? But we take it as a personal, kind of insult that, oh, you're judging me, you're not trusting me, which is actually not true. So, okay, with Chat GPT, it has still become worse. Dr. Girish, I completely agree with you. But at the same time, I want to remind all of us, see, every technology, every innovation has advantages and also disadvantages. We can't, deny that. But at the same time, if you are smart to use it to your advantage, you can actually still stay the subject expert and win your patient's confidence. So I was interacting with a very senior, bariatric surgeon. I was, just interacting and asking him, like, how do you respond to when patients ask you questions that they picked up from Google or some doubts they picked up from Google? So a lot of time, they ask n number of questions, and that's very irritating. And he said, I really, I not only enjoy when people ask questions because I know they have done some preparation, but if I'm better prepared, I can answer them more confidently. And also some of the risks, some of the possible complications, all that is also documented. So when you tell them, they see this is one of the documented complication. There is a possibility of this relapse or this complication. So that makes my job easy. It's again how you want to look at it. Nothing will stop for us. Are you ready to handle it? Are you ready to take advantage of it? That's your call. And that's what is going to decide whether you're happy with Chat GPT or not. And some more answers in the group. Okay. So clearly it says that things are changing at a very fast pace. I completely agree. Patients are now educated and they're paying for it. See, when somebody is paying for a treatment, they want value for their money, isn't it? Because earlier, mostly healthcare used to be either free or very nominally charged. I remember when we were kids, something like 50 rupees or maybe 100 rupees was the fee that we were charged, and we were even given medicine for that. But now we all know that, the cost of treatment. Today, if anybody gets admitted in a hospital, where will you be and how much you have to pay? So when you're paying for a service, you really expect that you will get value for money. Also, aggressive reactions coming from the patient side. Also, the legal hassles. We all know there are some patients' rights and responsibilities we have to respect, and we have to make sure that they are looked after. All that has made communication very, very important and very relevant. So let me take you to the presentation and take the discussion further from here. Give me 1 second to start the presentation. It's taking a while to load. So is the presentation visible to all of you? Is my screen visible?
Yes, ma'am.
Yes, it is.
Thank you. Thank you so much. Thank you. Okay, as we were discussing, that practice of medicine was much, much simpler earlier, but things have really changed in the last couple of decades. People have become more aware, they are more demanding, there's more answerability now, people have become more aggressive also. As a result, the conflict is on the rise. And also, media participation, we all know what it is and how it is. And then, of course, problem of litigation and extent of fights have really multiplied many, many folds in the last couple of decades. So to respond to all these changes, there is a realization that we need to work on number of things, and one of them is patient communication. Let's see what do studies suggest. There are so many studies that actually showcase the communication that we make, but this one study I thought I'll share with you, that according to Tong et al., 75% of the orthopedic surgeons who were surveyed, they believe that they communicated satisfactorily with their patients. But when their patients were asked, only 21% of the patients were actually happy with the communication they were made by their treating doctor. So that shows the gap between what we think we are communicating and what our patients see as communication. So even when it comes to practicing shared decision making or informed decision making, many of us still feel that we cannot practice shared decision making because patients don't understand the medical condition, they don't have enough information, they don't have enough skill, so they can't take a very a right decision, and therefore somebody else should be deciding on their behalf. Whereas a lot of other studies have shown where there those who advocate shared decision making, they feel that in almost every situation it can be practiced. Studies have also shown, if this one study I'm talking about, that is Institute of Medicine, they have identified that clinicians and other healthcare professionals lack adequate communication skills training. Till very recent past, there hasn't been any proper inculcation of communication skills to the doctors. 2019 onwards, we have introduced ATCOM module, that is Attitude, Ethics, and Communication module in the medical education program. And now from year one, like Dr. Girish was talking about the Kalamazoo interview inventory, that's being introduced now. And we are hoping that in the years to come, the medical students who will become graduates and will come into practice will ultimately be able to showcase some effective communication skills while handling their patients. So with Maulana Azad Medical College for the last 10 years, I'm working with the final year students, and I have introduced Calgary Cambridge Guide to them, and I train them in patient interview skills using Calgary Cambridge Guide, and I also cover some of these topics where they need to learn how to handle uncooperative patients, or patients who are not really understanding their point of view. That's with the idea to make sure that they are better prepared to deal with the patient and their family. So this is a recent survey that happened in India by ICC, CRMAA, and Taragini. So almost 45 to 50% of the patients and the families reported that they did not even have clarity on the diagnosis. What is my case? They have no clarity. There was lack of understanding on treatment and care options. What are the options available to me? Do I have any other option to treat my condition? They didn't have that idea. They also perceived lack of involvement in deciding the treatment. As we are discussing, that most of the times we prefer, deciding on their behalf. So we don't, in real sense, include them in helping them take a decision, but rather we already have made up our mind, and that's what we push them for. And as a result, they feel that they were not involved in the decision making. Somewhere they felt unempowered in the treatment of their patient. They feel that they're still a mute spectator in the treatment of patient. All in all, they also reported it to be a rush consultation with their treating doctor. Almost 1/3 of the patients felt that they were not allowed to describe their conditions or symptoms. So most of them, they felt that they were not given enough time to talk about their problem. Any idea if we allow the patient to speak, in how much time they can tell about their problem?
Yes, studies have shown any patient who enters into the outpatient department, and when they start talking to the doctor, first 3 minutes are very, very important. They will tell their story, but the doctor interferes in the first 1 minute itself by putting leading questions, because they don't have the patience to listen to all the stories. A patient can never be satisfied if they're not being listened to properly.
So the recent study, Dr. Girish has said that we interrupt the patient within 11 seconds of interaction.
11 seconds.
And if we allow the patient to speak, most of the patients are able to talk about their problem in 1 or 2 minutes. But usually we lose patients and we don't, allow them to complete what they are saying. And as a result, somewhere they feel that they were not allowed to describe their condition. Almost the same number of patients felt that the doctor did not straightforwardly address their concern. So that means somewhere there was a feeling that I had a couple of questions. They were really very important to me, but they were not answered impactfully. So as a result, there's a feeling that my questions were not really answered properly. So I think all in all, these studies clearly show that in India and outside India also, the concern is same. Patients feel that they need to be given a little more time to talk about their problem. They feel that their concerns should be addressed by somebody. And when their concerns are not addressed by us, due to any reason, it could be lack of time, it could be overburden, it could be that I'm not really very prepared to answer those questions, that is where they start going to ChatGPT or Google. See, when they don't get answers to the questions, then they will definitely go and search on Google or put on ChatGPT and ask for answers. Then we can't be unhappy with them that you are going to Google and you're coming back to us with so many other questions and concerns. My question to all of you is, if we communicated effectively, if we learned how to communicate effectively, how do you think we will be benefited? write in the chat box. Please write in the chat box. If we communicated effectively, how will we be benefited? Ultimately, we like to do something only if we are benefited by that. So write in the chat box, how will you be benefited? Okay, patients will trust us, I agree. Patient satisfaction, absolutely, I agree with you. Will save our time also. That's very true. I agree with you. Patient will feel involved in the treatment. It can reduce conflict. That's a very important outcome, absolutely. Less of headache, less calls from someone known to. Yes, that's true. More compliance. And of course, you will be able to diagnose correctly. Very right, Rama. I completely agree with you. 50 to 80% of the diagnosis can be made if you ask the right questions, if you allow them to answer, and you listened carefully. And very right, if you give that chance, you will be very close to the right diagnosis. Less legal issues, yes, it will avoid further complications. It will reduce errors and medical legal hassles. I agree with you completely. See, so many benefits of communicating effectively and learning how to communicate. See, that's an art that can be learned. It's not a rocket science. Anybody can learn, provided we are willing to learn, provided we want to improve our communication skills. We normally think that, oh, I know how to communicate, so I don't need to learn. So this particular session will open your mind to the idea that it is not about talking effectively, but what to talk, what to ask, how to listen. That's a very important skill that we need to learn. Studies have shown that if you communicated effectively, your medical errors will go down. According to Joint Commission, medical errors are the third commonest cause of death in US. We haven't done any study in our country. I don't know if we did, where we will stand. But this should tell you that how important communication is. In India, they have identified 5.2 million medical errors happening annually. This is a study done by Professor Ashish Jha from Harvard University. I have a feeling that this is an underestimation. Errors must be much, much more than this. So medical errors like wrong site surgery, wrong medication, wrong organ removal, wrong treatment, and wrong patient, they're very, very common. Most of the errors are around medication error and patient. Yeah. Of course, infection and surgery also are a big chunk. And 60 to 70% of these errors are because of poor communication. That's the sad story. We all think we communicate very well, but actually the real communication does not happen the way it should be. So let's do a small activity. I'm going to put 5 of you in the waiting area. Any 5, please raise your hand who are ready to participate in this activity. Okay, Dr. Girish, thank you. Who else? You can raise your hand, you can raise virtual hand, whatever is comfortable. I need 5 people to, so that I can put you in the...
I'm ready.
Okay, thank you so much, Dr. Sheershar, Dr. Archana, Dr. Tushar, I think, because two of you are together. Okay, Dr. Shraddha and Dr. Tanushri. Thank you. So I'm going to put all of you in the waiting room and I will call you one by one. So Dr. Shraddha, I'm sending you to the waiting room. Give me 1 second. Okay, great.
Joined in as
Dr. Tanushri, I'm putting you in the waiting room. Somebody's device is on unmute mode. Can I request you to, so Dr. Tushar, both of you will go to the waiting room because you are joined together. It's okay. It's your call. So 3 people have gone in. Dr. Shishak, you are also okay to go?
Yes, ma'am.
Okay, thank you. So we have 4 people. Okay. And one more person I need. Dr. Rima? Okay, Aparna, you will go? Thank you, Aparna. I'm sending you to the waiting room. So, Dr. Rima, I will be showing you a situation which all others will be able to also read. You have to just read it for yourself and let me know when you are ready. Is that okay? Are you clear with the activity, Dr. Rima? You can unmute your device.
I will be in a waiting room.
No, you are not in the waiting room. You are with me now.
Okay, okay.
I'm going to show you a slide which is visible to all others, but I want you to read it to yourself. You don't have to read it to everyone, but you have to read it to yourself. And tell me when you are ready.
Yes, ma'am.
Okay, so I'm going to stop sharing. And whatever you have understood, I want you to explain that to the first person that I'm calling from the uh, waiting room. So I'm admitting Dr. Tanushri, and you have to, whatever you have understood, you have to explain to her. Give me 1 second. So, Dr. Tanushri, Dr. Rima has a set of information she's going to share with you. Please listen to her carefully. So, Dr. Rima, whatever you have understood, please explain to Dr. Tanushri.
Here is a 21-year-old male in bed number 1 and who had underwent a removal of a calcified tumor between third and fourth rib by Dr. Shetty. And the patient had numbness below the nipple area. And Dr. Shetty was not available this morning. So, telephonically, neurologist opinion needs to be advised, and it was forwarded. Neurologist opinion was forwarded.
So,
Okay.
Dr. Tanushri, have you understood?
Yes.
So, shall I call the next person so that you can explain the same thing to the next person? Is that okay?
Okay.
Yes.
Okay. Give me a second to admit the next person. So, I'm admitting Dr. Archana. So, whatever you have understood, you have to explain to her. Okay. So, Dr. Archana or Dr. Tushar, whoever is participating, Dr. Tanushri has a set of information she's going to share with you. Please listen to her carefully. Go ahead, please.
Yeah. So, hi, Dr. Archana Tushar. I've got a set of information from Dr. Rema saying that there's a 21-year-old male admitted in bed number 1. The patient has undergone a removal of calcified tumor from third and the fourth rib by Dr. Shetty. The patient is complaining of numbness around below the nipple area, and Dr. Shetty was not available in the morning. So telephonically, we have to get information, neurological advice from some neurologist. So that message has to be forwarded.
Okay. So, who is participating? Dr. Archana or Dr. Tushar? No, one of you have to. Is your device connected on audio? Because I'm not able to hear you. I think we are probably you are able to hear us, but we are not able to see we are not able to hear your voice. You have to uh, connect your audio. Maybe you log out and log in, but I'll call the next person meanwhile. Is that okay? So when you log in, you have to use your device audio system. Only then you will be able to. So, Dr. Tanushree, I'm admitting Shraddha, Dr. Shraddha. So whatever you have, like, sorry, you'll have to repeat it again to Dr. Shraddha. Dr. Shraddha, can I request you to have your camera on? Okay. So, Dr. Shraddha,
Yes, ma'am.
Dr. Tanushree has a set of information. I want you to listen to her carefully. Dr. Tanushree, please go ahead. Dr. Shraddha, are you able to please settle down?
Yes, ma'am.
Are you part of the activity or you have just joined? Because I don't know.
No. I am part of the activity, but I have joined from another device because it was not giving me technical.
Okay. Okay. So, Dr. Tanushree has a set of information she's going to share with you. Please listen to her carefully. Dr.
Yes.
Tanushree, please go ahead. Yeah.
Yeah, so hi, Dr. Shraddha. I've just got received a message from Dr. Rema saying there's a male, 21 years old, on bed number 1, recently operated for removal of calcified tumor from third and the fourth rib. Now by Dr. Shetty. Now the patient is complaining of numbness below the nipple area, and Dr. Shetty is not available in the morning right now. So a neurologist opinion has to be taken, so that has to be forwarded.
Okay, got it.
Okay. So, Dr. Shraddha, I'm going to call the next person. I want you to, whatever you have understood, I want you to explain to them. So, I'm admitting Dr. Shirshak.
Yes.
So, Dr. Shirshak, can you please have your camera on? Yeah. So, Dr. Shirshak, Dr. Shraddha has a set of information she's going to share with you. Please listen to her carefully. Dr. Shraddha, go ahead, please.
Yes. Hello. Am I audible, sir?
Yes, madam.
So good morning. We have a patient, 21 years male, who is on bed number 1, and he has been operated for calcified tumor on third and fourth rib by Dr. Shetty. On asking to the patient, we found it. Patient is complaining about numbness below the nipple, and so as Dr. Shetty is not available on the is not physically available, so he has told us to take the neurologist opinion. Patient is complaining of numbness below the nipple.
Dr. Shirshak, is that okay?
Yes, ma'am, but then I have few queries.
Yes.
First and foremost, we don't identify the patient with bed numbers. We identify the patient with the
Dr.
name of the
Shirshak,
patient.
hold on. I mean, whatever information she's shared with you. The activity is little different. I'm going to admit the next person, and you have to communicate whatever you have understood and
Oh,
clarify.
that's all.
Is that okay? So let me
Yes.
take the next person in, and I'm admitting Dr. Girish. Okay.
Madam, my speech is very bad today, my voice. I'm having severe high fever, actually.
Oh my goodness.
So,
Same is my situation, but
welcome, Dr. Girish.
yeah. Dr. Girish, Dr. Shirshak has a set of information he's going to share with you. Please listen to him carefully. Dr. Shirshak, please go ahead.
There is a patient in bed number 1 who has undergone a surgery of 2 of the ribs.
सब रिमूव कर देना है क्या अभी आपने आपकी
Sorry?
डिवाइस क्लिक कर दिया है
Sorry? Can I go ahead?
Yes, sir.
A
Dr.
patient
Shraddha,
is
you want to say
admitted.
something? Yeah, okay. Please go ahead. Sorry. Yes, Dr. Shirshak,
A
go ahead.
patient was admitted in bed number 1, and in the third and fourth rib, he has undergone a surgery. And now, and the patient was admitted under Dr. Shraddha. The primary consultant's name is Dr. Shraddha. Post-operatively, the patient complains of numbness below the nipple. However, Dr. Shraddha is on leave or she is not available in hospital. So she has asked the informant to take a neurological opinion to solve this problem or to solve this complaint of the patient.
Dr.
This
Girish,
is
is
all
that
the
okay?
information I have got.
Yes.
Dr. Girish, is that okay? So I'm admitting Aparna, the next candidate, and I want you to, whatever you have understood, I want you to explain to her. She's joining in. Yeah, Aparna. Dr. Girish has a set of information he's going to share with you. Please listen to him carefully.
Okay.
Yes, Dr. Girish, please go ahead.
In bed number 1, a patient has been admitted and the patient had undergone surgery on 3rd and 4th.
Okay.
And Dr. Sresh Ghosh has not mentioned about what is the type of surgery. Dr. Shraddha is a surgeon who operated. Post-operatively, the patient developed a numbness below the nipple, and Dr. Shraddha has asked for a neurologist's opinion.
Okay.
This is what exactly he told.
Okay.
So, Aparna, whatever you have understood, can you explain in your words?
Yeah. A patient in bed number 1 has been had come for a surgery on 3rd and 4th, and Dr. Shraddha was the doctor who treated him or her, and but the patient developed a numbness below the nipple, and now Dr. Siddharth has asked for a neurology OP.
Thank you, Aparna. Thank you. So, friends, what happened in this communication? Write in the chat box, because I don't want to listen to your words. I want to see what you have seen. What happened to the whole thing? What happened to the whole message? Write in the chat box. Okay, name change. Dr. Shetty se Dr. Shraddha ho gaye. Very good. Okay. Then what else changed? Patient का नाम कहाँ गया? क्या था patient का नाम?
Not there. Name was not told.
That's not. It was something, but it was not sure. बाद में तो sex भी पता नहीं था. Male या female, not sure. Age not mentioned. Okay, age also forgotten. Name गया, age. हम भी normally this is how we talk. No, अरे that patient on bed number 7. अरे वो appendectomy वाला patient. अरे वो TB वाला patient. अरे वो pneumonia वाला patient. That's how we talk about patient. Multiple factors change, exactly. But what happened to the complete message? Surgeon name changed. Name of the patient was missing. Surgery was not mentioned. Absolutely, completely got changed. 3rd and 4th rib जो है वो dates change हो गया. Yes, I agree with you. 3rd and 4th जो था, it was surgery between 3rd and 4th rib. वो dates में change हो गया. True. Age not mentioned. Patient detail not mentioned. Surgery details, surgeon name changed. And then of course, what else? Operation details not mentioned. मतलब सब कुछ miss हो गया, honestly, है ना? Everything got mixed in. See, we normally say patients do not know how to communicate. They are not good communicators. They can't tell about their problem properly. See, this is how even we communicate. Although I saw most of you very meticulously writing down whatever information was being shared with you, that was being noted by all of you. But even then, the whole information got mixed up. Neurologist call over skip. Yes, the main important thing was call the neurologist. That particular information got missed somewhere on the way. We all come from different background, different educational background, socio-cultural background, different communication skills. Some communicate very effectively, some are not very good communicator, some don't have good vocabulary, some have very limited vocabulary. So when these things work together, there's all possibility of making errors. And we thought it is the patient who makes error, but honestly, more errors happen on our side. So this was a real life case that I shared with all of you. This is not something that I've just created. This is a real life case that happened in one of the hospitals. And unfortunately, this patient was not seen for almost like 16 hours. Let me show you the slide to the first slide, because some of you who were in the waiting area, you did not get a chance to see this slide. This was the information shared with the first participant.
Oh my God, he has not said anything.
Yes. See, that's how the information gets diluted. And this is a real life case that has happened. And what happened as a result was, this patient was seen 16 hours after the first complaint of numbness. And poor boy, he went into irreversible paraplegia. 21 years old boy. Many of us may be having kids of his age. You know, most of the communication happens, failure happens because of lack of coordination between us. We work in silos. This is my department. I will only look into this. That's not my area. I'm not going to look into that. That's where the patient suffers. Patient has one body. Patient wants to be treated by multiple doctors because that they see it as a benefit. But we say, I'm a cardiologist, I'll work only on cardio. I'm a neurologist, I'll only work on neurology problem. But then look what we are doing to the patient. And that's what is the reason for the error that happened in the patient care. Between us, we don't communicate effectively. Between us, we don't clarify things. Any idea in a simple, activity of taking a blood sample from a patient, how many people get involved? Write in the chat box. Guess how many people get involved in a simple activity like blood sample? Write in the chat box. 8. Okay. Patient, doctor, lab technician, bystander. Yeah, but then somebody orders, somebody notes down, somebody takes the blood sample, and somebody, goes to give the blood sample, somebody collects the blood sample, somebody does the testing, somebody enters the, record, and then somebody collects the record, then somebody ties the records to the file. Imagine how many people are involved. Almost like 8 to 10 people. You're very right, Dr. Sheshi. And that many opportunities of error. I remember I was taking a session for a group of interns. So one of them said, ma'am, I was asked to take a blood sample of a patient. I took it, and next day, when we were having a round, consultants round, we were discussing his lab finding. The patient said, sir, mera to blood sample kal nahi liya. My blood sample was not collected yesterday. Everybody said, how is it possible? There are reports attached to your file. What are you saying? How is it possible? And then when they went into detail, they found out patient number 7 ka patient number, bed number 6 पर बैठा हुआ था. We did not confirm the patient's identity. We assumed that this must be this patient who is sitting on the bed, and he took the blood sample. That patient did not say anything because he thought maybe mera blood sample lena tha, liya hai. That's how errors happen. When a lot of times we assume things that itself can be a reason for a problem. Any idea in an average day of 3 to 4 days, how many hands does the patient information exchange? Write in the chat box. Minimum 10. Okay. 20. Okay. More than 10 to 15. Okay. Yes, Dr. Archana, very right. Archana or Dr. Tushar, I don't know. 50 to 60 people handle a patient's information in a 3 or 4 day stay. There are so many nurses, there are so many doctors, and there are so many, external departments that come in between who handle patients' information, and that many opportunities of error. And if we don't communicate effectively, if we don't coordinate with each other, a lot of errors happen. So very important is communication is essential to lead to a better coordination between all of us. We need to communicate with our team members effectively to make sure that we are on the same page. As a result, definitely patient safety and continuity of care will be looked after because errors happen because of communication failure between us. Even, you know, sensitive communication like breaking of bad news, end of life care, grief counseling, these are very intense communication. They require advanced level of training, practice, and then actually doing this activity. I don't know how many of you have genuinely received something like this, any training of this kind. As a result, you know, most of the patients, like 70 to 80% of the patients, considered that this was a suboptimal experience. Very few doctors are able to handle these sensitive communications impactfully, meaningfully, compassionately, effectively. Most of the times, patients are left confused or feeling hopeless and helpless and feeling that where do I stand? A lot of time, what we say is very, very inappropriate in this situation. I remember a patient had relapsed after say 3 or 4 years of her cancer treatment. It was a lady who was taken by her brother. So her brother was sharing his experience with me. He said, I'd gone with my sister to the oncologist. And what he said was, अरे बहुत अच्छा निकल गया आपका 4-5 साल तो ठीक ठाक निकल गया अब हो गया कैंसर तो होना ही था रिलैप्स तो होना ही था you are right but what you have said is too blunt for the patient. So a lot of time, since we don't know how to go about doing this, we really require training to learn how to communicate these, informations effectively. If we communicate it effectively, even the risk of medical negligence goes down. Especially in critical care areas, the patient and the family like to be updated. They want to know what is happening in my case. And if you don't communicate, they already have this assumption that we are not very careful with treatment. We are not very responsible. We are not very particular. We are just after money. We just want to make money from their stay. And if in case, unfortunately, if the patient goes into some complication or something happens, they assume that because the patient was not looked after well, that is why this patient died or had this complication. Studies have shown that almost in 70 to 80% of the cases where the patient sued the hospitals or doctors for medical negligence, the problem was not medical negligence, it was poor communication. It was when they were not communicated effectively. That's where the communication gap happens. And if we communicate it well, I think this risk of medical negligence will go down. And we all know whenever there is allegation of medical negligence, there's a possibility of violence. Violence can be prevented if we knew how to handle conflicts, how to de-escalate situations, how to proactively communicate, how to address their concern. When you don't do it, it ultimately can end up into violence against us. And especially, unfortunately, if the patient dies, if the patient suffers some harm at our hand, you can expect violence against us. You can study your own hospital, go into depth of all cases where you experienced violence against any of your healthcare provider. The deepest root cause would be communication failure from us. You can study any case, you will find the same issue in all cases. If we communicated effectively, I think much more than anything else, you will be happy with yourself. Your team will be happy with you because communication is not just with the patient and the family. You are working with the team, with a set of people. You have nurses, you have residents, you have doctors, you have other support staff, and everybody needs to feel part of the team. And when you communicate with them compassionately, respectfully, giving them their due respect and regard and acknowledgement, that's where the real professional satisfaction lies. And all that is nothing but communication. Appreciation, acknowledgement, there's so much into it. That's the benefit of effective communication if we communicated well with the patient and between us. Now, my question to you is, what are the benefits of effective communication to the patients How do you think the patient will be benefited? Please write in the chat box. Please write in the chat box. How do you think the patient will be benefited if we communicated effectively with them? Patients will feel safe and sound, absolutely, in respect to his treatment. Agreed. Less aggressive, yes. They feel satisfied with the treatment. Better outcome, yes, Archana, I agree with you. They'll be more satisfied, they'll be better off. They'll have more confidence and satisfaction, absolutely. Better understanding, reduced confusion, yes. They'll feel satisfied, absolutely, they'll be happy. Reliability develops, yes. The trust factor will definitely go up. And then trust develops with doctors, absolutely. Patient satisfaction, building trust, doctor and treatment, and leading to create positivity, and so will recover. Everything will be positive. The patient will be happy, patient will be satisfied, patient will have trust, so automatically outcome will increase and the recovery will be faster. Absolutely, I completely agree with you. If you communicated effectively, your patients will can see it, can feel it, can sense it, that you are really looking after them well. So automatically their body starts healing itself when they feel they are in a safe and good place. They feel that they are wanted, they are respected, they are welcomed, they are treated as a human being. The body starts healing because it starts releasing positive hormones. Their compliance improves, their participation improves. So communicating with the patient effectively is very important, and lot of studies have shown patients respond better to the treatment modalities when they have good communication coming from their healthcare provider. Chronic conditions like diabetes, high cholesterol, hypertension, HIV, glaucoma, they all respond better when you have good communication. Simple thing like diabetes. I tell my patient who has diabetes to make lifestyle changes. But what exactly I mean by lifestyle changes? When I say make dietary changes, what exactly I mean by dietary changes? What if I explain that, see, whatever meals you are taking, divide them into smaller quantity. Don't take too much food at one point of time. And these are the foods you are not supposed to take. These are the foods you can take comfortably. And you can make a, now I'm giving them proper communication. Just saying that, control your diet or regulate your diet or change lifestyle. What exactly I mean by lifestyle changes? I have to talk, in detail. Similarly, with high cholesterol, hypertension, HIV, whatever lifestyle changes they need to make, can I be more specific? Can I give them complete information? Whenever you or your team will communicate effectively with them, you will see these patients will perform better. Even in cardiac surgeries, they have seen patients respond better to the treatment. There's a decrease in post-operative complications such as cardiac arrhythmias. It's not me who is saying, there are multiple studies that have shown these changes. So you can see when you communicate effectively, when their questions get answered, when they feel that they are, their concerns are addressed, automatically you will see their compliance will improve. They will have more clarity on what changes they need to make, why they need to come for follow, why they need to restrict salt, why they need to control their sugar intake. So all that, when it is explained properly, automatically it will improve their compliance. And of course, without any doubt, you will see they'll be very happy with you, because primarily patients communication is the way we handle. They don't see your degrees, your qualification, your experience, how well behaved you and your team is. That is what patients value. And that really improves patient satisfaction. So, my last question to you is, if we all communicated effectively with the patient, with their family member, and also between us, how do you think the organizations will benefit? Write in the chat box. डॉक्टर शीर्षक से टाइमली बिल पेमेंट, उसके लिए भी कम्युनिकेशन जरूरी है, जो आपने लिखा है ना, वो भी बहुत इंपॉर्टेंट है. Good number of patients, yes, that's true, very true. Word of mouth publicity with better flow of patients. Yes, Dr. Archana and Dr. Tushar, 75% of your footfall comes from the word of mouth that your satisfied patients spread about you and your organization. Of course, built up of positive, better, and strong reputation of the institution. Yes, your work comes with your reputation, with your work, organizational reputation. Good marketing of organization. I agree with you. Reduce discharge time. Very right. Less conflicts. Patient will go, will give better feedback. अरे अब तो Google का time है. Nobody will go and write good reviews, but very quickly they'll go and write poor reviews in case if you are, if anywhere they have a bad experience with us, and patient will return for other elements also. Yes, absolutely, I agree with you. Positive environment with less educated relatives and happy staff. I think, Dr. Achana, this is really very, very important. Less conflict and patient will go, give better feedback. Absolutely. I completely agree with you. See, it's a culture. It's a culture that we create. And every organization has a culture. We may realize, we may not realize. And there's an energy. The moment you enter a hospital, you see everybody being very respectful, very cordial between them, between each other, and with the patient and the family. And there are organizations you go, it appears completely chaotic, and everybody seems unhelpful. But if you improve the culture of your organization, the work environment will change. See, we spend 8 to 10 hours in our workplace. It's very important to have good work environment because we don't carry money from the workplace. We also carry the energy. So creating good work environment is useful for us. And then of course, greater job satisfaction. I've seen people staying in one place if they have a great job satisfaction. Attrition is a problem with most of the organization. One of the reasons could be the poor work culture of the organization. Of course, if we communicated effectively between us, if we followed the protocols, if we followed the checklist, automatically the patient safety and quality will get improved. Higher patient experience scores, if you will take their feedback, they will give you a positive feedback. And of course, improved patient loyalty, they will come back, they will come for follow-up, they will send more patients to you, they will come for other problems also to your hospital. And of course, they will recommend to the hospital. So I think this session has given us clarity that it is not just the nice behavior, but all medical errors and quality healthcare is primarily dependent on good communication. So in nutshell, communication in healthcare is not about niceties. It is therapeutic communication that happens between you and your patient. It is the clinical communication between us that we talk about the patient. It is part and parcel of the treatment and not optional. And it has a direct impact on continuity of care, patient safety, and treatment outcome. And there are set communication protocols for everything, for everything. And every healthcare provider should know about those protocols and should practice them meticulously. And there are so many ways to learn and implement these protocols and these skills. Thank you. So this is session 1. We can take a couple of questions. We have around 3 to 4 minutes. Anything you wish to say or ask, clarify? But I hope this brings some clarity to our mind that that we need to communicate effectively.
I think you're right when you said that the degrees do not matter. It is your attitude and communication and how much you can actually actively communicate and listen and show empathy to the patient is all what that matters.
Absolutely. See, these are all small things. We may not even realize that they exist and they can impact, but patient really values those things. And between us also, when we don't communicate effectively, you say something and you don't clarify. We have seen a lot of errors happening when we are The task is not clear to the other person, but they don't clarify. So I can see when something can be
any study which shows that why doctors fail in communication. What are the reasons?
So honestly, in India, we are not open to studies. I have tried multiple organizations requesting them that can we do a study with you? Can we do something? But we have not received any, positive willingness, because everybody feels that, why should I wash my dirty linen in public? So they don't want to. But we definitely understand from the experience that I have, like I've done more than 2,000 programs. So I do have this understanding that one, of course, there's lack of training. Unless you will formally integrate it in the training program, then slowly probably you will be able to see the change. So right now we have a very mix of role models. There are very good role models available who communicate very effectively. Second is there are role models who don't value communication at all. They think I'm here to treat, I'm treating, that's all. Communication is not my cup of tea. I don't want to get into. And then of course everybody thinks that I just have to do my task as much as I can. And patients also never demanded it, so they never got it. But now we all know that patients are demanding it. We will have to work on it. We will have to provide them this. Slowly things will change, definitely.
So I think apart from communication with the relatives, it is very important that doctors are also communicating properly with each other.
Absolutely.
Like suppose there is one patient and a primary has given reference to some other consultant. There is very key step where the patient management will change. But they will be reluctant to talk to each other. They will tell the duty doctor, okay, you talk to the referred consultant and ask him. So that really delays the matter. The communication is not effective and it delays the management of the patient.
Absolutely.
So I think communication between the doctors is also equally important.
Absolutely. So this case that I discussed with you, although Dr. Shetty informed his team to, connect with the neurologist on urgent basis and take his opinion, what if he had called himself and asked one of the neurologists and told him, send your resident to see that patient. I mean, I operated, but I'm not in the hospital right now. So can somebody go and check on him and give me the, or maybe after 10, 15 minutes, he could have checked with his own team. Has somebody come in? Have you sent the referral? So follow-up is very important. Completing the communication is important. But that's where we assume it will happen. It never happens on it. I've seen a lot of senior consultants being very rude and aggressive and intimidating to their residents. So when you insult your residents, when you're rude with them in front of the patient, one is patients will lose faith in your residents. Second is your residents will lose confidence in themselves. They'll be very scared to, come in front of you. I remember one of the interns, she approached me. She said, ma'am, I go into panic attack because once I was in an emergency department and one senior resident came and shouted at me in front of so many people. The moment I see him, I go into panic attack. That's what was her concern. Now imagine if this is what we are doing to our own fellow professionals, what about people and public doing to us? And I know a lot of senior consultants are very rude and aggressive. But that's not the game we should be playing. So Shraddha has asked a question, what can be few set of questions for initiating conversation? Patient to get perfect information. So we will be covering this in the second session after the tea break. We'll cover that and I'll try to include this aspect also. Dr. Tashau says non-verbal communication and verbal communication can add up the maximum in value of the patient experience. Absolutely. And we are going to cover this in detail in the second session. Thank you for bringing that up. I'm glad that you are coming up with your thoughts and you're sharing your thoughts. So that's what is really expected. And all those who are keeping their cameras on after the tea break, please have your camera on. I get my energy to talk from your, audio visuals that I can see. So I respect and I request all of you to have your camera on. You have voluntarily registered for the program. So be here with me and interact with me. All of you have beautiful face. I would like to see everyone, whoever is around. So we break for a cup of tea. It is 10:32. We come back at 10:45. Is that okay?
Yes.
Yeah. So we meet at 10:45. Thank you so much. Thank you. The session of discussion is what are the essential skills in patient management or patient care. So I want you to write in the chat box, what do you think are very, very important or essential skills in patient management? Write in the chat box. Okay, proper assessment of patient, fine. That's very important. So I'm particularly focusing on the communication skills and interpersonal skills. Clinical part, I'm sure I expect you will be able to manage. But when it comes to interacting with the patient, like listening, somebody has mentioned listening and empathy. Yes, Dr. Girish. Identity of patient means age, gender, caste, occupation. Again, Dr. Shraddha, yes, they are very important to make sure that you don't make mistake on the patient's identification. But I'm primarily focusing on communication and interpersonal skills I'm talking about. What should be told and what not, yeah. Being careful about what you're saying. Then listening to their complaints, discussing the treatment modalities with them. Yes, that's also discussion, negotiation, shared decision making, eye contact, very important. Greeting the patient by his or her name, again, very, very important. And listening with empathy, proper assessment. Okay, soft spoken tone in conversation, that's very important because that's what is going to make your patient comfortable. What else? Assertiveness, very important, Aparna. That's very right. You need to really know how to assert. Yes. So being focused and being away from distraction, that's also an important skill so that the patient feels that you're giving 100% of your attention to them. That's very important. And do not give a stern look when the patient enters your clinic. Very right, Dr. Tanushree, that's very important. The first interaction actually happens visually. The patients look at your face and they get an idea how welcoming you are, how kind and nice you are. And if you have that stern face or no expression face, they are confused whether they are at the right place or not. Then keep your mobile away. Absolutely. I think that's very important because nowadays phone has become a big distraction and they feel that they're not getting 100% attention. Absolutely. So I want to show all of you a video. So this video fortunately has been done by Indian doctors, so you will really relate with them. In the first one, I'm showing you how a lot of time we communicate. I don't mean that all of us do in the same manner, but try to observe what more or less similar you do in the conduct. And the second video is like how it can be done in a better way. So let me take you to the videos and take the discussion from there. I want you to note down from the video what you think was done appropriately or inappropriately, whatever it is. Yeah. Oh God. Just a minute.
Ma'am, there is a audio will be there. We
Yeah,
can't.
I'm surprised that why is this audio not.
Since when?
Give me
For
one
the
second.
last 5, 6 days. Now we can hear you.
Yeah. Sorry, actually, the audio was on the lowest mode. Yeah.
Next.
What? Doctor, my leg is swollen and painful. Since when? For the last 5-6 days. What were you doing? Why did you wait so long? This looks pretty bad. Doctor, I thought the pain was just a strain in the leg. Anyway, what do you think now? You could have waited for some more time and we could have amputated your leg. Leave it. What's your sugar level? It is under control, doctor. The fasting was 140. When was it done? What was your HbA1c? It was 4-5 months ago. Actually, HbA1c is a expensive test and I was feeling all right. So, I can't understand. You do investigation according to your will. You don't take proper treatment. You don't follow our advice. I don't know why you need doctors. And you come up with all sorts of complications like this. And what did you do with your leg? I went on a pilgrimage to Sabrimala, so had to walk barefoot. I might have injured, I think. Barefoot? Hello? Yeah. Who? The patient Ram, HIV positive patient. So he doesn't want CT scan. So tell him if he wants treatment, he needs to undergo CT scan. Right, what does he think of himself here? Prime Minister or President? See, discharge him against medical advice and tell him not to come to this hospital once again. Okay? Yeah, bye. And you got this boon. I'll tell you, if you go once again, you will also go near the God. Didn't I tell you about the foot care when you came last time? Huh? And your smoking is continuing without interruption, I guess. I have reduced a lot, doctor. I am smoking only 1 or 2 cigarettes a day now. I can't understand your attitude here. You do smoking, you are overweight, you don't take medications, you don't do investigations. I don't know what to tell you. I'm trying, doctor. And if you don't want to see me, I could consult someone else. See, whatever I'm telling is for your good. I don't know how to tell. I gave you information leaflets last time and you're not following my advice. And if you don't want to see me, it's fine with me. I have got enough work to do. I've got enough patients to see. Sister, please call the next patient.
So what do you think was inappropriate in the video? Write in the chat box. Doctor did not acknowledge the patient. Absolutely. Doctor was rude. Agreed. No eye contact at entry point of the patient. Disinterested look. Yes. Doctor was blunt, rude, and inattentive. Rude and negative approach. Accusing the patient of negligence. Rude behavior, pointing all faults of the patient. Absolutely. Reaching privacy of another patient. Absolutely. I think that's a very important observation. Good. The patient looked scared and confused. I agree with you, Dr. Girish. Absolutely. Negative approach from the beginning. Threatened the patient, made the patient scared. Yeah. Breach in the patient's confidentiality. Yes, Dr. Tanmishri. Yeah. And no attention towards patient on arrival, arrogant, rude tone towards patient, fearing counseling, rude on calling in front of patient, and then more of blaming than counseling. Absolutely. And negative comments on weight, and habits. Absolutely, absolutely. So I know not everything you must be doing the same, but can you write for yourself? I don't want you to write in the chat box, but spend 30 seconds with yourself and from this behavior, identify some of the behaviors that you may be doing with your patients or with your fellow professionals. I don't want you to write in the chat box because I don't want to make you uncomfortable. But for your own understanding, can you write down a couple of points from the video that you think you also sometimes do, either with patients, their family members, or with your fellow professionals? Okay, done. Now let's watch. So in this video, did you observe that he made mockery of the patient's religious beliefs?
Yes.
A lot of time we do this. We talk very poorly about somebody's, somebody's fasting, or somebody says, I don't eat this particular thing, or I can't eat regular food. So we sometimes even for medicine, if they say that this medicine has a red mark on it and I can't take this. So we actually literally snub the patient by saying, if you want to get well, then you have to take this medicine. There is no way out. So very clearly we could see that he was rude, aggressive. He was not respectful towards patient. He did not make eye contact. What was the first word that he used when the patient uh, came in?
What?
What? So when you say something like this to a patient, what do you think are we trying to communicate? Is it a respectful way of communicating?
No, disrespectful.
Not respectful. So I'm not saying that all of us do everything like this, but some mistakes I think we all make in similar situation. Even when it came to
One aspect, sometimes the doctors might get annoyed, especially in a situation like this, where the patient would have been told a detailed advice on diabetes, diet, and how to keep the feet and all that. In spite of it, they go out, they don't comply. Sometimes the doctors get annoyed.
I agree with you, Dr. Girish, and I think that's because of your concern for the patient and your concern for the patient's well-being. But at the same time, you have to remember, see, if you are seeing 20, 30, 40 patients every day, and if the patients are non-compliant, only compliance rate across the world is 30%. Only 30% of the patients actually comply with whatever you say. So that means almost 70% of the patients will not comply with whatever you advise. So that means out of every 10 patients, with all 7 patients, I'm going to be unhappy and aggressive and maybe, behaving in a little more intimidating manner. But think of your own mental health in that process. Every time when you shout at a patient because the patient is non-compliant or the patient is not listening to your instructions, you are affecting your own mental health. Your job ends once you are able to explain to them what are the benefits or the risk in their non-compliance. After that, they have to decide whether they want to take the why I'm saying this, because ultimately the self-care has to be promoted among people. You can explain to them. You can have people who can do patient counseling and patient education. That's perfectly all right. But at the same time, if you do not disengage yourself from the patient, you're taking patient's burden, and that's going to affect your mental health. So it's very important to remember that you have to just explain and end your conversation with the patient. So getting angry, getting annoyed, shouting at the patient it's not going to help the patient, but it's going to adversely affect you. That's the thing I want to emphasize. And of course, he talked about patient's HIV status in the presence of another patient. So that's again not advisable. Patient's confidential information has to be kept confidential, and we can't talk about the patient's information loosely like this. A lot of time we can get into legal problem just because of this. Let's watch the second video to see could he have communicated in this manner.
Next. Hello, Mr. Kannan. How are you? Please take your seat. Thank you. What can I do for you?
Doctor, I think I have a problem with my leg.
What happened?
4-5 days back, I went to Sabrimala and I had to walk barefoot for some distance.
Mhm.
I'm very scared now because my leg is swollen and painful in the last 4-5 days, and I think I did a stupid thing by walking barefoot.
Let's see what we can do. Good that you realize the importance of foot care. Meanwhile, how are your sugars?
Actually, my fasting sugars was 140, but it was some months ago. I was feeling all right and I didn't do the HbA1c. It is so expensive, you know.
It is expensive indeed, but it is so important to get the investigations prescribed by the doctors, because otherwise it's very difficult to give the treatment, and treatment may not work as well. Anyway, can I examine your leg?
Yeah, sure. Sorry, sir, it was my mistake. I didn't do the test.
Hello? Yeah? Yeah. Excuse me for a moment. Yeah. What's the name of the patient? So he doesn't want the CT scan, right? Yeah. Try to explain to him the importance of CT scan. Yeah. When I come for rounds, I will also tell him. Okay. Thanks for informing. Thanks. Bye. Sorry about that. You got infection in your leg. So how are we doing regarding the quitting the smoking?
Regarding smoking, it's doing good. Actually, I brought it down to only 1 or 2 cigarettes per day now, doctor.
That's good. But total quitting is very important. See, if you have reduced from 1 pack to 1 or 2 cigarettes per day, quitting that is also not very difficult, And how are we doing regarding the exercise?
Yeah, going on, but I must admit not so regular.
See, exercise and diet are as important as your medicines, if not more. But for the time being, you need admission for sugar control and control of this infection. Is it okay with you?
Whatever you say, doctor, you have to cure me this time, and hereafter I will definitely take care of myself. This will not happen again.
Yeah, we need to control your sugars and control the infection. Otherwise, it may go for gangrene and may lead to further complications. Now, the sister will go through the procedure and admission process. Okay. And meanwhile, you have this leaflet and you can go through it, which will help you to follow the regimes. Okay. Thank you very much.
Thank you so much, doctor. It was so kind of you.
You're welcome. Thank you.
So I hope you could see at the end of the consultation, both doctor and the patient were happy. See, very mindfully, we have to remember how we have to conduct ourselves. If you have a tendency to get angry or to shout at your patient or act in a little unprofessional way, it will have a huge impact on your relationship with the patient and also the overall experience that your patient and you will have. Taking it further from here, as I said, there are a lot of skills that can help us become better in our patient management. But I want to share specifically 5 skills with the idea that one, if you integrate these 5 skills in your practice, definitely you will feel much more satisfied after the interaction with your patient. You will set a right example to your team members because ultimately your team members are constantly observing you and learning from your way of managing patient. Third, you can teach even these skills to your team members because since I'm giving you something that is, you can explain to your team members also, and that whole thing can be replicated by all your team members. So the 5 skills that I want to talk about, the first one is building rapport. What is building rapport? What is building rapport? When the patient comes in,
Patient feels the warmth and then opens up to you.
absolutely. So that means we have to proactively make an effort to make the patient comfortable and should feel the warmth. How much time does it take to build rapport? Anyone? How much time
3
does it?
minutes.
Sorry?
2 to 3 minutes.
2 to 3 minutes. Okay. Anybody else?
Even a smile can also make a patient comfortable to start the conversation.
Absolutely. So that means it is not
Few
the time,
seconds.
few seconds. Absolutely. So it is not the time that decides whether we are able to build rapport or not. It is the intention. Do I wish to build rapport with my patient? Suppose a patient comes in and I am doing something, I can see somebody walking towards me. I don't lift my head. I don't make eye contact. I'm doing something. The person comes and stands right next to my table. I don't offer them a place to sit, but I don't show that I have acknowledged your, coming in, or this is the place you have to sit. Do you think I've been able to build rapport with the patient? No. On the
No.
other hand, if patient comes in, I lift my head, I make eye contact. Usually patients say namaste or good morning. If you respond to it, even if they have not said namaste, I can say, Namaste Babaji, aiye, baithiye. And your rapport building has it. Rapport building does not take time. It's a matter of intention. Do I value building rapport? Why is it important building rapport? Why is it important to build rapport with your patients?
Because only then the
That will
patient
help
will
in
tell you
further
the truth.
communication.
Okay, that will
Patient will
help.
tell you all the intricate details and the truth only when he or she feels comfortable with you and and he feels that you are a trustworthy person.
Absolutely. That's a very important thing. So if you remember your internship time or junior residency time when you were asked to, work up a case, you will collect all the details from the patient and then you will go to your consultant and say that, okay, this is the case and this is what is my understanding of the case. But your consultant is not convinced with your explanation and they put a hand on the patient's shoulder and they ask, are you taking any other medicine besides this treatment? The patient says, yes, 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 I am taking actually a treatment for tuberculosis. And then you literally pull your hair. Why did he not tell all this to me? That's because the patient could never have that kind of, confidence and that comfort with you. So creating comfort and familiarity is building rapport. And it is very important to make your patient comfortable because the information that they're going to share with you will only happen when they will have that confidence that I can share everything and I'm not going to be judged for this. Because a lot of time they will hide information like tuberculosis or anti-epileptic medicines because they feel hesitant that they will be judged for. Therefore, it is very important to build rapport and make them comfortable. Is it being friends with them? Is it being friends with them?
No.
No. It is being friendly. It is not
Yes.
being friends, but it is being friendly because we want to make them comfortable, we want to make them feel welcome, and we want them to open up. So that's the idea. Now, the challenge is I want to do an activity with all of you, but most of the participants are not having their camera on. So if I do an activity, I'm going to partner all of you with each other. I'm not sure how many of the participants who have not even kept their camera on, are they going to participate? So can somebody tell me if you want to participate or not in the activity?
Yes,
Dr.
ma'am.
Prachita, Dr. Archana, Dr. Indumati, Sonia, Shivani. Okay. So how many of you want to participate in the activity? Raise your virtual hand so that I know. Yeah, I can see those who are having the camera on, they will participate. But what do I do with others? Jesse, you have to check how many people are there who are actually registered participants. There are a lot of unregistered participants. Okay.
Yes.
I'm going to put you all in breakout room, and I hope partner who comes to your blessing is somebody who opens up, who have the camera and talk to you. So the activity is that I'm going to put you in the breakout room for 3 minutes, and in that 3 minutes you have to tell about yourself, your name, your designation, which hospital are you from, and then you have to tell, if I was not in healthcare, where would have I been? So I will be messaging you. You will get 1 minute time to tell about yourself. So first, one person will speak, the other will listen. Then in the second minute, the second person will speak and the first one will listen, so that both of them get a chance to tell about themselves and you get a chance to listen to each other. I'm going to make breakout rooms, send you with random partners. So I don't know who will be partner to him, to whom. And then we will, and I will message you once the 1 minute is over. After second minute, I will message that we are left with 1 minute so that you can complete your conversation. And in 3 minutes, we will come back to the main area. So is the task clear to everyone? It's clear? Okay.
Yes.
Thank you. So I'm going to create breakout room. Yeah, there will be 2 participants in each.
No, ma'am. Actually, we both are sitting together. So how we both can take participation?
So who has registered between 2 of you?
We both have registered.
Both have registered, but if you have joined from one device, I don't know how you are going to do that. Maybe 2 of you can communicate with one partner, so you will be 3 of them.
Is it okay if I tell her to join from her device? Actually, she has joined, but she's
She can.
joined virtually from there. So I will just let her.
Sure. So I'm creating the breakout room. All of you will have to, join the breakout room. You will get the message and you have to join the breakout room.
Join.
So you have 3 minutes. So you have 3 minutes time to complete the activity. In the first minute, one person will speak, the other will listen. In the second minute, the other person will speak and the first one will listen. And the last 1 minute is to complete the activity. You can start the discussion now. So many of you have not joined any group. Please join the breakout room to participate in the activity. Many of you have not joined any breakout room. Please join the breakout room.
I didn't have any partner in the breakout room. Somebody left, I guess.
Oh, I know a lot of you did not have partners.
Me too,
That
ma'am.
was the
I
time
didn't have any partner.
I should have
I
actually
also
excluded
didn't
all.
have any partner.
Oh, I should have excluded all those who were not having their camera on. That could have been. See, that's the challenge when people don't listen to the instruction and they don't follow the program.
But in that way, we spoke to ourselves.
Extremely sorry for this, but that's beyond my control. The whole activity was all about how many of you could speak to any partner? Anybody who could speak to the partner? Raise your hand.
I spoke to myself. There was nobody in room number 8.
I know. I saw you were
Same
alone.
here.
Anybody who got the partner or nobody got the partner?
Yes, ma'am. Me and Dr. Pooja, we spoke.
You spoke. Okay. So how did you feel after talking to her?
So, in less than a minute, we just summarized who we are and
Hmm.
what would we have been if not what we are right now.
Absolutely. Absolutely. See, within few minutes, I'm sure you must have felt little comfortable, little
Yes,
more
yes.
familiar. So this is what actually, happens when we interact with our patients and their family members. If we proactively communicate with them, we can make them comfortable, we can make them open up, and we can get maximum information in the shortest period time, especially where the workload is very heavy in the government setup, where we know that there's a large footfall, patient footfall. So there it's all the more important that if you are able to quickly build rapport and get the information and work on your patient. But usually we assume that building rapport will take a lot of time, and therefore we avoid building rapport and we mechanically work and we don't even make eye contact. That's the sad story of the interaction. At the same time, I don't know if, I mean, I'm sure if you could not experience it, so you may not really know the value of building rapport. But even at workplace, we work for years together, but we don't build any rapport with our, hospital team. On the other side, I always say that we spend 8 to 10 hours at workplace, and that's more like our second home. And people with whom we are working are like second family. So how important it is to make sure that you feel comfortable with them, they feel comfortable with you, and you are able to be available for each other rather than having that conflicting kind of a situation. So again, at workplace also, proactively we have to build rapport with our team members and make them comfortable and feel respected and important part of the treatment team. So what interferes with building rapport? What do you think interferes with building rapport?
Ego.
Very common. Very, very common. I completely agree. That's one thing which comes in the way. And what else?
Lack of time.
Again, lack of time. I feel that it is, yes, there can be a situation where you are very busy and you don't have time. But mostly, building rapport is more of an act of attitude than the time. Because if you want to build rapport, if you want to make people feel wanted and comfortable, you don't actually really require that much of time. It is intention to build rapport is important. And any idea what percentage of our success and happiness comes from these skills, communication and interpersonal skills? Any guess?
30 to 40%.
A study by Harvard says 85% of your success comes from your communication and interpersonal skills. That's the importance of building rapport and making people comfortable around you and proactively connecting with them. So as we were talking about building rapport, it just takes initial few seconds for the patient to see whether you are willing to build rapport, whether you are wanting to be respectful and kind and nice to them. So it is going to make your job also easy. And when we talk about what interferes with building rapport, any idea what interferes with building rapport? Ego, one of you said. Ego, that's true. What else? What else? Write in the chat box. What do you think comes in the way of building rapport? Introvert nature. Yes, if somebody is very quiet and introvert, there is a possibility that you will have challenge building rapport. So, I mean, you will not feel comfortable making an effort to connect with people. Taking others for granted, yes, that can be one of the, we assume that why do we need to build rapport? I have to just get the work done. I don't need to build rapport. And then superior behavior of the person with whom you are interacting. So the other person is in ego. So naturally you feel that I can't build rapport with this. Personal issues can be, yes. Paternalistic attitude, Dr. Girish, would rather make you more prone to building rapport because in paternalistic, we like to protect people, look after people, make them comfortable. Somebody this is on mute mode. Can I request you to mute your device? There is some sound in the background. So whenever you are interacting with somebody for the first time, you will see the first thing that we observe is their body language. We go to government offices, a lot of time we can actually, see the person sitting in the chair, is he going to be helpful or not? And we decide it based on the body language. And 55% of the communication happens through body language. 93% of the communication is non-verbal, 55 is the body language, and 38% is the tone of voice. And even if I don't tell you anything about this person, I'm sure you can make out that this person is angry, unhappy, irritated, and is literally shouting at the person. And action speaks louder than words. So let's do a small activity to understand what exactly I mean. Actions speak louder than words. So those of you who are having your camera on, I wish others could join in, but that's okay. So keep your hands free. Set yourself free. Keep your hands free. And I am going to do an activity with all of you, and you need to just go with me. So I'm sure you remember that poem. If you are happy and you know that your nose. I hope you remember this. Everybody remembers? Okay, wonderful. So we will do this together. If you're happy and you know that your nose, if you're happy and you know that your ear, थोड़ा जल्दी जल्दी करना है मेरे साथ, quickly. If you're happy and you know that your nose. How many of you were about to touch your chin?
Oh, so then that's the chin. First touch, then that's the chin.
Yes. That's because you were all observing me so closely that though you were listening, but you were not listening. Because visually, the input that we get, we focus more on that. So even when we interact with somebody, if our body language says that I am not happy to see you, I don't want to help you, I'm not comfortable, trust me, they will not be able to really feel comfortable with you. So your body language plays a very big role in making the other person comfortable or uncomfortable. And even if you verbally say, no, I don't want to upset you, I'm there to help you. But if your facial expressions are different, they are going to trust your expressions more than what you are saying. So body language includes everything right from your eye contact, facial expressions, gesture, posture, touch, space, everything communicates. So for example, if we talk about the facial expressions, what are the usual facial expressions we have when we are interacting with the patient? Number 1, 2, 3, 4, 5, 6. Number? Which one? Number?
2.
Number 2?
3.
3. Most of the time it's 3.
It is 3 or number 5? No
First
expression.
and 5.
No expressions.
On listening to the
First and
treatment, it's
5.
5. On listening to the payment, it's 3.
No, we are talking about our expressions, not their expressions. What expressions do we keep normally when we are interacting with patients or with somebody lesser in rank to us?
1.
Maybe at 9 o'clock.
With
Maybe
a
when
smile,
the other
we should
person is
always do
smiling.
that.
But usually our expression is number 5, where we have a no expression face. We don't like to smile. We don't smile. There's a reason why we don't smile. Why don't we smile? Why don't we smile?
Patient may be in pain and we are giving smile, so it will be wrong.
I agree with you. That's one of the reasons. That's one of the reasons where we avoid smiling. But I think in lot of situations, the patient is not in that severe pain or condition. But even there, we don't smile. We like to have a very, expressionless face.
Because by the time the conversation has ended, we are already irritated by the so many questions patients has asked us.
That's also true. I agree. So to start with itself, we have this expressionless face so that the patient does not dare ask a lot of questions. So with this expression, we kind of intimidate the patient. Don't ask me a lot of questions. But trust me, if you smile and interact with people, they feel comfortable, they open up, they share more information, which will help us in lot of other ways. And in case if the patient tries for secondary gains, there are so many ways to refuse. If they try for discount or they try for some secondary gains, all that can be handled. But for that reason, we did not have an expressionless face. So expressions like anger, irritability, unhappiness, attitude, they are visible. Patients are able to sense it. Your team is able to see it. Your staff is able to know it. that you're angry, you're irritable, you're unhappy, or you have ego problem. And that would put off people, that will push off people. Eye contact, very important. A lot of time you must have seen that you visit somebody's room and they're busy doing something, they don't make eye contact. Why is it important to make eye contact? Why is it important to make eye contact? Especially
for
with
building
That gives
trust.
confidence to our patient's relative. When we are making an eye contact and talking, they get the confidence then.
Okay, that's very correct. So it helps patient have confidence in us, and it helps us also show or express confidence in ourselves. And
First, feeling patient feels that he is being attended and he is in proper hands. Means he is.
absolutely, absolutely. So patient feels that there is somebody who's ready to give me 100% of attention and who is wanting to attend to me. Even beyond that, couple of advantages of making eye contact is you get to observe the person, you get to notice the facial expressions. From facial expression you can actually check the intensity of pain or suffering or general condition of the patient. All those things you can get if you make eye contact with the patient. And when you look at them, not only you communicate that I'm listening to you with great attention and interest, but you're also simultaneously observing the patient's reaction to the interaction you are having. So the protocol is look at the eyes and above the eyes for 2 to 3 seconds and shift your focus. Please do not stare at the patient, that can make them feel uncomfortable. And looking from head to toe is absolutely not a good idea. So that should be avoided. So till now, we have not said a word. It's just facial expressions and eye contact. Moving further, the second part in the body language is your posture. Which is okay, A or B?
B.
Forward.
Which is okay? A or B?
We could see only A, but then
Is it? It's not moving? No,
no, A is okay.
This is B. Yeah. Actually, both are not okay.
Both are not okay.
In
Both are
A,
not okay. Correct.
yeah, in A person appears very casual. In B, the person appears slow. So that kind of sitting posture with the patient will not communicate the interest or the attention that the patient is asking for. So an open posture, it encourages expression. So when you lean forward and you show that you are listening, that will help show that you are interested in whatever they are saying. The second part is now language, and language again plays a very big role in communicating not only your thoughts but also the way you look at it. So a lot of time with the patients, not only with patients, with our team members, with our nurses, technicians, and other support staff, with junior staff, and with patients and their family member, our language is inappropriate, and that sends a very bad message to them that I'm not, very good at communicating. So, can you tell me some of the things that we sometimes say to our staff or to the patients or their family members? Can you think of, or maybe it's something that you have heard? So very often we have seen people use disrespectful language, especially for younger people or patients who are little uneducated or poor, or the team members who are lower in hierarchy. We also sound rude, authoritative, and uncourteous with them. Snub others by using foul language. अरे तुम अपना इलाज करवाने आए हो या मेरी knowledge check करने आए हो? In case the patient asks a lot of questions. And even basic courtesies like thank you, excuse me, sorry, we don't practice this with the patient and their family member. When you make your patients wait, how many of you say sorry to the patient? Sorry, I made you wait. Sorry, I had an urgent work. Or How many of you say sorry to your patient in case if there's a phone call in between the consultation and you have to take that call? You take the call, but how many of you say, sorry, I had to take that call? So we don't a lot of time practice even these basic skills. Yes, Dr. Shivani, you want to say something? So Dr. Shivani, you are saying that yes, I do it. Okay, great. I'm not saying not all of us do it, but I'm just reminding that these are basic things that we need to practice with the patient. And a lot of time we are very well behaved with outsiders, but when it comes to practicing those social skills with our team members or with people we are living at, we sometimes don't even practice those skills. So it's very important to remember. And the second reminder is kindness when you practice. It's a language which the deaf can hear and the blind can see. So even if they don't understand your language, they still can sense that you are kind and compassionate. And that comes out even in our body language. After the body language and language, the third is tone of voice. 38% of the communication happens through our tone of voice. We say the same thing but using different tone and it communicates differently. For example, if somebody comes in and I say Aiye. Somebody comes in and I say Aiye, you can make out the difference, isn't it? So we don't go wrong on words. We don't choose wrong words, but we change the tone of voice, especially with youngsters, with juniors, with people lower in hierarchy to us. We have a tendency to use aggressive and authoritative tone of voice. So if you look at this one sentence I have written five, 6 times, put little emphasis on the word that I have highlighted and read that word. And you will see every time the message will be very different. I hope you could see it. And that's what happens when we put little emphasis on something, the whole meaning completely changes. So in public dealing with patients and with our team members, we should avoid inappropriate tone of voice, which is like when we sound unfriendly to people, we are disinterested or unconcerned. They ask us something and we don't respond to them with interest or attention, or we sound inconfident. So if you sound inconfident, they're less likely to accept what you say. Or if anybody is rude and authoritative and aggressive, again, that's not a very desirable kind of a behavior. In public dealing with patients and with our team members, we need to be friendly, act responsible, and that comes in the tone of voice. Confident, and confidence will come from where? Where will the confidence come from? What is the source of confidence?
Believing in oneself.
Believing in oneself and knowledge. If you know your subject well, it will automatically come in your tone of voice. That confidence will definitely come.
And also, if you know about your patient well.
Yes, that's again knowledge about your patient. If you know the details, absolutely. You have to sound soft and polite and at the same time professional and non-aggressive. So please remember, inappropriate tone of voice can trigger extreme reaction leading to vomit. And we have seen this a lot of time. When our tone of voice goes wrong, it can lead to aggressive reaction coming from the other party. So these non-verbal behavior, they should be avoided because they interfere with the building of rapport. That is, when somebody is talking to you and you're looking away, you're not maintaining eye contact, or you are staring, or even when you're looking at them, they can sense a kind of sarcasm in your eyes. Sometimes I've seen people closing their eyes when the other person is talking. Tone of voice can go wrong, using authoritative and intimidating tone, or you get distracted by using your phone, or you start writing something, or even start moving away. These are not the behavior that are desirable. If you want to build rapport, these things should be completely avoided. Now coming to how to build quick rapport. So we have talked a lot about building rapport. Write in the chat box, what do you think will help us build rapport? Write at least 1 point each one of you so that we have. Okay. I'm looking for your answers. So what all can we do to build quick rapport? Smile, absolutely. Eye contact, wonderful. Being respectful, yes. Wonderful. What more? Greetings with good mood, absolutely. Very important. Call by name, again, a very important point. Eye contact, posture, maintain good posture, open posture. Nodding while listening, correct. Body language and tone of voice, absolutely, Dr. Reem, I agree with you. Body language plays a very big role, and your tone of voice. They both amount to 93% of the communication. Body language and tone of voice. Their smile and welcoming them with warmth, absolutely. And introduce ourselves first. Yes, that's very important. Take their introduction and introduce yourself also. Very important. Start with a warm greeting. Absolutely. Absolutely. Allow them to explain completely their complaints. That means listen to them, allow them to speak. Greeting with a smile while addressing the patient by their name. Yes, use simple language. That's very important. Listen and talk respectfully. Again, a very important point. Wonderful. So you all are giving me excellent point. And I think I can just sum it up by giving you these points. They're all, I mean, we have covered almost everything. The first and foremost important thing is prompt attention. The moment they come into your visual field, you must lift your hand and make eye contact. When you don't make eye contact, it shows them that you don't really care whether they are around you, or you have not even noticed them, or you have noticed but you are not respectful towards them. Smile if appropriate. Like one of you said that if the patient is not well, it is not appropriate to smile. I agree with you, but in a lot of situations, the patient is fine. They have just come for consultation and we can always smile and welcome them. Greet the patient. Usually patients would greet you, but in case if they don't greet, you can greet and welcome them. Offer them place to sit, very important. Show them where they have to sit, especially if there are multiple chairs. They may not know where to sit. So it's always good to show where they can sit. Introduce yourself. So in a lot of hospitals, I've seen, doctors, nurses, and other support staff wearing different colored uniform. You may know that blue color is for doctors and green is for nurses, or some other color is for some other staff. But the patient may not know. So it's always good to introduce yourself. I'm Dr. So and so, or I am Sister so and so, so that they know whom they are interacting with. And then ask for patient's introduction. Very, very important. For example, there's an old lady coming with a young boy. Who is the patient?
Maximum possibilities of old lady that she might be a patient, but sometime it happens. With good experience of a doctor, a grandmother can bring grandson to that same doctor.
Absolutely. So that means there is no way to find out who is the patient rather than asking who is the patient with you. Now, two ladies have come with the name. One, this OPD slip says Lena. Now, who is Lena between two of them? I can't say. So it's always good to take patient's introduction and then even take attendant's introduction. Why should we take attendant's introduction? Why should we take attendant's introduction?
Know the relationship of the patient.
Many of the times, patients consult their attendant for any decision to be made. So they have to be respected.
Absolutely. So it's very important to know who is the person accompanying the patient. It could be just the neighbor. It could be a colleague. It could be a friend. So it's always good to know how is the attendant related to the patient. A lot of times you might share some information related to patient which the patient may not want to share with the attendant.
Confidential.
It's important to know who is what is the relationship of attendant with the patient. And then of course, small talk before the big talk. What exactly we mean by small talk before the big talk?
Like casual discussion so that the patient feels at home.
Yeah, maybe small, simple, informal talk. Even something like, did you come from very far off place? Or did you have to wait for very long? So that kind of, again, creates comfort. But what are the other benefits of doing this small talk before the big talk? Can you think of some more benefits?
Yeah, again, they feel more comfortable to discuss their problems.
Absolutely. They'll feel that, oh, you're very nice and kind person. So at the same time, you get to see the patient's ability to hear what you are saying. Are they able to listen? Are they able to comprehend? Patient's language, patient communication skills you will get to see. Do they speak the same language that you are talking? Is the patient's hearing capacities affected or not affected, especially for elderly patients? You get to immediately notice that the patient is hard of hearing, or patient has language problem, or patient has problem even explaining or expressing themselves. So you will get a lot of insight into it if you have a small talk before the big talk with the patient. And then, of course, when they are talking, it's very important to demonstrate interest and respect. That's very, very important. So that was about skill one, that is building rapport. And I think that's very important. Half the job is done when you have been able to build rapport with your patient. The second skill is attentive listening. Again, we normally think that we listen very, effectively, but actually, we all know we did that activity and we have an idea. We did not listen to the complete information. As a result, the information got corrupted and it changed every time. It went from person to person. So I wanted to do a small activity again on listening. But the same challenge we have, very few people have their camera on. The rest of the members are sticking to their stand of not having their camera on. Okay. So we'll do another activity because I don't want you to miss on your opportunity to learn. I want any one of you. Yes, Shraddha, you want to say something? Go ahead. Shraddha and Shivani, you want to say something?
No, we want to be a part of activity.
Okay, we will do. Don't worry. I will not make you suffer because of others' behavior. So we'll do another activity. So I want any one of you to agree to speak for 1 minute or any topic of your choice. Any volunteer? Any volunteer?
Yes, I can.
Okay. Dr. Shraddha has agreed. Who else had agreed?
I can.
Dr. Shishak. Dr. Shishak, you had throat problems, so I think we'll give chance to Dr. Shraddha. Is that okay? So, Dr. Shraddha, I'm going to put you in the waiting room and I'll call you back in a minute. So, I'm putting you in the waiting room. You can think of the topic that you want to speak on. Be ready with your topic. I'll call you in. Okay. So, Shraddha is in the waiting room. And when she comes in, definitely she'll try to share whatever she has on her mind, but we don't have to listen to her. We have to show that we are not interested in listening. So what all can we do to show that we are not interested?
Best is attend a phone call.
Hitting your phone.
Not seeing.
Yeah. Or interrupt her or ask something that is like confusing.
Keep our cameras off.
Yeah.
So attentiveness.
Yes. So make sure that all of you are able to disturb her and not let her complete. Okay, I'm taking her in. Okay, Shraddha. So are you ready with your presentation? Whatever you want to say?
Yes, ma'am.
Okay, so you have 1 minute time and I request you to start.
Hello everyone, myself Dr. Shraddha Mutta. I am clinical head of a Mahavir Multi-Speciality Hospital. It has
I
been...
didn't hear you. Can you come again?
I'm not able to hear you.
We couldn't hear your name. I couldn't hear.
Yes. Come in the evening, please.
Should I start it again?
I'll come for the movie. Maybe
Again,
sometime
please.
later.
So, hello everyone. May I get your attention, please?
We are busy, ma'am.
Yeah, okay. But it is
Yes,
just.
what were you telling, Dr. Shraddha?
Am I audible to everyone?
Can you not speak a little more louder?
What's up?
I guess I am much audible.
Barely.
It seems that you are busy. So, may I know the appropriate time when I can talk with you all together?
You can do it now. Proceed, please. But talk a little more louder.
Okay. Hello everyone. I am Dr. Shraddha Mutha. I am clinical head of Mahavir Multi-Speciality Hospital. I'm glad that we are meeting.
Where is this multi-specialty hospital?
Where is this hospital?
It is in Aurangabad, that is recently renamed as Chhatrapati Sambhaji Nagar in Maharashtra.
How far is it from your house?
Is this question really relatable for this? I just wanted
I'd like to
to.
know. I'd like to know because I know how much time you're taking to travel. I'd like to know that. Sort of concern.
So, thanks for your concern, sir. We will talk it in personal. Will you please allow me to communicate with everyone so that I can brief what my hospital is about? And I will be glad if you will be part of my just hear the journey how we have come with.
So
Is
you're
it okay,
keeping
sir?
your journey from your house to the hospital is a secret. Okay, proceed.
Oh, Shraddha. I'm sorry to have put you in that position.
No, it's absolutely okay.
Sorry, this is done purposely.
Really sorry. But actually, I wanted to give you all a taste of what it happens when the patient is saying something and we interrupt them and we stop them and we start asking closed-ended questions. And as a result, the patient gets confused. What do I say? Oh my goodness, I had to tell about this or I had to ask about this. But then the way we start asking closed-ended question quickly, they forget about what they had to talk about. So I gave all of you a taste of what you give to your patients in case that's the behavior that you give. Attentive listening is a very, very important skill. The thumb rule is 20% talking and 80% listening. Whereas we do the other way around. We believe it's all about we talking and patient listening. As a result, the patient satisfaction is very, very low. So it is not only important to demonstrate that it is not only important to listen, but it is equally important to demonstrate that I am listening to you. So there's no greater agony than bearing an untold story inside you. Lot of patients go back very unhappy because they have not been heard. They have not been given chance to, talk about their problem. So it's not only important to listen, but it is very important to demonstrate that I'm listening to you. First and foremost thing is face the person. Especially now we have computers and iPads and all sorts of, gadgets in the room. So a lot of time we spend simultaneously entering the information. We are not even facing the person, which is very uncomfortable for the patient. Make adequate eye contact even if you have to use your laptop simultaneously. Smile if appropriate. Nod, that's very important. See, when you have an expressionless face and you're not even nodding, it can confuse anybody. Are you listening? Are you agreeing? Are you understanding? So it's very important to show that yes, I am listening and I'm understanding your point of view. And then lean forward to communicate interest. That shows that you are listening and understanding what they're saying. When they are talking, please avoid doing multitasking. A lot of time we are actually entering their information. Unless it is very important, you can put on hold or you can inform them at least that whatever you're saying, I am entering simultaneously. But in between, whenever they talk something important, you will have to leave everything and listen to them. Avoid interrupting, let them complete. If there is something that you want to ask, in detail about, you can note down that important point and ask that question to clarify. But do not interrupt in between. Lot of time when you interrupt, they forget about what they want to talk about. So it's very important to showcase that you are listening very, attentively. So that was skill number 2. The third skill that I want to recommend to all of you is your attitude. It's very important to demonstrate positive and helpful attitude. If we don't practice it, the patients and their family members can make out that we are not helpful. And also, there's a saying, Jaisa Raja Vaisi Praja. So if your behavior with your patient is not very helpful and positive, trust me, even your staff will start emulating this same behavior. So make sure that you demonstrate positive behavior. And this I want to share with this story actually. It's how you look at your work, how value your work, that makes a lot of difference. So there was a building being made, and there were construction workers who were doing the construction work. So one of them, somebody who was passing by that side, he went to one of the construction worker and he asked, "What are you doing?" In a very regular tone, he said that this is my livelihood and I'm earning my livelihood. I'll get money and I'll be able to look after my children, which is perfectly all right. So a lot of us work for money, which is fine. There's nothing wrong in that because we require money to sustain ourselves. But if we are working only for money, that's not a very welcome idea because healthcare is about human being, emotions, life, and he goes to the second one and whom he asks the same question to him, "What are you doing?" So that person was slightly irritated and upset, and in a very rude tone, he says, "Are you blind? Can't you see I'm working?" So lot of us work as though the work is burden to us. So as a result, we are not very happy to do whatever we are doing. And that comes out in our behavior, in our body language, in our tone of voice, even in our attitude. So if that's how we are working in healthcare, then probably we are not in the right field of work because healthcare is all about sickness. People are in need of help, people are unwell, people are suffering. So they come to us with the hope that we will relieve them of suffering. But if we find that as a burden, so it will definitely come out in our behavior, and that's not desirable. He goes to the third person and he asks the same question, "What are you doing?" And this person takes him to the side of the building, and there's a huge notice board, and over the notice board, there's a very huge map of the building that is coming up. In a very proud tone, he says that there's a very beautiful temple coming up here, and I am constructing that. Imagine same work, 3 people doing with 3 different set of intentions. And trust me, the outcome is also different. When you work with the idea that I'm here for work, then you will definitely get money, but nothing more, nothing less. If you think your work is burden, you are going to create negative energy for yourself, for others, and neither you are going to be at peace and happiness, and nor you will be able to make others happy. But when you view your work as something very, very important, very vital, then your the whole approach becomes very different. Then you know that if you are able to save one life, you could really relieve somebody of pain or suffering. So you can definitely see the impact it will have on others and on us. So we see a lot of people who would have this attitude that it's a very important task. And this is not just for the doctors. I'm not saying this is only for doctors. Wherever we are, whether we are a nurse or a front desk staff or a quality people or dietetics, even support staff, if I know my job is very important for the patient's well-being and I value my work, I will do my work with great enthusiasm and responsibility. So that attitude is very important because a lot of time, we have a solution. If we work little bit extra, we have a solution, but are we willing to put in that effort? That is what going to decide are we ready to go an extra mile to help them? So a lot of time the solution is not readily available. But if you plan and decide to help this person, you can find a solution. So I want you to draw these 9 dots in your notebook. Draw these 9 dots in your notebook. And then I will tell you what to do with these 9 dots.
I know this. We have to start from below the 9 dots to connect all the 9
If
dots.
you have done it, Dr. Shishak, then you have to stay quiet. Sorry. Because I want everybody to work towards it. Huh? If you know it, then don't even, you can do it, but don't show it. I request you to. Yeah. So you have to connect all these 9 dots with with 4 straight lines without lifting your pen. I repeat the instructions. Connect all 9 dots with 4 straight lines without lifting your pen. Could anybody do it? Other than Dr. Shirchak, because he knows he has done it earlier. Dr. Girish, could you do?
I could have done this, going beyond it and back.
Then that means you have done it earlier, so you don't have to show you now. What about others? Dr. Archana, Dr. Tushar, Dr. Shraddha, Rema? Could you do? Let's see. Bring it closer. Bring it little more closer, Dr. Emma.
Yes, ma'am.
These are 5 lines.
Means,
I need 4 lines.
Yeah, I didn't realize, ma'am.
4 lines. You have to connect all 9 dots with 4 straight lines. Okay. You can see this. So the idea is to go out of the box if you want to help somebody. You'll have to be a little more creative. So according to a study by Harvard, every problem has minimum 4 solutions. And every solution should be tried at least 4 times before you give up. So there are 16 opportunities to resolve a problem. There's another way out. This is also one of the options. And you could actually connect all 9 dots with just 3 lines also. So this is finding the solution. When you have helpful and positive attitude, you are more likely to find a solution by working towards the problem. And that's very important. Nothing comes straight in black and white color. You have to really work on the problem and find solution. So that is skill 3, positive and helpful attitude. Skill 4, empathy, a very important skill. So empathy is when you are, it's not that you attach yourself with the patient, but you try to feel in tune with the person. What is the person going through? And the benefit is, how can I relieve this person's suffering? So people working in healthcare are blessed. They can actually reduce the suffering of the person. So empathy is not just about emotional response, but it is a cognitive response to the situation where immediately you start thinking, how can I relieve this person? How can I help this person? How can I reduce this suffering? So that's empathy in real sense. So we all experience, 4 kind of emotions in day-to-day life. For example, a patient comes in, I'm in emergency department, I'm doing something important. I can see the patient sitting in front of me, but I don't pay attention for good 3 to 5 minutes. Now the patient and the family is getting restless. I can see it, but I don't care. And I'm still continuing my work. That is apathy. That is apathy. That is instant sensitivity. That means I'm not realizing that the patient has come to an emergency department looking for immediate help, prompt attention. But I'm taking my, sweet time to attend to the person. The patient's attendant comes to me in a very rude and aggressive way. He says, "Ma'am, what is this? I'm here till for the last half an hour and nobody's attending to us. What is the point of coming to the emergency department?" Now, this person has, insulted me in front of so many people in the emergency department, and I'm very annoyed with this person. In the heart of my heart, I say, I'll make you wait for another half an hour. This is antipathy against the right emotional response. A mother comes with the child is unwell, the mother is crying. Seeing her cry, even I start crying. That is sympathy. So all these 3 emotional responses are inappropriate, unwanted, not required, unhelpful. The correct emotional response is empathy. When you are able to see their situation, see their world, you don't judge them for their behavior, but you understand their feelings and then you communicate, keeping that understanding in mind. And your behavior does not change. You don't become aggressive or unhappy with them, but rather you know that at such a moment anybody can become like this. So you are more receptive or accepting their. So that is empathy in real sense. And I think in healthcare, that's one thing that we really, really need to integrate in our approach. So what are the barriers to practicing empathy? What are the barriers? You can write in the chat box or you can unmute and speak.
Barriers to
practicing empathy.
Empathy.
Yeah. Empathy. Why don't people in healthcare demonstrate empathy?
Might be patient will take misadvantage of that.
So we normally think that if I'm soft with the patient will. There is a possibility, yes, a couple of patients try to take advantage, but then most of the patients are always thankful to you if you are empathetic to them. Dr. Tanushree writes, doctors want to finish their OPD and leave in OPD setting. See, in empathy, you don't take the emotions with you. You don't take the attachments with you. You just finish your work there and very mindfully you leave it there and then you move on. But when you are working with the patients, there you are more understanding and more compassionate towards your patient. Dr. Shivani has written workload and patient load in medical field. I agree and disagree at the same time. I've seen a lot of doctors working in government setup who are very kind, compassionate with the patient in spite of the workload. But I have seen a lot of private practitioners who don't have much of workload, but they are very aggressive and rude and not very empathetic to the patient. So it's again a kind of mindset that we all have. Casual approach as the routine, yes, I agree with you because people have tendency to, become with monotonous work, we sometimes tend to lose that sensitivity to the patient's condition and we become more casual in our approach. I agree with you. So I agree that's skill 4. And skill 5 is assertive communication. What is assertive communication? What do we exactly mean by assertive communication? I can see some answers in the chat box. Positive communication, okay, that's also fine. Positive conversation, okay. What else? Showing confident personality. Okay, that's one another part. Absolutely. What else? Logical approach. Okay, that's also fine. Giving hope of further treatment. Okay. What else? Able to defend our views without hurting. Okay, that means you are able to express yourself without being without hurting others. Absolutely fine. See, in public dealing, a lot of time there will be situations where there will be kind of disagreement between you and the other party. Very often this will happen. You are asking the patient to, come for follow-up. The patient is not in regular follow-up. You want the patient to get admitted. The patient is not wanting to get admitted. You want to recommend surgery. The patient is not willing for surgery. So there will be a lot of such situation. You ask for blood donation. The family refuses to arrange blood. And there will be kind of, so we all handle these situations different. And assertive communication is when you are able to express yourself in an open, honest, positive, confident, and respectful way. Do you want to know what is your communication style? I'm going to give you a questionnaire I'll put in the WhatsApp also, and I will put here also for your, give me 1 minute to bring the questionnaire. Okay, so I'm going to send in the chat box. Please check if it is working.
Yes, ma'am, it is.
So I have even sent on the WhatsApp in case if somebody wants. Yeah. So in the questionnaire, after every 5 questions, you have to total the scores and note the scores with you in your notebook. Don't forget to note down the scores with you before you submit the form. So there are total 4 sections. Every section has 5 questions. After every 5 questions, you have to write the total of those 5 scores in the form. At the same time, you note down that scores with you in your notebook. Is the task clear? And are you able to see the questionnaire?
I have to deal with someone authoritative.
So, Dr. Girish, are you doing it?
Yes, I'm doing it.
You have done?
I think the first thing is over.
Okay. If anybody has challenge with understanding any statement, you can ask me once again. You can clarify.
Include it. 16.
Audio. Once you are done, write done in the chat box so that I know how many of you have finished.
Done, ma'am.
I've received only one response till now. I've received 4 responses. So Soumya, do you want me to send the message once again to you? Do you want me to share the link once again? Okay, I've shared. Seven responses received. So how many of you are still doing? Please raise your hand so that I don't wait unnecessarily. If you are still working, then raise your hand that you're still working on it. Otherwise, we'll start with the discussion. Okay. So see, we all handle these kind of situations in public dealing. That's very, very common. These kind of situations are very common. And we all handle these situations in four primary different ways. Some of us become just quiet. We just do not take any stand. We do not voice our opinion. We just accept what others are saying. And that style of communication is called passive communication. So you can write in front of your first score. You have copied 4 scores. All of you have copied 4 scores. In front of your first score. Yes, Dr. Shishak, you want to say something?
Yes. No.
Okay. Okay. So in front of your first scores, you can write passive communication. So as explained, passive communication is when you don't voice your opinion, you don't say anything, you don't confront, you don't share your thoughts. That means you passively accept it. The second way is we don't speak in the situation. We don't speak when when there's a time to express yourself, but we go back and talk later. That means we don't share our thoughts when we are in a situation, but we talk about it later, but with a negative thought process. And that is called passive aggressive communication style. So your second score is passive aggressive communication style score. The third is aggressive communication, where we become aggressive. It could be change of tone of voice or wrong selection of words or facial expressions and body language completely changes. We may raise our voice, sound aggressive. That is aggressive communication style. The fourth is assertive communication, where we express ourselves in a very open and honest manner. And then we also listen to the other person. Now let's take an example that the patient party wants to go Lama. They want to go Lama. Some of us might not even object to it, will not try to explain, will not try to have any dialogue with the patient party. And if they want to go Lama, we say, okay, you have to sign a document and then you can go. That's more like a passive communication, that you are not making any effort to kind of explain to them the risk in going Lama and what exactly do they want to do after going Lama, where are they going to take, nothing. So you just accept them, okay, sign the document and go. That is passive communication. Passive aggressive is when you don't try to talk to them or ask them why they want to go Lama and where they want to go Lama after Lama, but you just get the papers sign, and then at the back you talk, oh, they are acting very smart, as though they will get some extra care anywhere else. They can never be happy anywhere. Look at the way they talk to everyone. So what we are doing, we are talking poorly about them in their absence. That is passive aggressive. In the aggressive style, we start talking aggressively with them, and we even blame them for the outcome. You brought the patient late, you don't listen, you don't cooperate. I have been asking you to do this, you're not even arranging blood. Now you want to go lama, whatever you want to do, you do. Don't blame me for the outcome. So that is aggressive we are handling. In the assertive communication, you will sit and talk to them, ask them why do they want to go lama? What are their reasons or concerns? Or where do you want to take the patient? How do you think you think you will be able to help the patient? Or what are the risks involved in taking the patient from the hospital? So you kind of have a dialogue with them, and that is called assertive communication. So how many of you have highest score on assertive communication? Almost all. So can you write your scores in the chat box with a comma in between? Write all 4 scores with a comma in between. Okay, so very interesting finding from your scores. See, almost all of you have highest score on assertion, which is a good sign. But what happens when things don't work the way we want them to work? We are likely to go back to the second highest style of communication. So if I may take example of, okay, I take example of I want to take some interesting examples so that we learn from it. So if I take Pooja's example, so Dr. Pooja, your scores are 14, 12, 8, 18. That means you will try assertion, but if assertion does not work for you or it doesn't bring you the result you are looking for, you are likely to move on to passive behavior. You will withdraw in that situation. Let's look at another scores, and that is, okay, Shraddha. In your case, you will try, assertion, and in case that does not bring you the result, you are likely to move on to either passive or passive aggressive style. So either you will be kind of completely withdrawn, or you will be unhappy, but you will not address it. If we look at Indumati's scores, 15, 15, 17, 17. So she's likely to use these styles alternatively. So as a result, depending upon the situation, if she's dealing with somebody in authority, then probably she might choose to be, passive or passive aggressive. Or when she is dealing with somebody in lower in hierarchy, there's a possibility that she might choose aggressive behavior. If we look at, okay, Dr. Shishak, in your scores, the assertion is 20, which is good. At the same time, if you look aggressive, and passive, they're also almost in the same range. So that's an indication that there's a possibility that you change your communication depending upon the person with whom you are interacting.
Yes, yes, ma'am, I do that.
But whereas in practice, if you will start using assertion in all these situations, slowly you will see it will bring more positive results with people. So it's helpful to use assertion. It's a learned skill. It takes longer to stick to that, but once you are able to practice it, it becomes your day-to-day way of handling situations, and it's a very helpful way to.
Right, right.
So these are the 5 skills. If somebody can write in the chat box and revise before we, I'll take 5 minutes break before we start with the next session. Pooja has asked me to repeat her scores. Pooja, give me 1 minute. I will repeat it for you. So Pooja, in your case, your scores are 14, 12, 8, 18. So 18 means you are practicing assertion. At the same time, if assertion does not bring you the result you want, you are likely to move on to passive communication style. That means you will withdraw. You will just avoid confrontation. Okay. Dr. Rima has written one of the skills, building rapport. Then, which other skills have we talked about? 5 skills that I hope you will be able to showcase. Listening, yes, effective listening, attentive listening. Wonderful. What else? Empathy, very good, very important. Positive and helpful attitude. Yes, and assertive skills. Building rapport, attentive listening, positive attitude, empathy, and assertive communication. Thank you. Thank you. Wonderful. So any questions you have about this? Any questions you have about this topic? This is a very vast topic. Actually, it takes much longer to cover. So that's where we have gone almost like 15 minutes more than the time planned. So it is 12:35. Can we take 10 minutes break and come back at 12:45 and have the third session? And after that, we will break for lunch, if everybody agrees. You can say yes or no in the group. I'm okay with whatever you answer.
Yes, ma'am.
Okay, great. Thank you. So let's have 10 minutes break and at 12:45 we connect back. Thank you. Thank you so much. Questions about the second topic that we discussed?
The commonest certain of the communication workshops, majority of the doctors, what they tell is all these aspects, of empathy, listening, then, building up a rapport. In a government hospital, when you have 50, 60 patients to be seen in a matter of 1 hour or 2 hours, how do you cope up such things?
So this is a very common question I am asked, especially when I interact with doctors working in government setup. So there we know that the workload is very heavy and it's very difficult to, it's only about once you, understand the importance of these skills in your communication. They don't require any extra time, honestly, but they just require to be mindful of your conduct. If you remember that in a professional setup, you have to conduct yourself in a very responsible way. I'll give you an example. This was shared by one of the participants in the program that in the emergency department, there was a death of a patient. The diseased body was still there. The family was crying because naturally their family member had died. So they were crying. So one of the residents says, please go out and cry. Don't cry here. Tell me, I mean, how would you explain that behavior? Isn't that a lack of sensitivity? Isn't that a lack of understanding that, I mean, people won't know where to cry when somebody loses their family member. Or I've been told that when there's a, still a dead body around, the doctors and nurses, they are, laughing and they are joking and they are talking about food. बिरयानी कहाँ से मंगवानी है, वहां से मंगवाते हैं, यहाँ से मंगवाते हैं. I mean, these are all very basic things we have to integrate in our behavior. And tell me, whatever I've talked about, the 5 skills that I'm talking about, if you look at each one of them, they don't require extra time. Building rapport does not require time. Listening does not require time. If you, like somebody was asking me, what is the right way of asking question? For example, a patient comes with fever. Tell me, what all questions do you ask about fever to the patient?
How long they have the fever? When is it in the morning? What is the temperature?
Hmm.
Is it
अभी
more
कितना है?
in the evening?
हाँ. कब
With
से
without chills.
without chills and rigor है? What with what medicine it is getting relieved? Do you have any other infection in the body? So 10 questions have to ask. What if I ask just one question? You told me that you have fever. Give me, can you tell me in detail about your fever? And you get all the information. And when they are talking, you listen to them attentively, you get all the information from them. And in case whatever they have missed, you can ask them. So it's all again a practice that you will have to integrate. Don't ask closed-ended questions. Don't ask leading questions. Ask open-ended questions. You will save a lot of time and energy. Let the patient do the speaking. When they speak, they feel good that, oh, my problems were heard attentively. And you save a lot of time, and then you can think of now what more questions I have to ask. So that's how you save on time actually. Third, I talked about positive and helpful attitude. It's something that does not take time, but it's the attitude that you have towards your work. If I consider my work as burden, I am not going to be kind and nice to people. I'm not going to be helpful to people. I was taking a session for a group of doctors working in emergency medicine. I asked them, what do your patients say when they're going after they kind of get discharged? Can you believe one of them said that one sometimes the patients tell, आपके साथ भी ऐसा हो तो आपको पता लगे. Now imagine if this is what my patient is telling me, they're literally cursing me. That means my behavior is not appropriate. I need to introspect. So that's something that we have to, be mindful of. Empathy does not again require time. It is cognitive process. Am I understanding patient's point of view? Am I able to see their challenges? Am I able to address those challenges? I don't think any skill requires extra time, but yes, it requires mindfulness. It requires attention, practicing a very responsible behavior. And that is what is actually leading to a lot of violence and aggressive behavior against us because we don't practice empathy. From our facial expressions, they can make out that we are not connected with them or we don't even really care much for them. I hope I have answered your question.
Yes.
Thank you.
Common question that I have been confronted when I go and address them on professionalism and communication.
Mm-hmm.
One question, and they put a stiff resistance and they say, what is this? What are you talking? I am seeing around 60 patients in 2 hours. And do you think I can actually sit and empathize with each one of these patients? I can't even spend more than 4 minutes with the patient. These are all the, barging of questions which have been thrown at me.
The patients do talk of a lot of things that are not concerned with the patient, are not with the present situation. When you ask them what complaints do you have, so they'll start with what happened 10 years ago. How do we really stop them? A lot of us, I mean, when I ask the doctors and especially working in government setup, they will say very bluntly, we say, don't talk about what happened 10 years ago. That has nothing to do with now. Tell me what is your problem now. I'm not here to listen to your story. But empathy would say, I understand you want to talk about your problems, but right now, what is the reason of your visit? If you tell me, I'll be able to help you better. You are not disrespectful, but you have asserted that I can't spend more time with you. There are so many patients outside. So that's how we have to learn to communicate the same things in a more respectful and positive manner. That's the practice we require. So there's a question. Yeah, go ahead. Yeah.
Yes. To make a study, CAHO, that is now since the last 5 years, we had this in the curriculum in the form of a role play right in the first year, second year, third year, fourth year, final year. It has been taught. Now we must follow the path, see what are these doctors who are now getting qualified in the next 3-4 years. Are they putting it into practice? Is there any change in the communication when compared to earlier?
So I'm not sure what kind of studies are really being undertaken by NMC National Medical Council, because they are the one who have implemented ATCOM module. See, again, the trainers who are training, if they are just training it as a subject, but in their individual practices, if their behavior is not in alignment with what they are teaching, trust me, your actions speak louder than your words. What you're teaching, if you're not practicing, then don't expect your students to change overnight. Plus, the training also, training of the trainers, how far that has been done, and in real sense, how much of it they really agree with what they are teaching. A lot of time, they themselves are not convinced with what they are teaching. So naturally, they will not be able to teach with a lot of conviction. So, but I am hoping that in the years to come, slowly things will change. Also, the curriculum will get revised. Also, the methodology or pedagogy of delivery will change. I hope in the time to come, things will definitely change positively.
Thank you.
Thank you for your question. So, Dr. Shivani has asked a question: what kind of approach is expected towards patients from our skill we discussed? Shivani, can you explain your question? I'm not very clearly understanding. What kind of approach is expected towards patient from a see approach is patient centric approach. You are yeah, go ahead, ask, please explain your question.
I just wanted to ask that what kind of approach we should keep while communicating with the patient. Like we should be passive or aggressive passive or passive aggressive. What?
Only one style, assertive communication. Once you will start practicing assertive communication, not only in professional life, even in your personal life, you'll be very happy, because you're communicating very openly, honestly, and you are open to dialogue, you are open to listening to them, and then you are ready to even agree to them in case if what they are saying it makes sense to you. Not that you are rigid on it, that what I'm saying is the final word. For example, you are saying that you need surgery, but the patient says, ma'am, I have wedding in the family next week, and it's very important for me to attend the wedding. Is it okay if I can wait for the surgery? And if you think it's not a very emergent situation, and there's no risk of anything very serious risk to the patient, and you agree, yeah, it's okay, it's all right, you can come after the wedding is over, the next week in the next week, and we can operate you. So that means you are offering from your point of view, you're ready to listen to their point of view, and then you're ready to even mend your decision according to what is right. Of course, you don't compromise on the clinical goals. Your clinical goals are primary. For example, if it's a case of ectopic pregnancy, you will not say, okay, you attend the marriage and come back. It's an emergency, that patient needs to be operated now. And then you explain them that, see, this is the situation right now. You're bleeding inside. It can lead to any kind of situation, and you can even go in shock. So that's not advisable. This is an emergency. Don't postpone it. You need to be operated. So that's, but then what you're doing, you're explaining, you're talking, you're negotiating, you're having a dialogue, and that will only happen when you will consider your patient as equal to you. When you consider your patient equal to you, then you feel like having a dialogue. But if you position yourself here and if you position your patient here, you will never treat them equal. You will always assume, I know more, I know. Maybe you know the subject more, but the patient's circumstances and their situation, they know more. So we can't say like whatever I say has to be the final word. That's how. But assertion is definitely a very powerful skill. It comes with great difficulty, with lot of practice. But once it comes, then it becomes a way of your life, and even in your personal life, you're able to communicate very effectively, and it brings a lot of respect and appreciation from people when you are able to honestly express yourself. Thank you for that question, Shivani. I think that was nice. One of you have asked how to learn and improve assertive skills. Honestly, as I said, it comes with time. You have to be mindful of three things. One is your language. Your words should not go down in terms of the respect or the decorum. So make sure whomever you're talking to, whether to your children, to your employees, to the patient or their family member, always use exemplary language. That's one thing. Second is your tone of voice. Your tone of voice should be firm, but it should not be authoritative or intimidating or scaring others. If you are using loud voice, if you are shouting, it is not assertion, it is aggression. So make sure that your tone of voice is clear, but at the same time, you are not scaring others or you're not threatening others. Third is your body language. In assertion, we all should make eye contact with the person with whom we are talking, because you communicate seriousness of the issue when you make eye contact. Your eye contact also shows that you are serious about it and you are confident about what you are saying. So your facial expression should not have a expression of pleading people or feeling scared or hesitant. At the same time, facial expression neither should threaten others nor should show that you are feeling threatened. So making eye contact and expressions that are showing seriousness and your seriousness about the concern. It's always preferable to sit and talk in case if it's a long discussion. Use an open body language. Speak what you want to speak. Then let the other person speak. Listen to that person. Note down the important points. If you need to clarify, ask for more clarification. And at the same time, listen to their point of view. And if you agree with their point of view, don't hesitate agreeing that, yes, I think what you are saying is making sense to me. Let's go with what you want. That's how assertion can be brought in. And every time you have an argument with somebody or you could not act up to the mark, sit with yourself, reflect on it. You will realize where you went wrong, what could have been done or said differently. And the next time in a similar situation, you can change your way of handling that situation. It comes with practice, but I can tell you, once you will start practicing assertion, your challenges in life will go down. It will become far more easy to communicate and express yourself. The biggest satisfaction you have is you could express yourself. I think that's a very important satisfaction. You could share your mind, you could express your thoughts. That's a very important expression and very helpful. Okay, now going ahead with the discussion, the third topic of discussion is how to de-escalate situation. So I'm sure time and again we all experience situations where the other party becomes aggressive and then everybody is baffled. What do we do? How do we handle it? What if this person starts fighting with me or fighting with my staff, or maybe breaks furniture or equipment, or even start physically hitting? So I'm sure some of you must have seen these situations in your workplace or in general, and we do get to see a lot of videos also where we see the patient party becoming aggressive. So I think it will be helpful to discuss this topic from a point of view. Why do people become angry? If you write in the chat box, why do you think people become angry? Why do they start acting aggressively? Because I think nobody comes with the plan that I am going to hit 2, 3 people this time when I get admitted. But then still people lose control, people become aggressive. So what do you think is the reason why do people become aggressive? Write in the chat box. Wonderful. I am getting good responses in the chat box. When they are dissatisfied with what they are told, what we tell them. Agree. Not satisfied with treatment or prognosis, especially when the prognosis goes bad. Correct. Frustration and helplessness. Agreed. Too long. Dr. Girish, what exactly you mean by too long?
Too many tests. Arrogant talk by doctor, too many tests.
Okay. Okay.
Sorry, just that. Okay. Is neglected. Too long a waiting time.
Waiting for too long, or they feel neglected, or too many tests, especially if they have this feeling that these are not required and you are just writing. Ambiguity about this situation. Again, uncertainty is a very big stress factor. And then don't know, manage their stress and emotions. So they can't regulate their emotion, and their emotional reactions are very, they are overwhelmed with this situation. That's possible, absolutely. Bad outcomes, very right. I think that's a very common thing, especially when they were not expected something like this. And with the arrogant, the way if we are arrogant and rude with them, they can carry that grudge with us, and the moment they get a chance, they can take up that grudge. Not fulfilling their expectations of being attended early, or our ignorance towards the coming wonderful. Patients and their relatives come with the hope of complete cure, but if they are not given a true picture of their condition, lack of confidence and clarity makes them violent, especially if we don't fine tune their expectation. They will come with unrealistic expectation. But do we address it? Do we explain? Do we fine tune their expectation? That's what is going to make them realistic in their expectation. And then they are left unattended during emergency, or the treatment is too expensive, or there is no smile on the face of the doctor. That means we are handling them in a very mechanical way. Absolutely. So I was trying to, understand why do people get angry, especially in patient care. And I came across very interesting article that I want to share with all of you. That actually, this is an article by Mark Gorkin. Let me show you the. So, Mark Gorkin has explained very beautifully. He says there are 4 phases of anger, and they all start from I. Whenever one has a palpable sense of some injustice done to them, or there is some injury caused by us or generally. Third, they feel or experience invasion by others. Then there is always an intention to address the status quo. So let's understand each one of them. First, somebody's device is on unmute mode. Please mute your device. Thank you. So the first I is injustice. So whenever the patient or their attendant, they feel that they have been a victim of a injustice or unfair treatment or disloyalty, they are likely to feel bad, and there's a risk of becoming aggressive. For example, lot of studies have shown where patients have experienced abuse. So patients have experienced abuse or mistreatment at our hands. For example, this is one study I have brought for your understanding. This is a study where the staff has self-reported in institution setting like nursing home that almost 64% of the patients have experienced abuse at our hands. And then there's a psychological abuse in almost 1/3 of the patient, physical abuse in almost like 14-15% of the patient, 11% of the patients have experienced neglect, and almost 2% of the patients have also experienced sexual abuse. Female patients, patients with cognitive impairment, and patients older than 70 years are at higher risk of abuse. In another study in Uttar Pradesh, over 57% of the women reported some or the other form of mistreatment during childbirth. I think it's an underestimation. Almost every woman experiences some ill treatment at the hands of the healthcare providers during childbirth. This problem is not just in India, it's a universal problem. And in another study, where they tried to understand birth trauma in in different countries like New Zealand, US, Australia, and UK. They identified 6 types of mistreatment where the professional standards were not met, or patients were neglected, or they were left, unattended. So it's not just in India. I think across the world, that is what the situation is. The second eye, no, this is the same eye injustice we are talking about. So in another study, they found that almost 20% of the patients reported experiencing some form of unfair treatment by their healthcare provider. The second angry eye is injury. So whenever patients experience some kind of harm at our hands, they are agitated, they're very angry. It could be, that they feel disrespected, discarded, or ignored. Not only physical harm, but it could be even psychological harm to them. And there is a sense of insult and humiliation. So naturally, this can upset anybody and can precipitate aggressive reaction. The global picture says, which is according to WHO, every 1 in 10 patients experience harm when they are receiving hospital care. Half of the harm is attributed to medications. 10 out of 100 patients acquire infection from the hospital, infection that they did not come with. Approximately 12.7 adverse events happen for every 100 hospitalizations. Patient fall rate is 3 to 5 per 1,000 bed days, and more than 1/3 actually result in patient harm or injury. 5.7 to 8.4 million deaths happen due to suboptimal quality care. So if you look at the picture, almost everything is related with patient care and some harm caused by us due to our carelessness or being unattended. More than 50% of the harm is preventable. And trust me, all these things do not go unnoticed by the patient or their family member. Tell me who will ignore it if they get to know that they have been harmed by us or our team member. And especially when they are paying for the service, you can well imagine their anger or their agitation. The third angry eye is invasion. So whenever patients feel that their personal space have been disrupted or violated, they feel uncomfortable. A lot of time we stand around the patient's bed. A lot of us are discussing about the case. Some are examining the parts, some are lifting the shirt and palpating, some are just observing the parts. So all that makes the patient uncomfortable, and some people are really very uncomfortable about it, especially when their identity or integrity is being threatened or attacked. Now, for example, a patient who is an elderly member of a family, respected and well placed and a professional, and if he or she becomes a patient and comes to us in the hospital, and we treat him or her like an ordinary patient or a regular patient without caring for their identity or their social position, definitely they will feel that their personal space has been invaded and not respected. A lot of studies have shown where the patients experienced lack of privacy even during childbirth, or they felt that they were examined even without informing. They are talking about the childbirth, experience. In psychiatric consultation, also patients have reported that they felt lack of privacy and confidentiality during consultation. There are people moving around, and they are being asked very sensitive questions. So it becomes uncomfortable. How do they really share their information or ask their question or discuss their case? So it can be very embarrassing for the patient to talk about their condition. They have also reported feeling stigmatized and discriminated due to their mental health condition. So that's invasion. The last angry eye is intention. So when they are done with what we have given to them. There is an energy and determination to do something about this injustice, injuries, or invasion, and that's where they decide to challenge the status quo. So that's where they have decided now enough is enough, and I want to really express my, unhappiness or dissatisfaction with what is happening. So all these situations do not happen overnight. Usually, actually, you can identify these situations and patients who are likely to end up into aggressive reactions if you are alert and if you can sense that there is a risk of aggressive reaction coming from the patient or patient party. So can you tell me some situations where you can anticipate aggressive reaction? Write in the chat box.
Ma'am, can I just ask you the last intention, what you mentioned? What was that related? I didn't understand that.
Okay, intention is when they have decided to, act out or take a action. It could be like talking rudely to complaining against somebody or, even hitting people around them. So intention is when they have kind of decided, I want to now challenge and I want to sort it out or resolve it.
So the challenge, like the injustice or the injury, what they have received during their treatment part. So intention of that. Okay.
Intention of challenging that.
Okay. Okay.
So when somebody kind of has now decided, oh, I want to now challenge it, I want to give them back, or I want to fight back. That's our intention. Yeah. Okay. So my question to all of you is, thank you. So my question to all of you is, when do you anticipate some aggressive reaction coming from the, patient party or patient? Yes, when there is sudden death, you can, especially when everything was going okay and then suddenly patient died. Absolutely, there's a risk of violence and aggressive reaction coming from the patient party. Absolutely. What else? What else?
Unanticipated deaths.
Unanticipated death. Yeah, that's another reason where everything was going okay and suddenly the patient collapses. Absolutely. Problem with insurance, that's perfectly all right. That's a financial crisis. The patient party did not expect that they will have to pay, but the insurance has refused to, honor their claim. And the patient party is left with no option than to arrange funds. So it can be a very difficult situation for them. They can get agitated and they may start fighting and arguing with our team. Absolutely. What else? In what other situations do you anticipate some kind of aggressive reaction?
When the patient has not been counseled properly and some unexpected or not unexpected, rather new complications or treatment modalities have been given already to the patient.
I think prognostication and regular updating is very, very important. If you are not doing it, then you're taking a chance, because in case if the situation deteriorates, the patient deteriorates, or the patient develops some complication, then they will be very unhappy with you and they will blame you and then they'll fight with you, because they are assuming if we are paying for the treatment, that means everything is fit and fine. Everything.
Whenever there is delay in emergency treatment.
Yes, whenever there is a delay in treatment, they will, because any delay in the treatment, they equate to possibility of recovery going down. So there is a, this is how they equate. They don't care for the seriousness of the situation, but they do care.
Not getting attended timely, either by consultant or by staff, or even a housekeeping.
Yes, absolutely. Delay in treatment or delay in getting the service can end up into the feeling that, yes, I have not received the treatment in time, so there's a possibility of me having some problem because of this. Yeah. Consultant not coming on time. Yes, doctors not attending on time, and there's less or no chance of good outcome or prognosis. Reaction and patient not being informed prior. Yes. So you can see there are some situations where there is a possibility of some aggressive reaction. So like we have learned medical triaging, we should learn social triaging. There can be somebody's device is on unmute mode. Can I request you to mute your device? Please mute your device. Yeah. Okay. So, and if you know that there's a possibility of some extreme reaction coming in, you will be better prepared for it. So, for example, situations like whenever you have a medical condition like dementia, delirium, traumatic brain injury, and some neurological disorder, you can expect aggressive behavior from the patient side. Patients, especially when they are confused because of some cognitive impairment or those under the influence of drug, you can expect the patient to behave in an aggressive manner. Pain or discomfort can trigger extreme behavior from the patient party. Whenever there is fear or anxiety or uncertainty of outcome, and when there is an unanticipated outcome, you can expect them to be aggressive. And then frustration, like many of you mentioned, long waiting time, lack of information, or perceived neglect, you can expect them to act aggressive. And then loss of control, feeling of helplessness, it could be some diagnosis that cannot be, the condition that cannot be managed or treated. So they feel completely helpless in spite of all the money, all the facilities, they're not able to do much. So that can also lead to extreme reaction from the patient part. So let's do a small role play. All of you, please have a look at this situation. I'm giving a very simple situation that there is this patient, 75 years old. He's admitted in the ICU, and unfortunately, he soiled his clothes while using the urinal. Now, when the brother, that is the male nurse, comes to change his clothes, he's probably a little rude and rough. Patient's family members have noticed it, but at that moment, they did not intervene. But later on, they decided that this is not done. We can't accept this behavior. So they have come to you. They are insisting on apology from Anil. They want Anil to come and apologize to the patient and to them. Or otherwise, they'll call police or media. And you are in charge on duty. So who will be ready to do the role play? Dr. Girish, you will be patient or attendant?
I'll be the doctor.
Doctor, okay. Okay, so we have the doctor who is ready to handle. Somebody who is ready to be the patient's attendant. We don't need the patient. We assume the patient is in ICU. It is the attendant who has come to the doctor complaining about the misbehavior. So anybody who is willing to be the patient's attendant? Dr. Shirchak, can I request you?
Yes, ma'am, I can.
Okay. We need one more person. Anybody who's willing to be the family. So both of you could be children to Mr. Rakesh Sharma, who is 75 years old patient. Any volunteer? Anybody? See, role play is the best way to learn. If you want to really practice your skills, you have to get into the role play. So I just need one more person. Okay, wonderful. Thank you, Dr. Vani, for agreeing. So all of us will switch off our video and 3 of you will be in the common room. So Dr. Girish, you want to be going to them or you want them to be coming to your room? How do you want to do this?
Or I'm going to them or they can come, no problem.
No, whatever you decide, they will accordingly act.
The interaction is the breakout room, huh? Or here?
No, it's not a breakout room. All of us will have our videos off. Only 3 of you are going to be, in the...
The family member is coming to me.
Yeah, they are coming to you. Okay. And... yeah. So sorry?
Who is representing Mr. Anil?
Dr. Shirshak will be son of Mr. Rakesh Kumar. We don't have Anil here. It's only if you decide that you want to call him, then we will ask somebody to act as Anil.
Shirshak is the patient's attendant.
Patient attendant, Dr. Shirshak and Dr. Vani.
Okay, two people. Okay, that's fine.
Dr. Vani, can you have your camera on? Dr. Vani, are you there? So can I request you to have your camera on, because so both of you are going to be doing the role play. Even I am going to
unmute. Yes, unmute.
So is it 3 to 5 minutes are okay? 3 minutes are okay?
Yes.
Ma'am, can you just show us the content again once more, please?
I'll just explain you briefly. A patient used urinal, and as a result, he soiled his clothes. So Brother Anil, who was on duty, male nurse, he changed your patient's clothes. But while changing, he was little rough and rude with the patient, because naturally changing the clothes is not a very comfortable kind of a thing. So you were there, either you or Vani was there, and you observed that he was rough and rude with the patient. But at that moment, you did not react. But later on, you realize that this is not fair. How can they behave like this with the patient? With the elderly patient, they need to be more understanding that this can happen. So you are unhappy, and now you have gone to Dr. Girish, who is the treating doctor. And you have gone to him that either you call Anil to come and apologize, or we want to take the patient from your hospital, and also we are going to report it to media, and we'll call police also. Is it clear, Dr. Shirchak?
Yes, ma'am.
Okay. So just 1 second. I thought we'll just.
Vani has to unmute, I think. Dr. Vani has not unmuted.
Dr. Vani, you have to unmute your device.
No, can't hear.
Device. Please unmute your device. There is a red button on your device on the top. If you have joined from phone, there is a red button on top, left or right. And you have to touch that button. Not able to unmute? See, we can't unmute your device. I can just ask you to unmute, but you have to unmute.
So they are coming with a complaint. Sirsha and Vani are coming with a complaint to me. Am I right?
Okay, I'll be the second relative.
Okay, thank you. Thank you. So I will only come in if I want you to kind of stop, but then you can start with your discussion. Go ahead.
Yes.
Yeah, doctor, we have a lot of complaints about the ICU, and it was very, very disheartening to see how rude your staff is, how they misbehave with the elderly person. I'm really, really hurt, and we are going to complain, and we are going to put it in the social media as well.
I'm very sorry, Archana, that this has happened. I'm extremely sorry, and I'll definitely look into that. I'd like to see what exactly has happened. Actually, can you tell me what exactly happened?
So my father, he had urinary incontinence. He passed the urine in his clothes. And the brother who was attending to him, he was extremely rude while he was, changing his clothes, and which really made my father uncomfortable. And he doesn't want to stay in your ICU anymore.
Okay, I'll see that, but you can say now I'll just come to the ICU. I will see that the best is being done, and in fact, I really am very sorry. I'll see that.
No, I mean, how we are not in the ICU with our patients. Our patients are under your care, and if this is how your staff is going to behave with our father, we are not going to continue here. Or else you call that person over here. I want an apology from him.
Definitely, it will be done. I will definitely find out exactly what has happened, and you have told me now that you see that, or again, I will see that an action is being taken. We will conduct an inquiry, and a proper appropriate action will be taken. But I will see to that the best care now is being given. I'm just walking on against the ICU to see your father and see that the nurses in the ICU look after him very well.
I mean, how we will be assured that this doesn't happen again?
It will not happen. I can assure you I will see that. I will immediately arrange a staff meeting. I'll appraise all the staff about this. And this particular person who had misbehaved, we will inquire and see that an action, appropriate action is taken. I'll even ask him to apologize to you. What he can do.
Sir, please call Anil. We want him to come and apologize.
Yes.
I will definitely call him. I'll ask him to come and apologize to you. There's no. I feel very sorry about this.
Please call him. So let Dr. Shirchak act as Anil.
Now,
I was there when when your staff was changing the soil linen, and I have recorded
So, Dr.
everything.
Shirchak, hold on. So, Dr. Girish, will you call Anil or not?
Now, I will be talking to Anil now. Can I talk to Anil? Let Shirchak be Anil.
Assume that we have talked. We are not going to hear that, but we want you to come back to us and tell us what do you want to do. Do you want to?
Anil, actually. Shirchak, hope you understood.
So, do you want Anil to come in and apologize?
Yes. I would definitely like what you can say to Anil. Shirchak, I will explain to him. I'll explain to him that what you can say. The patient has been hurt. Patient is a patient. We have to give the utmost.
Okay, so I will act as Anil. Is that okay?
And that's fine.
I am there. Yeah, you have called me in and I am there. Yeah.
Anil, I heard there was a complaint for the patient. You know very well the feedbacks on the patient are very, very important for us. And we will see best care, personalized care has to be given. Some mistake has happened. Maybe you would have done notifications, or maybe you would have been busy and therefore you would have gone a little late, but that's fine. Let you please go and apologize to the patient and rectify the mistake immediately.
Sir, this family is very rude. Every time I go to change their clothes, they talk to me very rudely. The patient is also very aggressive, very rude, and he does not let me change his clothes comfortably. He does not cooperate. You have no idea how badly these people behave with me. And I did not misbehave. I already had handled, 2 patients before meeting him, but they were asking me to come immediately and attend to them. There was another emergency. I was attending them. But these people were not letting me finish my work and come back. And they are complaining for silly reason.
I understand, Mr. Anil. What you have said is very right, because I know you are good. You are very good at your work and you work very well. I'm sure that would have been an emergency. Otherwise, you would have gone and attended. I know you well. But patient is a patient. They have their own problem.
I will not apologize, sir. It's not my fault. I'm not going to apologize.
No, I would love what you can say and see that what you can say you do it out of what you can respect to the patient. However, the rules.
Sir, I will not apologize. I have not done anything wrong. I have not misbehaved with them. They are there. They should be apologizing me because they are the one who misbehaved with me.
Not doing it, then I will apologize what you can say on your behalf to them. But see,
sir, that's your call, but I did not misbehave. I did not misbehave.
That's fine. That is fine. But what you can say, I will definitely be conducting an inquiry. I'll be informing the medical superintendent, and what you can say, they conduct an inquiry, and after that, what you can say, an action will be taken. Fine.
Okay. Can I request everyone to come in? Thank you. Can I request everyone to come in? Now you see, I want to ask all those who are here. Will you call Anil to apologize?
No.
And suppose if it was not Anil, but it was one of your resident doctors. Will you call your resident doctors to come and apologize?
No.
See, what is the risk when you call your employees to apologize?
The situation will be escalated more, and as an in charge, I will have to take the responsibility. I'm taking the responsibility. I'm apologizing, and I will see to it doesn't happen next time. And I will definitely not get the subordinate in front here.
So what is the risk if you call the employee to come and apologize?
Unnecessarily flaring up the situation.
Plus the
employee also will feel left out. I mean,
and what can happen?
We can't lose his trust, and we cannot put him in the blame game there.
And what all can
And
happen?
it may be so that the brother actually did not do anything, or the staff did not do anything. It was over expectation or exaggerated behavior of the relative.
And if it was a physical setup, we are in a Zoom meeting, so we are not physically in the same place. If it was a physical setup and if it was a real life situation, and if the family was very agitated with my behavior, what do you think would happen?
Violent,
It
like
will become more
hatapai kind of
aggressive.
a
The
thing could have
situation will be
happened.
escalated,
They could have caught hold of my collar and slapped me.
Yes.
How dare
Absolutely.
you misbehave with my father? And then you would
Absolutely.
be confused whom side should I take, my employee side? So it's very important to remember that if you will call your employee, you are going to get into another set of problems. So how will you
Can
skill?
can I just add?
Go ahead, please.
Because in the hospital where I am now, I get a feedback from every patient. And 60, 80 to 90% of the patients give a very good feedback. But when there is a negative feedback pertaining to any one staff, I immediately ask the staff to talk to the patient in specific over the phone if the patient is already discharged. Otherwise, when they are here, I will tell them, please tell sorry. The moment they tell sorry, the patient quietens down like anything. They will never try to attack anyone. I think it is a wrong view of my colleagues who said that we will not allow the person to apologize. It is wrong. You can as well conduct an inquiry and tell them you can do it. But stubbornly telling that I will not go and say sorry. In fact, as a doctor, I would have said at least 20 times sorry. Why can't he say one sorry? What is going to happen? Please.
So, Dr. Girish, I appreciate your point of view.
Girish,
And I also, no.
That person,
Yeah.
the whole scenario will quieten down. And they themselves will tell it's fine, I didn't mean to harm.
What happens, Dr. Girish?
Yes.
A lot of time, of course, see, when we apologize, I agree with you. Half of the anger goes down. I don't disagree on that. At the same time, sometimes the staff hasn't done anything wrong, but when we ask them to go and apologize, it not only demoralizes the staff but also sends a negative message to the other team member that just to please the patient party, my doctor is going to insist on asking for apology, and he is not going to stand with us when we are saying that we haven't done anything. I understand your point of view that every staff who has, there are always gray things, everything is not black and white. Like in this case, maybe they were actually very rude and aggressive with Anil, and maybe Anil was really tired and was not able to really handle the situation. Maybe Anil was doing double duty, maybe the patient is very heavy. It could be anything. So everything is not black and white. There are sometimes gray matters, and then it becomes difficult to straight away telling them go and apologize. Then what about your team? They are
see to it that if there is a mistake, please do not go and apologize. And I can tell you 99.9% of the time, everything or it just settles down, the patients cool down. They themselves say, no, I don't want to harm anybody. You're all doing very good work. This is what the response is.
No, I agree. I'm not arguing on that, and I respect your point of view. But at the same time, there's another point of view that all others are sharing, and we can consider that. And we may also agree to disagree. Even that's also an option. So, but most of the times when you ask your team members to go and apologize, it not only demoralizes the staff, but it sends a message to the other team members that they may also be asked sometimes to apologize even for no mistake of theirs, for no fault of theirs. So there's a way. Now, my question to all others is not to Dr. Girish, but to all others. But the family is insisting on apology. And as you said, that you don't want to call Anil because you feel that it's not fair to call Anil. So, how will you handle that situation?
Multidisciplinary team meeting.
Sorry?
Maybe the ICU head, the primary consultant, the CNO, the Anil brother, and the patient's attendance. Multidisciplinarily, we will meet and then we will sort it out rather than one-to-one meeting.
Okay, that's one way. Then, but the family is insisting on apology, or we want to take the patient lama, and also we are going to put it, on social media. So you
Right.
want
In
to,
that case, the CNO and the leaders should apologize, not the staff, because staffs are under us.
but what if the family is insisting? My question is this: if the family
Yes,
still,
the CNO and the ICU
they are
head
will
will
we want
apologize and
Anil
will
to come
tell
in.
that we have taken it as a very positive feedback And we will assure that we give regular trainings to our staff so that this incidents, if at all has happened, does not ever get repeated again.
Okay, thank you. What do others say? What is your opinion? Somebody other than Dr. Shirshak and Dr. Girish, if they want to think and answer.
It doesn't have any point to expose our co-workers or our subordinate on the next party. It's always like in a blame game in that way. Better to listen to one party, assure them, send them back, then get the another party, listen to them, tell them the feedback we got and why it has happened. Then we can go into the depth of that corrective and preventive action for that point of view. Like you said, that
is required. See,
yeah,
listening to both the parties, understanding their point of view is very important. And then also, like we normally do RCA and CAPA. In every situation, we do RCA and we do CAPA. RCA is root cause analysis and CAPA is corrective action and preventive action. That if in case if you need to train your staff, resensitize them, or you need to, tell them or maybe change their posting or give them some relief, all that needs to be done, that's fine. But when the families insist on apology, can I tell them that I am ready to call Anil and apologize? But I fear.
It will be like I am heading the unit, and even if the apology is required, I will be apologizing rather than that one
So
person.
I apologize on behalf of Anil because after all, Anil is my team member. So I need to apologize on his behalf. At the same time, if you want me to call Anil, I can call Anil because if he has made a mistake, it's my duty to call him. But I just want to bring your attention to a point where I feel that if I make him to come and apologize, it will not only discourage him, but will also demoralize my other team members. And that will affect the patient care. So, my request to you is if you focus on the patient's well being, for which I am ready to apologize. I'm ready to go and meet your father and talk to him and also apologize. And I'll put some senior nurses to look after your father so that he does not feel unsafe with some of our team members. But definitely at my end, I will retrain them. We'll talk about it. We'll see what are the lacunae and why did that happen, and it should never get repeated. Is it okay if I don't call him, but then I promise that we will be taking all possible precautions to not let this happen. But I will put some good senior nurses to your father's care. Do you think something like this can calm them down?
This can calm.
Yes, I think this is a better approach.
Better approach. This is a much better approach. Yeah.
Now, I would like one of you to slip into the boots of the patient and start thinking, will you be happy if some other doctor has got nothing to do with it, apologize? Or would you like to have the person who done the mistake to apologize? You slip into the boots of the patient and then talk.
Exactly.
But sir, here we have not proven, that the person has actually done the mistake. That is also there.
And actually, apologizing person is not the doctor. He is the head.
He's representing him.
Yeah.
He's not an individual. He's representing the whole department. So I think it should be okay.
Plus, we don't know the intention of the relative when the person who has committed this or the victim, when he comes to apologize, we don't know how the reaction would be. We are assuming that they might be cool and calm and they might accept, but it could be the other way around as well.
They might act out. They might physically, hit the person. Especially if the employee is of lower rank, there's all the possibility that they can act out. So that means the situation can happen anywhere with any one of us. But are we able to identify when to mitigate, when to intervene, and how to handle it? So next discussion is about the stages of crisis development. And as I've been telling, nothing happens all of a sudden. There are always warning signs. Are we identifying those warning signs, red flags, and can we mitigate the situation? That's what is going to decide how the whole situation will be looked after. So let me take you through the presentation. And this is the case we discussed. And I think there's an understanding that yes, these situations are very common, but we have to be very thoughtful of what action we should be taking. We need to do RCA, we need to do CAPA, but at the same time we have to stand by our team. And a lot of time the problem is not very black and white. It could be a mixture of anything, and we need to be very mindful of what action we take. So talking about the stages of crisis development and how do you go about managing it, as I said earlier, crisis moments don't happen all of a sudden. There are always red flags, there are always warning signs that, that if you observe them, identify them, you can actually prevent from situations going, downside. Somebody's device is on unmute mode. Can I request you to mute your device, please? Okay. So the crisis stage 1 is called triggering stage, where the actual trigger has begun, where you can see the patient or their family member may show signs of increased tension and irritability or even frustration. So it could be because of pain, fear, unmet needs, perceived neglect, anxiety, or uncertainty. Trigger could be anything, but you can see that there is some amount of frustration, irritability, and tension in the patient or their family member. And you will see they will be actually speaking in maybe louder than the normal voice. They may be pacing up and down. They may even try to talk to different people to clarify. They may even express their doubt and they will not agree with what you are saying. They may ask you a number of questions. So that's the first stage where you can sense that there is some disagreement between them and us. So at this stage, the management strategy should be early intervention. Don't ignore these signs. They are very clear indication that if we don't handle them now, they can escalate and they can become serious in intensity. So early intervention, that is address their concerns promptly, give them a space to express. You can make them, you can call them to your room, you can talk to them, you can ask them to visit you in your room, whatever way works for you. Make them sit and talk. That's the idea. Don't ignore these symptoms. When you are meeting with them, offering them a glass of water, acknowledging their feelings, and offering reassurance will calm them down. Like Dr. Girish was telling, that if you kind of apologize, if you make them sit and talk, so they feel that yes, there is somebody who is ready to understand my point of view. Second is communicate and follow the process. So they may not know who you are. You could be a floor in charge, you could be a patient experience officer, you could be a grievance officer, you could be a quality manager, you could be a ward sister, you could be ICU in charge. So you need to, identify yourself, your role, and how you're going to help. So for example, if you say that I am, ICU in charge and I'm here to help you, I have heard that there is some problem and I want to resolve the problem. I'm here to address your problem. So let me understand what the problem is, and if I'm able to help you, I will definitely help you. If I think I'm beyond my control, then I will definitely escalate your complaint to the next level. So what you're doing, you're explaining the process and procedure in simple terms, and then ask them to share their concern. So one of the good ways is ask them to repeat what exactly happened. So when you ask them, can you tell me who was there with the patient, and can you narrate the incident to me? So a lot of time when you hear from them, you get to know more clear picture from what they have experienced. Also, what are the hidden feelings? So 75 years old man, retired professor, very educated, well placed in society. So naturally, family is not very happy with the way he has been treated. So there could be some hidden reasons for them being unhappy about it. And when you listen to them, when you attentively understand their concern, actually half the suffering diffuses and they feel being heard. So, like I said, it's very important to listen to the real message. As I said, he is 75 years old, retired professor, educated person, well placed in society. So, naturally, there are some feelings behind that fact. You can ask questions to clarify and also use silence and restatement to reach to the exact message. At this point, very important is to not only stay calm, but also mind your demeanor. What happens? We don't speak, but our expressions somehow tell them that I'm not agreeing with you or I'm not understanding your point of view. You're making a big issue of small thing. So your body language has to be very, well guarded. Don't try to interrupt them. Don't try to correct them. Don't try to be in hurry to justify yourself or your team. See, that staff is very old, very senior. He's been working since morning. He was supposed to be relieved by 6 o'clock, but the next staff did not come. So he's doing double duty. All these excuses will not work with the patient and their family member. And don't try to shun away their concern, because to you it might seem very trivial, but for them it's a very big issue. So be empathetic, understand things from their point of view. Don't judge or discount their feelings, whether or not you think their feelings are justified, but these feelings are real for them. And therefore, it is important to acknowledge them and don't question. Next is express empathy. Empathy, where you try to kind of, recognize, I can understand it must be very disturbing for you. I think this is something you don't expect. I completely understand your point. What you're doing, you are recognizing their feeling. Yeah, I can see you're very upset about what exactly happened. Anyone in your place would have, reacted in the similar manner. And that kind of again validates their feelings, and they feel that yes, we are being understood, not only heard, but also understood. Next is apology. I don't know how many of you really apologize, but apology actually works, to calm the person. And especially apology, even for the inconvenience. For example, they have come for MRI, the machine has gone out of order all of a sudden. So this is not something that you have done or your staff has done, but their day has gone wasted, or they were waiting for 3 hours, and when it was about to be their turn, the machine went out of order. So that apology actually makes them, calm down, thinking that, okay, somebody understands the inconvenience I have experienced. Actually, the word I'm sorry has two interpretation or two expressions. One is an expression of compassion, where you want to apologize for the inconvenience. Whereas the other one is where you feel that, yes, we have gone wrong and there's a mistake from our side, and we apologize for the same. So a lot of time when we apologize, but we don't apologize in real sense, it can go wrong. For example, when you say, if what you are saying is true, then I think I must apologize. So that means I don't trust you. There was a mistake, but it wasn't a very big thing. Again, you are making their issue trivial. I'm sorry, we cannot attend to individual requests. That means I will not help you. This sorry is just for the sake of sorry. I'm sorry, but we don't allow visitors during non-visiting hours. So that means I'm not ready to understand their point of view, and I'm just apologizing for the sake of it. And sometimes these things happen, but they are not done deliberately. So according to you, it could be an apology, but they don't see it as an apology. Next is provide information. So a lot of time the agitation or aggression is about incomplete communication or improper communication or communication gap. So it's very important to, clearly communicate to them what is happening or what will happen and address their concerns. So for example, in this case, like when you say that we have got to know about this problem and we are definitely going to work on it. We don't, thank you so much for you bringing up this to us. We'll definitely not only look into it, but we will also take corrective actions by retraining the staff and resensitizing them. So what you are trying to say that this is what is the action plan that we are going to take. And then explore alternatives, that is check what does the patient want. A lot of time it is when you ask them, what exactly do you want me to do? So for example, in this, if they said, we want Anil to come and apologize. So that means clearly they have said that this is what is our expectation. Sincerely try to resolve the issue and address their concern. So if I say, okay, I will look into it, I will talk to my staff, I will interact with them and find out. So I'm trying to postpone or procrastinate. Whereas if I want to resolve the issue, I need to be prepared and know the staff's point of view or staff's version of the story. So when you're looking for a solution, please focus on the solution rather than the patient behavior, because a lot of time their behavior is very inappropriate. So in that situation, avoid being defensive, but try to resolve the issue. So explore alternatives with an open mind, because a lot of time there can be very serious consequences of not addressing the problem. So this is one step. We are just one step where we can the situation can go, it can escalate, or you are able to mitigate the situation. So we are very close to either closing the case or actually escalating it. And if we are not able to find an alternative that works for the family, we are in second stage, and that is called escalation stage. That is where they are unhappy with the discussion they are holding with us. So you will see that there will be increased emotionality, and there will be signs of anger, shouting, or threatening language. You will see them acting, even sometimes, aggressive body language that you can observe, and the person may begin challenging you or your authority, or the authority you represent, and they can become belligerent. That's because their emotional mind has now overtaken their rational mind. So naturally, all their reactions are more like, out of anger and unhappiness. So again, you will see that their voice might go louder. They may start arguing with other people now, with security staff, technicians, nursing staff. There will be an expression of dissatisfaction, doubt, disagreement. They may refuse to cooperate. They may refuse to pay. Again, this is a serious situation, because if we are not able to handle here properly, the patient can become very aggressive. So the management strategy here is very important, is please maintain your composure. Usually when the patient starts misbehaving, even we lose our composure and we become aggressive. That's where we have to very mindfully stay calm and use a low and steady voice, firm but not disrespectful or aggressive. So avoid arguing or challenging the patient, because the more argument you will indulge into, more likely you are going to escalate the problem. And avoid using confrontational language or making threats, because this can escalate this situation. At this stage, you can provide them guidance, for example, asking them to calm down and express properly. See, I want to help you, but you need to calm down and we need to discuss it. Let's sit down. You tell me your concern. If this is not working for me, tell me what exactly do you want. So what you are giving them, you're telling them that they need to behave in a manner so that you can have a dialogue. So you are kind of setting boundaries where you are communicating that the aggressive behavior is not acceptable and that's not going to really help. You could even, give them directions. For example, see, if you're not satisfied with the solution I'm providing, we have floor managers. You can talk to them. We have patient experience officer. You can take their assistance. You can write your complaint in case if you're not happy. You can give us feedback, because when you give complaint and feedback, the whole team works on it and we make sure that the problem is resolved. And then you could also speak to, like, we have grievance officer or we have patient relation officer. So what you are telling them that in case if you are not satisfied with me, this is not the end. You can escalate your case rather than arguing or fighting. Again, at this stage, assertion will play a very big role. Communicate in a very open and honest manner, but at the same time, you have to be positive and confident. So clearly spell out what you can do and what they should do. Be firm, but not aggressive, because the moment you will become aggressive, they are likely to, become more aggressive. If you think that the situation is not really, manageable, and there is, increased emotionality and anger, so you need to discreetly alert your colleagues or security personnel for backup. Make sure that they are not in the visual field of the patient, because if they are visible to them, then they are likely to, get agitated by seeing that there are security people around me and you have called security to control me. But of course, you need to have them on your side, and as a standby. So, a couple of points that you need to keep in mind when you are handling this situation. One is, be aware of your body position. So please do not stand eye to eye and toe to toe with the person. This may not be you; it could be your security staff. So again, this is going to send a challenging message to them. And in case if you go very close to them, you are invading their personal space. As a result, it can lead to increased anxiety, and they may actually act out thinking that you are going to hit or one of your team member is going to hit. So having a 3 feet distance is a good idea. I think in counseling room, having a table between you and the patient party is again a good way to maintain distance. And Follow two-door policy. For all counseling rooms, I advise that you should have a two-door policy. The reason is usually the exit gate is behind the patient party. And if you are trying to exit for your safety or for any reason, the patient party might think that you are running away from the situation, and they may catch hold of you and start hitting physically. So if you have a back, if you have a gate behind you, if you have a door behind you, you can excuse yourself giving some good reason. So you can ensure your safety, because you never know at this stage the patient might act in any way. So two-door policy for your counseling rooms is a good idea. At this stage, please do not argue, because that's not going to help you. They are not listening. They are just acting out. They're just, shouting or speaking. So avoid answering all questions. Even challenging questions should be avoided, because they're just doing it to provoke you and to make you act out. Don't get into, tug of war kind of a situation. Shift their focus to the problem or the patient's welfare. So if you redirect their attention to the patient's welfare, they are likely to understand that they need to focus on the patient's welfare. A lot of time they want to talk about something. It's okay to let them vent, especially if it is happening in the counseling room and there are not very many people around you. So because when they are able to vent, they are also able to get rid of the negative energy they were holding. And if you think that that's not appropriate, especially depending upon the situation, for example, if it is happening in the OT or labor room or ICU, then of course you have to, kind of give them direction and tell them that this is not the place you can act like this. Then set and enforce reasonable limits. So you will have to tell them when to, like, the person is really becoming belligerent or defensive or aggressive. So there you will have to clearly tell that this is acceptable or not acceptable. But don't give any consequences that you cannot do. For example, if you say, if you don't behave well, I'm going to discharge your patient, you can take your patient. So please don't give that kind of threats. They are not a good idea to threaten them. Your facial expression, body language plays a very big role in this situation. If your non-verbals are aggressive or even, scared, you are communicating a different message. They are actually not listening to you, but they are looking at your body language and facial expression. So it's very important to keep your non-verbals, neutral, and be aware of your gestures and facial expression, because your tone of voice, your movement, your facial expression, all that the patient or party is observing, and they are going to react to that. So some expressions can really aggravate the situation. For example, when you say, I don't care, I can't do anything, or what can I do? This is not my job. So when you do something like this, say something like this, that's going to aggravate the situation. So in such situations, only one person that you have control is on yourself. Avoid overreacting. I know it comes with a lot of practice, but you have to learn to remain calm, rational, and professional in such situation, because your response is going to directly affect the person's behavior. So using assertion in all situations will help you. Certain behaviors that you should avoid, like shouting back, banging the door, throwing patient's file, calling security even without, provocation, is a big no, and one should avoid that. All through, please keep a check on how you're feeling in this situation. So be mindful of your feelings. Don't ignore your feelings. And if you think that you are not able to manage, let someone else handle you or support you. Because a lot of time when we are overwhelmed in this situation, we might overreact and may do something which might regret tomorrow. So it's better to take help of somebody who can help you control the situation. If nothing changes, then we are in crisis stage 3, and that is called acting out. That's where the person may actually lose complete control, and they may exhibit aggressive or violent behavior. They may start throwing things, they may start damaging furniture and other items. They may even start hitting people. And they are usually not able to reasoning at this point. So as I said, it's not going to help much to have a dialogue with them. So in this stage, your management strategy has to be ensure safety. So make sure that you and those around you are safe. If possible, you can remove your patients and staff from that area. It's better so that they don't get hurt. And also, call for help. As I said, engage security discreetly, let them be in the accessible area. Activate your emergency procedure, whatever buttons you have to push those buttons. Usually it is code violate that you need to initiate so that everybody gets to know that there is a crisis. So in this situation, I think the best way is to minimize interaction, avoid any direct confrontation and verbal exchange, because that's not going to help. They're already not in mood to hear. Nothing is going to help in that way. But once they are, everything is over, they have done whatever they have wanted to do. They are in now stage 4, and that is tension reduction. So when the emotions calm down, you will see that they are regaining their control. They may even regret their actions. They want to make amends, and they want to apologize or compromise or whatever has happened. So all that, although it's easy said than done, but let me tell you, this opens an opportunity for the positive change, reconnection, and resolving the issue. So at this stage, if you can keep yourself calm and be ready to make changes, offer reassurance, but avoid discussing the incident until the person is fully settled, because they are not in that state of mind. And reassess needs and address any remaining concerns, especially for the patient. It's very important. Once the whole thing is over, make sure that you document. I'm sure all organizations have incident reporting format, but basic, documentation should be done all about name of the aggressive patient party and the hospital staff who attended this situation. What was the background situation? How you responded and steps you took to mitigate the situation? What was the outcome? What did both parties agree? What aggravated the situation? And any suggestions regarding solution and situation, especially how to prevent these things from happening in future, CAPA, and then how you can be reached out for questions on this. So that's very important to document this, because that's going to help us know what exactly. Post-crisis stage, it's very important to sit and reflect and see how you were feeling in this situation and how you're feeling now. You can discuss with your colleagues and learn from them about how this situation could have been managed differently. Read material to update, and then, of course, attend programs to learn crisis management. More you will practice, more you will learn how to go about handling such situations. So the carry home message is there are always, warning signs. Contain the situation as early as possible to prevent it from becoming a big issue. Thank you. Okay. Any questions? I know it was a long session, so we had to discuss a lot of things around it. So I think I'll not hold you from your lunch. It is 2:07. We connect at 5 minutes to 3. If that's okay with everyone. Let's meet at 5 minutes to 3. Thank you.
Yes, thank you.
Thank you.
Question about the last topic that we covered about de-escalating situation, managing aggressive patient party. Okay, so going further from here, the next topic of discussion is breaking bad news. So what kind of bad news do you get to announce to the patient or patient party? If you can write in the chat box. What kind of news do you get to Death. Yeah, very common is death. Bad prognosis. Yes, that's also a bad news. So any previous disease. Yes, that's another important thing. Cardiac arrest. Yes, that's a serious issue. Cancer as a diagnosis. Absolutely. Another very serious concern. HIV. Yes, if somebody is HIV positive. एक बारी fan on कर दीजिए नहीं नहीं I just need the fan on. I don't want AC. Thank you. Thank you, bas. I just need fan. That's all. Yeah. Somebody is seropositive. That's again to be when you announce something like this, it's difficult. It requires a lot of. Okay. How many of you have had any formal training in breaking bad news? Write yes if you had any formal training, and write no if you haven't had any formal training. No.
Robert Buckman's spikes protocol.
Uh-huh. So that you have read, or maybe you have been trained. You have an idea about it.
I didn't have any formal training during MBBS or but subsequently I came in, and I've been using this very often for the past maybe 5 or 8 years.
Yeah, mostly people are using that spikes model to break bad news. Yeah, that's true. Yeah. So I can see most of you have written that no, you have not had any formal training. And see, that's the challenge. If we don't know how to go about doing it, and if you have to do it, how difficult it becomes for anyone to, break the bad news. And like you have mentioned, bad news is something very serious or very, something that has grievous this thing. But honestly, for a patient, bad news could be, if I share my experience, for example, maybe I'm talking about 20 years ago, maybe more than that, maybe 25 years ago, suddenly, I had breathing difficulty. And, especially in my lower lobes, I had a lot of pain while breathing. So my husband took me to one of his friend who is a physician, and he examined and he said, let's get the x-ray done and let's see what it looks like. We did the x-ray and there was some shadow in the lower lobe. And he said, it could be tuberculosis, but let's start with the simple antibiotic and see if it responds to it. Otherwise, we will have to investigate for tuberculosis. And then he gave me a set of antibiotics for 3 to 5 days, which I took. Trust me, those 3 or 5 days for me were like hell. Everything, came down, crumbling, because my both daughters were very, very young at that time. And the second one was almost like not even 5 years. I had so many concerns. Who will look after them? Who will attend them? Can they sleep with me? Can I hug them? Can we share our meals? See, in spite of the fact that we know it's curable and everything is fine, there's nothing much to be. But these were the 110 concerns I had on my mind. Fortunately, like when we did the X-ray after 4 or 5 days, everything was fine and symptoms also subsided and I was fine. So my idea of sharing my experience with all of you is it's not always about death or complication. I have seen mothers crying when they get to know that their child has amblyopia in one of the eyes. My husband is an ophthalmologist, so in my clinic we do get to see such patients. And they are so disturbed. Mothers literally start crying. That's a bad news for them because they feel, oh my goodness, my child will have to really, maybe either wear specs or maybe in one eye we will not be able to improve vision. So one clarity we need to have, knowing that I have diabetes, I have hypertension. I mean, when we give these diagnoses to people like sweets, but when it comes to us and we get to know that I have this condition, it can be very, life changing for all of us. So bad news is not just about death and complication. Any diagnosis that we give to people can be a bad news for them. And a lot of time we have seen, people get upset when they are not given the news in a very appropriate manner. And like you have mentioned that there hasn't been any formal training. So if you were lucky to have a senior who would do this complete exercise with great patience and compassion, You will imbibe the same way of doing it, but what if you didn't have any good senior who could really teach you the right way of doing it? So I think today's discussion is all about how do you go about doing it. There's so many protocols available, like Dr. Girish is talking about Spikes model. There are many models. There are many models. Idea is I need to learn some basic steps. What I need to do before I break, what I need to do when I'm breaking the news, and what I need to do after I have shared the news with them. So this topic and even the disclosure of medical error, they are quite similar in one way, because even disclosure of medical error is a bad news for the patient and the family. So when you tell them that something has gone wrong, so naturally for them it's a bad news, because they didn't come with to the hospital with the idea that they will also develop some condition just because of some mismanagement at our end. So in both these situations, you will see the patient might react in a similar manner. So we'll take the discussion from one topic to another accordingly, but both are basically bad news for the patient. So let me share the presentation with you and then have the discussion, continue the discussion about it. So very clearly, I think bad news is anything that has serious or adverse. It's a serious or an adverse event. It has impact on the individual's life and future. For example, infertility. Somebody who is doing this on regular basis, for them it may not be something very challenging, but when you talk about it to the patient and their family, they are really shocked when they get to hear about this problem. So anything that has direct or indirect bearing on the family and society can be a bad news for the patient and the family. So we have talked about the kind of bad news we have shared, and we'll do a role play around it. Again, I need some people to come forward and do this role play. So maybe we need one person who will do the breaking of bad news. We need somebody who acts as a patient, and the other one can be patient attendant. So this time I want a new set of participants to volunteer. You have to act like a patient, it could be a man or woman, who has been diagnosed with early stage of cancer pancreas, and then somebody who breaks the news to the family. I'm going to stop sharing, and I would request people to volunteer.
I can act as a patient.
Okay, that's a good idea. Let's see if we have somebody volunteering to. Yeah, in case if nobody volunteers, then I'll request you to do that. Thank you. Thank you for offering. Yeah. So who is willing to take this challenge of breaking the bad news? Anybody? I know we have only few people, with the camera on. So ultimately the responsibility falls on you, because I don't know about others, whether they are there or not. They have their camera off. That's a challenge. Anybody who's interested to play the role of the doctor to break bad news? We could even take a different situation. For example, something that you have been doing, we can take that situation. There's no hard and fast rule that we have to stick to this situation. So anybody who is into handling such situations where you have to announce a diagnosis? Anybody? Dr. Rima or Dr. Tanushri, anybody who is doing this? Dr.
Yeah, I can do it.
So you want to take the same situation or you want to change the situation?
Anything is okay, ma'am.
Okay, wonderful. No, but if in case if you are more comfortable doing something that you have been doing, I don't mind changing the situation also. If you give me a situation, I'm okay to even take that as a case for role play. Okay, so Dr. Tanushri is okay to play the role of the doctor. Am I right, Dr. Tanushri?
Yeah.
Okay. Now the rest of the roles are simple. Somebody who wants to be the patient and attendant. So Shivani, can I ask you to be the patient? If that's okay with you?
Okay.
Wonderful. Thank you. So Dr. Vani, will you be Shivani's maybe elder sister, or what do you want to play the role?
Mother, mother.
Mother. Okay.
Mother.
Thank you. I didn't want to tell you that, otherwise I thought that you'll say, "Oh, I am so young. You're asking me to play the role of the mother." But I'm grateful that you have overlaid here. So I think do three of you know the situation clearly? Great. Any information you require about this?
So maybe can we take up the role of like infertility, as you mentioned earlier?
That's also
Because where mother and daughter is there, we can take up infertility.
perfectly all right. Yeah, but now it's a well diagnosed case. I mean, there is no doubt if we have to do some more tests. We have established that it's a case of primary infertility. So rest of us will, switch off our videos, and only three of you will be there. I will only come in when I need to uh, come in and tell you that we have to stop or I need to intervene, and also try to follow the protocol that you normally do. Let me switch off my video. Okay, go ahead, please.
Shivani, I just saw your reports, all whatever we have done so far. And with that, it suggests that there are certain problems where, the conceiving in a natural way may be a little difficult. So you might require help of maybe some artificial reproduction techniques to get pregnant. So maybe who is accompanying you, who is there along with you. I can discuss, or is your husband there, your mother, who is there with you, so that I can discuss the things with them also.
I have my mother with me, but also I have few
Okay.
doubts about all this.
Okay, so please go ahead. I can answer your questions.
If I can't conceive naturally, are the artificial methods or the other methods reliable completely for my pregnancy? Will I be able to conceive after those efforts?
See, generally, like when you try to conceive naturally, there's always a 50-50% chance. Some may some may conceive, some may not conceive. Similarly, for the IVF, artificial techniques, also, it is the similar thing. Some may conceive, some may not conceive, some may conceive in first go, some may take, multiple attempts to get conceived. So we have to work out a plan accordingly, so which suits you, your body, or what kind of treatment we can offer, so that the possibilities are to the maximum which we can help you with.
As it is a big trauma for me and my family to know, I want you to explain me everything in detail, which will be easy for me, my family member to understand.
So first, let me just ask you, will it
Sorry,
be
I'm
okay to...
interrupting. Can we
Yeah, please.
engage the mother also, because she was supposed to be here?
Yes. So that's what I was asking her, that will it be okay for you to handle this alone, or let us involve your mother when she's accompanying you, call her inside, so that, we can discuss along with her, so that you are, in a better position. If you have some doubts, your mother can ask some better questions, or, may give some more clarity also
Yes,
in
I want
supporting
my mother
you.
to be with me.
Yes, so please call her. Yes.
Hi, ma'am.
Hello.
Ma'am.
So yes, I was just discussing with Shivani that some reports we had got, a certain set of reports where there's some problem. There are certain issues where natural conception may become a little difficult for her. So we might need, we will have to take some help of artificial reproduction technique, wherein there's a lot of support required from your side or from Shivani's husband, though her husband at the moment is not available. So I would really want that in the next follow up, you can get her husband also along, so that I can discuss these things with him as well, so that it is easier for you to undergo the treatment. Or, like, I mean, just because this is a diagnosed case, we cannot allow her to, give her a natural trial for some more time period, which will just delay the process process of conception. So considering her age and all that, we would want that to take the help so that it, benefits her.
There is no 100%. There is no chance of normal fertility at all in my girl.
Yes, don't worry. See, there are many options these days. Even if somebody doesn't get pregnant on their own or naturally, then we have many options available wherein you can take the help of those things and then become pregnant. So we can discuss those issues, discuss the options as well with you.
She has a very big problem in her with her in-laws for her not conceiving for this many years. So I'm scared if what this artificial fertility also fails, is there safe? It is safe, and 100% chance is there that my child will give birth.
See, 100% success is not, I wouldn't say that, but yes, like how you conceive naturally, it's a 50-50% chance. Similarly, IVF would also have a similar chance. So we can at least take an attempt, to go ahead with this procedure where, again, because the natural process is not happening, then we can go for the artificial. But again, it's not 100% success, and that is the reason why before you take a decision of going to that, I would request that if you can, bring along her husband also, so that the husband, both of them together, Shivani and her husband, can, discuss things and then inform her in-laws, so that, the process becomes a little more beneficial, I mean, little more smoother for you all. Or we can work out other things, then if you have some other problems, then
What are the reasons for
The
my
problem?
infertility?
The problem is in my child or in my son-in-law.
See,
Also, I want
so far what we have found out that your daughter is having a little problem, which is not allowing her to conceive. Okay, so even if I mean, if we opt for a surgical treatment, also that will not correct her. Rather, giving an artificial, the other options, alternatives would help her to go through this process in a better outcome. I mean, better success would be better than the natural conception. I mean, so natural conception, as I
nowadays
mentioned, it is
I
not
saw
possible.
nowadays I saw in the news and all that this artificial things and all proper way is not adapted. Beggars things are used like that. So I'm scared about that consequences also.
So
Okay,
yeah.
can I stop you? Now, see, this is something probably it's a bad news, no doubt. But at the same time, maybe they have some idea about what was, in the pipeline, because maybe they have already seen that the girl was not able to conceive for quite some time. What in a similar situation after they have made a lot of payment for the IVF and the IVF has failed? So that's where they will be agitated, and although I mean I would say you handled it very well. You were very calm and composed, and the speed of your talking was very good. It appeared like you were open to dialogue, you were open to, listening to their concerns and answering them in the same possible manner. But when they have already had faith in you and they have made the payment for IVF, and it's like first, second, third trial, and there is no success, that's where the real, challenge comes in. And then even we become apprehensive because we have already made the patient make payment, and we have also tried our best, but we can see that, and success rate we know in IVF is not 50%, it is 25%. So all the more it is, risky to, I promise 50%, and now the actually it is 25%. So they have seen on the Google and they come back to you. You promised us 50% chances, and now we have seen so many studies. They show that it is not 50%; it is 25%. So you can imagine the. But in any case, you managed it well. You were very cordial, very very nice to them. So I'm sure the family was open to having a discussion with you, having a dialogue with you. But a lot of time we have seen breaking of bad news actually leads to aggressive reaction coming from the patient part. So for everybody's interest, I would like to take you through the presentation and understand what are the steps that we need to follow when we are going to break the bad news so that we can handle that situation. And also, like I said, when you announce that IVF has failed and even that's not going to work, and probably the last option we have is that probably we need to go for maybe adoption. So it's again a very tricky situation, not that easy for anybody to accept. So let's have a look at the presentation and have discussion. What others have to say in case if somebody wants to add to the discussion from your point of view.
The mother was more worried rather than the daughter.
That was visible, absolutely. The mother was more worried than the
empathetic and is explaining in detail the aspects. But in the protocol, as we are going to tell now, no, first setting the perception, what the
we talk about it. We will talk about it. Don't worry. But you're pointing to the very right point. So that means I need to know who is more affected by this situation, who is more disturbed by the situation. So we need to probably address their concern or their emotional milieu, because major problem is their emotions. Probably technical part we can explain very well, but handling emotions can be very challenging, especially for the young doctors. That becomes a challenge because they know about their subject, they're doing very, very good job. But when it comes to handling patients' emotions or their family's emotions, they just cannot handle it. And that's where the communication breaks down. And especially if you have done so much for the patient. For example, seriously, you have put in a lot of effort to save the patient. For example, it is ICU situation, and you have put your heart and soul to save the patient. But unfortunately, the patient is deteriorating. Now you have to inform the family that there isn't much, hope of saving the patient. So probably that's where you feel very upset about the situation. Over and above that, if the family blames you that you fooled us, you made us pay, and we have spent so much of money, you had said that everything will be fine, and now you are, saying that there isn't much change. That's where we lose our composure and we also become agitated and start reacting with aggressive reaction. So how do you go about doing it? We'll talk about the protocol. Let me share the presentation with you and then have the discussion around it. Okay. So usually the patient's family and the patient, they have a lot of questions. So if you saw in this role play, we have a tendency to explain. Like I saw Dr. Tanushri explaining very well in detail, but we have a tendency to explain to the extent not knowing what they want to know. So that telling mode is very, deeply ingrained in our way of communication. A lot of time knowing what do they want, what do they want to understand. That's very, it's helpful to explore. And then when you give them need-based information, they're better benefited. So this is, one picture I had received long ago, and this is a case where a lady had died because of some complication, and the family were very upset about it, and they literally took her dead body and a procession, with the banner stating that so and so doctor mismanaged this patient's case, and she died because of his or her, mismanagement. So I don't know if any mismanagement happened, but I'm sure there was, communication failure. So when we don't update them, when we don't answer their questions, when we are not transparent in our, approach, that's where they accuse of us of hiding the facts or not telling them the truth. And unfortunately, in any situation, if things go bad, that's where they blame us for the poor this thing outcome, and also blame us for the medical negligence. So breaking of bad news is one of the trickiest and most difficult communication. because we are discussing issues like life, death, poor prognosis, complications, and unexpected outcome. And you will see most of the aggressive reactions occur after breaking of bad news. What do patients value? Patients value that please communicate clearly and empathetically. So a lot of time we are very straightforward. So in case, Tanushree, if you look at your communication, you started immediately with, Shivani, we have found from your result, this is the result. So we have a tendency to go straight away to the issue that we want to talk. But they expect us to be more humane in our approach and explain them and involve them in the discussion. So as I talked earlier also, that breaking of bad news is something that patients, almost 70-80% of the patients say that it's a suboptimal experience. And reason is clear, because if we have not had any training, if we have not learned how to do it, so we are doing it by hit and try. So it was okay earlier, but today, if we don't have right way of doing it, there's all possibility of aggressive reaction coming and all sorts of legal issues also cropping up. Younger generation experience more challenges, because when you become senior, you become more confident to handle the situation. But when you are young and still understanding, that's where you have challenge handling emotions, because breaking of bad news require not only advanced level of communication skills but also great experience in handling emotions. So one needs to be really good at words. How do you really deliver the news, handling emotions, and especially the questions that are going to come from the patient side. And then also, if you see them accusing you, how do you really control reacting to the situation? That's another challenge. So a word of advice for all of us is that we should build good rapport with the patient and their family, because you never know which case might turn into an emergency and have an unanticipated outcome. So there is a patient, all through her antenatal period, she comes to you and everything is fine. There is no, any red flag. Everything is going fine. But unfortunately, at the time of delivery, she goes into amniotic fluid embolism. I know this is one of the rarest complications, but we have seen cases. Now, if you have had good rapport with the patient and the family, if you have attended to their concerns meticulously, if you have answered their questions, if you have updated them on regular basis, when you explain to them that this is what has happened in your case, probably they will understand that you haven't done it or you haven't caused it. This is one of the things that could happen. And also, have we discussed about the possible risks during delivery? Because we know obstetrics is a very unpredictable branch of medicine. But we never like to talk about that with the patient party. We want to give them this picture that absolutely everything is fine. What if this case turns into anything unanticipated? So do we talk about all that? Do we update them? Studies have shown that if you are able to, create familiarity with the patient and the family and build rapport with them, the risk of aggressive reaction gets reduced. That's because they are less likely to be aggressive with the doctor they are familiar with. So it's all the more important that doctors should make themselves, familiar with the patient. The patient should have this confidence that my doctor is very responsible, very caring, very understanding, well-read, and knows about my case in detail. That's very important. Not only impression, but in reality, that should be the approach for every case that we are handling. So keeping the patient and the family in the loop by regularly updating them, by addressing their concerns as and when they come up with any questions, it's important to address their concern and then involve them in decision making. Rather than we deciding on their behalf, it's good to tell them the options and what option will work. For example, if the patient is in ICU and the patient needs to be put on ventilator, it's important to let them know why ventilator is important. And they may have concerns, what are the chances of recovery, because a lot of patients of their family members think that a patient going to ventilator means there is less scope of recovery. That means the patient is in serious condition, so there is less likelihood of patient making out. So addressing their concern and then involving resolving the, you say, no, everything is fine. If you put on ventilator, there's 80% chance the patient will recover. And then unfortunately, if the patient dies, they're going to blame you that you put the patient on ventilator because you wanted to make money. Don't be surprised if that's the accusation they come up with. So keeping them in loop, regularly updating them, addressing their concern, involving them in decision making are some of the things that will help you to break bad news effectively, because all through you have been very responsible in your approach with the patient and the family. Please remember, when the condition is critical or the patient has a serious diagnosis, it is the family who is moving under the greatest fear, and that is fear of death. When the patient party, especially if the patient is in ICU or in emergency department, the only thing that they are worried about is the patient should make it, should come out. And that out of that fear also, they might overreact to the situation. They may become aggressive with you. They may start questioning you, and they might even appear to be, not trusting. So many of us look after the patient very well, but do not consider the family as the beneficiary of our care. So as a result, we don't address their concerns and we don't address their emotions. Whereas, especially in the Indian context, when the patient is suffering, it is the family who takes decision on behalf of the patient, and it is important to involve them in decision making and patient address their emotions. So I'm going to share a protocol for breaking bad news. These are just guidelines. You can choose your own way of doing it. But if you are able to follow these steps, it will help you to deal with this situation in a more professional manner. Whenever there's a critical situation, updating of the family and breaking of bad news should always be done by the senior most person present there. Preferably the consultant who is treating the patient, because by now you are familiar with the patient, you are familiar with the family, you know about the case details. They may ask you a lot of questions, and as a senior person, you would know more about the case. So it should always be done by the senior person. So there are 4 P's of breaking bad news. The first P is about preparation, where you do your preparation as a physician who's going to break the bad news. Then place where you're going to do it, and also prepare the patient. Then second P is about performance. How do you go about doing it? Third P is palliate this situation. Once you have actually broken the news, then it's important to also help them cope up with the situation, and then the discussion about the plan of action that they need to follow. So let's dive deep into each P. The first P is about preparation of physician. So it's very important to first of all know in detail about the patient's case. Never go unprepared about what has been done, what you are planning to do, what are the investigations you have done, what are the findings of the investigation, on what basis have you taken this decision. You need to be thorough with it, because they are going to ask you a lot of questions, and if you don't sound confident and well prepared for it, you are going to lose face in front of the patient. So before you start divulging into the information, it's important to make connection with the patient and family. You may be knowing the patient's family, you may not be knowing the patient's family. So it's always important to take their introduction and also give your introduction to them. And some small talk, something like, what is your idea about the patient's condition? For example, if the patient is in ICU and you are calling the patient's family to tell them that the situation is not really good, the patient is not recovering and is not doing well. So asking them, have you seen the patient? Did you go and meet the patient? What is your feeling? What is your observation? So that's a way kind of you're getting to know about what is their understanding of it. So these activities like breaking of bad news or disclosure of medical error, they require time. So be mentally ready to spend some time and don't appear to be in hurry, because if you appear to be in hurry, or there's a phone call in between, or there's a visitor waiting outside, or you have a case where you have to go and operate, so somehow this sends a message that it's important, but it's not very important for you, and you have more important things to do. So this has to be done in a very peaceful manner so that they don't feel that you consider them less important. I'm repeating this once again. Please do not delegate it. You should always, the treating doctor or treating consultant should do this activity. Juniors can be present to observe and learn from the activity, but it should be done by the senior most. Talking about the place, it's very important to remember that it should never be done in an open place. I know in most of the hospitals we have counseling rooms now, but if I look at the government hospital setup, we don't have any counseling room, and we know mostly the breaking of bad news is done outside OT, outside labor room, outside ICU. Very rarely we have a side room or a counseling room where we do it. The risk of doing it in open is that uh, the patient might overreact. You may feel embarrassed by what the patient or the family says. Others who are overhearing the discussion, they may complicate the situation. So it's always advisable to sit down at a separate place and ensure privacy. It's comfortable for you as well as for the patient party. Then involve significant others. So it could be any relative of the patient whom you think can play a good role of creating a balance or calming down the patient party. But from your side, you can have a social worker. Now, some hospitals have a psychologist on board. Some people have social workers. Some people engage their senior nurses. Even having your colleague in the setup is also a good idea because you will be helped by their presence. And of course, things like facial tissue, glass of water. Usually now these are kept ready to harm the person and show your human side. So before you start saying anything, it's important to assess patient's starting point. Because how much does the patient know? For example, if the patient has just no clue, so you will have to really start and build from there and slowly, with every investigation, you will have to kind of inform them that what you're expecting. For example, a patient with the squamous cell carcinoma, the buccal cavity. So maybe in the first go, you will say, I think it looks something that needs investigation. Let's take a biopsy and send it. So in the meanwhile, you have sent the report, sample for biopsy. You ask them for how long it has been there. What have you shown it to some other doctor? What has been your understanding? What has the other doctor told you? So what happens? You have an idea how much they know. In case if you find that the patient party is not aware of anything, or they are not, they have just no clue. So you will have to really be careful about when you are going to share the information. It's also important to check the patient's information need. So usually, a lot of time, rather most of the times, we know it is the family who wants to know, and they don't want the patient to know in our context. Whereas we know among the patient's rights, this is one of the right of the patient, that the patient has right to the information and patient has to choose whom they want to engage in the discussion. But that's keeping that aside. I think in reality, it's always with the family that we discuss, and then the family says, don't tell my patient. We have seen a lot of situations where they say, please don't tell my mother that she has cancer, and we don't want to bother her more. So, of course, as discussion about it, we will do in a while. But then it's important to ask, what does the patient want to know? And check if they are prepared. And if they're not prepared, you will have to build on, starting from scratch. And then usually it's the family who gets engaged in the discussion. So it's also helpful to assess the patient's perception. A lot of time you will see they will have complete illness denial. No, this cannot happen. Or they may have wishful thinking that I think it will be all right. I will take this medicine. I will take Ayurvedic medicine. I will take this help and I should be fine. Or they may have unrealistic expectation of the treatment. So when you observe anything like this, it's important to address them appropriately. See, a lot of time they equate money with outcome. They'll say, we are ready to spend any amount of money, but please make sure that the patient comes back. So again, this is an unrealistic expectation. Of course, with money, you can buy the treatment, but you cannot buy the outcome. So this has to be addressed appropriately so that there is no miscommunication. Any misinformation they have, that should be corrected then and there itself. Otherwise, you are going to face the problem at in the later situation. Then in case if you see extreme denial or wishful thinking, tailor the bad news, but make sure that you have to communicate everything in a very honest way. So when it comes to performance, it's important to be sensitive but straightforward. So any attempt to minimize the severity or to soften the blow is going to lead to vagueness and confusion, and then tomorrow they will blame you. Because when you say, I think he should make it, I know, I feel it should be fine, but that means you are kind of sending a double message, which is not going to be helpful. And then balance between sensitivity and honesty. A lot of time we say we want to be honest, but then you sound very insensitive. That's not something that is advisable or desirable. So use simple language, as simple as possible. Avoid all technical jargons. So a lot of times, see, when you are in a department, some of the words which you use on everyday basis, they don't appear to be technical to you, but for the patient party, they can be very, very technical. So when you say artificial ways of conception, the patient party may not understand anything. What do you mean by artificial ways of conception? Even ventilator can be a new word to them, or BiPAP can be a new word to them. So we have to avoid all technical jargons, explain everything in a very, very simple manner. Another good important point is avoid single steady monologue. So if you continuously talk, because we have a tendency to be in the telling mode, and we think I must share everything so that I don't miss anything vital, but that makes it more like a monologue. They may have questions in between. They may have some concerns to address. They may not understand what you have said. So it's always good to, pause frequently so that they get an opportunity to assimilate what you are saying. So it could even, the patient may feel suddenly, in shock because, oh my goodness, this is something that I was not anticipating. So they will take time to even comprehend that information. And for that, we need to, go slow, give them a chance to assimilate what we are saying, or in case if they have not understood, give them a chance to clarify them. So use silence, and your body language plays a very big role, in facilitating the discussion. If you sound to be very rigid or a strict kind of a position, then patient family may not feel very comfortable clarifying their question. So it's good to have an open kind of a body posture and let them feel comfortable talking to you. Check for understanding. Lot of time we say something and they keep nodding, but when you ask them, have you understood? And they say, yes, yes, we have understood. And then you say, can you explain me what is your understanding of the discussion I have made? And you will see they will not be very clear about it. Or a lot of time you must have seen, you say everything and in the end their question is, Doctor Sahab, patient bach to jayega na? That means they have not really understood. So it's very important to check for understanding and and talking about the body language that will help to comfort the patient. 7% of the communication happens through words. Rest all is your non-verbal, your tone of voice and your facial expression. And if your facial expression and body language is not appropriate, they are going to, experience being intimidated or not being facilitated to talk. So we have to make sure that our tone of voice, like Dr. Tanushri, your tone of voice was very good, very, very kind and nice, and speed of talking also was very fine. So that encouraged the patient party to ask questions, to clarify. So that should be the tone of voice where you're encouraging to have a dialogue. And even your body language was, perfectly fine. Again, that showed that you're open to having a dialogue. Even your selection of words was very nice, except that somewhere you were using technical jargons because we are so used to using those words that they don't look like technical words to us. But from the patient point of view, they may not really understand what we are saying. So a lot of time, even using audio visual aids, like for example, drawing and explaining or having some model, some chart, that can help you to, explain better. So that's a very good way to, make things easy for the patient and the party to understand, because technical things sometimes become very difficult to explain verbally, but visually they will understand. So whenever you are going to, start the discussion, enter the room. Mostly we go to their room, or when maybe they come to our chamber, greet them softly, establish eye contact. See, establishing eye contact here is very important, because a lot of time when we don't make eye contact, they may say it as though we are not very confident, or maybe we have done something wrong and we are trying to hide it. So it's very important to make adequate eye contact, maintain open posture, which shows that you are open to dialogue, but you are not responsible for what has happened. So leaning forward, and tone of voice plays a big role. We have talked about it. Allowing them to express, it's very important. Let them also. Sometimes a lot of things they will say, that it may not even have relevance, but uh, there is an emotional background that needs to come out, and we have to let them vent. Whatever they say, we have to listen attentively, and whenever appropriate, we can nod to kind of express that we understand and we agree, and we are with them in this situation. A lot of time they may even react emotionally, or especially, for example, if we have done IVF and the IVF failure as a second or third case. So naturally they will have, now they, because they're feeling helpless and hopeless. So it's not that they are thinking that you are responsible for it, but they're very unhappy with this situation. So there can be emotional reaction. We don't have to react to everything. A lot of time we unnecessarily take the blame on self, and then we start arguing and we start giving explanation. Just maybe being quiet and let them venting out is also a good option to calm down. And then when a lot of time, verbally and non-verbal comforting can help. But of course, touching on the hand or head or shoulder can help, but again, we have to be very careful while using such gestures, because now not everything is taken in a simple way. So one has to be careful. But of course, we know when you touch on their hand or on their head, they definitely feel comfortable. So how do you start the conversation? Normally, if I may ask all of you, what is the starting point? What do you say when you start the conversation? So, like Dr. Tanushree straight away talked about, uh, your results show this. So that's usual way I've seen people talking about. But what other ways could we think of to start the conversation? If anybody would like to unmute and speak.
Maybe we could have just started with like gently greeting the patient, or asking her that have whether she has gone through the reports or not. So did she understand anything? That could have been done in that case.
And why I'm saying this, because when you kind of signpost them that I'm going to share something very serious, so maybe they'll have an idea, and already they would be knowing honestly. But when you start like this, they get this feeling that somebody understands that it is a difficult time for me, or some difficult news for me. So when you say something like this, I'm afraid I have bad news to share with you. So I have seen your reports, and the reports are not very encouraging. And unfortunately, I even got your report, checked at two places to be very sure of the findings. But I mean, the report at both the places communicate the same thing. So what you are, before you are actually sharing the information, you are kind of signposting and letting them know that this is what is your understanding. The question is, how does bad news hit the patients? Even if they have an idea, even if they know about it, bad news usually result in cognitive, behavioral, or emotional deficit. They will suddenly be quiet. They will not be able to think. Even behaviorally, they will not know how to react to the situation. So you will see them sometimes, sitting just quiet and being numb and not knowing how do they react to the situation. So we can't change the news, but of course we can help give realistic hopes, or make it worse by giving a cold behavior. A lot of time we act in a very cold manner, so that can be very upsetting for the patient and the family. The patient may react with, sometimes they may start crying, some people become suddenly silent. Somebody might say you, are you sure? Are you sure about the report? Could the report be wrong? Or they may say, please don't tell the patient. Patient might say, please don't tell my family. So these are the things you will get to hear often from the patient or their family members, because that's the emotional response to the situation. The psychological response is called DABDA. DABDA is acronym. D is denial, or they are not able to believe it. A is they will be angry, unhappy, aggressive, or revengeful. B is bargaining, where they may start asking, can we take the patient somewhere? Can we take second opinion? I'm ready to pay as much as you want, but please see what can be done best. So that means before they actually accept, they are in that stage of bargaining with us and with the diagnosis. Next is depression, where they have kind of realized the reality, but they're feeling very sad and low about it. And then finally is acceptance, that they accept the diagnosis. So this is called DABDA. So how do you handle this? When the patient is in the denial state, it's helpful to provide them with information. So if you tell them about the facts and figures, if you tell them about the result findings in an empathetic manner, to help them see the reality, they will understand that this is the truth. If you see them being angry and aggressive, uh, not reacting and not answering everything is a good idea. So stay calm, listen to what they are saying, and support by being quiet and allowing them to vent out. If you see them bargaining, help them see the reality. Of course, empathy in understanding their state of mind and asserting, providing them with the information that will help them see the reality. And when they are in the depression state, that means they are quiet and they are not able to, they appear a little confused but quiet. So that's where we need to give them direction on what they need to do. And then when you see them accepting, that's where we have to encourage them and help them move further and do whatever best can be done in that situation. So in all situations, I think empathy plays a very big role. It's a great tool to create solidarity. So that's where you have to kind of understand their state of mind. Anybody who is diagnosed with something like this would be upset, would be disturbed, and they'll take time to accept and move on. Giving them that much of time will definitely help them. There are many ways to express empathy. So you can, offer state something like, I can see how upsetting this is, or I know you were not expecting this. Even I was not hoping for something like this. Or sometimes even being quiet can be a great way to communicate empathy. Now, coming to the role of residents, nurses, and other paramedical staff. A lot of time, when we know that the patient's condition is not good or deteriorating, or there's no scope of improvement, especially in critical care areas, I think the resident nurses and paramedical staff need to be more understanding and accommodating to the family's need. For example, if the patient is in ICU and we know the patient is not going to make it, so being little liberal with the family to allow them to see the patient, because please remember, probably these could be the last few hours for the family to see their patient alive. So not that you will allow everybody and anybody to go into the ICU, but at least the immediate family members can be permitted to go and see the patient, without even visiting hours. With the instruction that please don't touch anything, don't disturb anything, just go have a look and then you can come back. So when you do something like this, they are always thankful for your gesture, and they appreciate you understanding that they want to be close to the patient, they want to see their patient alive and for as much time as possible. Now, what is the clinician perspective? I think it's a tough job to do. So everybody is uncomfortable about the patient's expectations. A lot of time when you have actually given them the hope that things will be all right and patient will make it, that's where when you destroy the patient's hope, you are concerned about that. Then there's also a feeling of inadequacy in the face of uncontrollable disease. For example, there is a condition where you can't do anything. That's not in your control. So that can be very disturbing and upsetting. And then a lot of time we are not prepared to, we are not prepared to manage the anticipated emotional reaction. I've deliberately written the word anticipated. There will be emotional reaction. There will be emotional reaction. So if you do not, if you do not know how to handle, if you're not prepared to handle, there's all possibility that you will end up into a difficult situation. And then sometimes you feel embarrassed to have painted a very optimistic picture for the patient. And then if you have to break the bad news, it becomes very challenging. So I remember there was an eye chain in Delhi. So this was the tagline they were using for the advertisement. घर से आइए सर्जरी करवाइए ऑफिस जाइए. So for phacoemulsification, that was their tagline. Come from home, get the surgery done, and go to office. So that was something like the surgery is very simple and 100%, with 100% result. But I'm sure later on when they had some nucleus drop or they had vitreous hemorrhage, they realized that this is not, in all situations that you will have 100% result. So it's not advisable to give a very optimistic picture for everything. Be very, very safe and careful when you are promising them something. So what are the remedies for this? Please give realistic expectation, accept professional limitation. We don't have control over 100% of the thing. So we have to not only accept, but also communicate that not everything is in my hand. And then learn to control emotional reaction. A lot of time we overreact to what they say, and that can aggravate the situation. Keep the family updated, and then document all communication. So whatever communications you make with them, some rule is communicate what you document and document what you communicate, so that there's a evidence of all communication that is made with them. Some of the common mistakes that we do in breaking bad news is, for example, we avoid breaking the bad news as long as possible. We don't share the diagnosis, we don't share the prognosis. So you are avoiding it, hoping that things might turn out to be different, but you are calling for a problem. Or sometimes just not doing it and hoping someone else will do it. Especially in shift duties, we have seen that people think, well, let the next person who is going to come in, let them do the breaking of bad news. Or lying, or at best being economical with truth. So that means not telling the complete truth. Either we are lying or we are hiding a part of the truth. Deliberately not picking patients' cues. You can make out some cues are there which clearly indicate, but you just do not pick those cues. And then doing the activity in a mechanical manner, where you think whatever it is, it is. It's not my fault and I'm not responsible for it. So these are common mistakes you will see in the breaking of bad news. So once you break the bad news, the patient may feel hopeless and they may fear that they are going to be abandoned. It's very important to reassure them that they are not going to be abandoned. Establish a plan, what they need to do now. Treat their current symptoms. For example, if it is pain or it is fever or bleeding, whatever it is that needs to be treated should be treated. And then discuss the next treatment plan, where you want to refer them in case, for example, you need to refer them to a specialty hospital. So you will have to help them with those referrals. So arrange for appropriate referral, give contact details of the person to whom you are referring. If possible, if you can call them and inform, and also give that person's number to this patient so that there's a proper coordination between you, patient, and the other doctor. That will also help the patient and family feel comfortable that they are going to somebody who is known to. And then involve potential source of emotional and practical support. A lot of time when you're not able to handle emotion, it is seen that if you involve family or social workers or spiritual counselors or even peer support group, that helps to support the patient. In a lot of hospitals now, I see that they have psychologists and they have social workers to help the patient with so many other things. So that's the whole idea of providing support to them. Okay, so to summarize this topic, I think most patients want to know about their condition, and if you are able to do it rightly, It will improve your relationship with the patient. It will also help patient and family cope up with the situation. It will foster a collaborative relation between you and the patient party and also prevent aggressive reaction. So it's a very important communication. We all must learn and practice and showcase these skills when we are uh, working with working in such situation. And all those 5 skills that we discussed in the beginning of the day, if you bring them here in this discussion and communication, you will see you will be able to handle the situation far more effectively. So this is in nutshell about breaking of bad news. So any questions about the discussion we had about? I know it's a new learning, and it will take us time to start, using this learning in a real manner. But more you will practice, more you will try to implement whatever you have learned in the program. It will help you to be more effective in handling such situations. Because a lot of time, breaking of bad news ends up into aggressive reaction coming from the patient. So do we move to the last topic of the discussion?
Yes.
Give me a minute to start. Give me a minute. Okay, so last topic of the discussion is disclosure of medical error. I think it's as difficult as breaking of bad news. And especially in disclosure of medical error, since the patient has a reason to be angry with us, so all the more there's a risk of aggressive reaction coming from the patient party. So if anybody would like to share their experience where they have managed or they have seen how do you go about managing disclosure of medical error, if you want to share your experience, it will be good learning for all of us. Anybody where you have disclosed a medical error or you have handled a situation of medical error.
Adverse reaction, yes, but that's not a medical error, I think.
Yeah, adverse reaction, it's still explainable because again, we are not at fault. So we can just say that it is the patient who was probably sensitive to the drug and has reacted to it. But I know talking about disclosure of medical error is very, very difficult. And that's something that we are never prepared for. And therefore, the focus is on covering it up. But we have seen so many cases where covering is not an option. So, for example, if you had to operate on one side and you operated on the wrong side, where is the scope for, not sharing or hiding data. And that's why, disclosure of medical error becomes a very difficult task. Again, I don't think we have had any formal training in disclosure of medical error, but we really need to know how do you go about doing it. So a lot of protocol is something similar to breaking bad news. There is something more that we are going to talk about. So anybody would like to share their experience? Dr. Archana, Dr. Prashad, from your...
Yeah.
Yeah.
Actually, there was an incident when inadvertently a wrong dose was given to a kid regarding a paracetamol. So that time, when the consultant noted that the wrong dose was given, they initially checked with it that what dose it was given, and then we have to go ahead that we have to check the paracetamol levels in the blood and all these things. So we have to take the parents into the confidential that confidence that all these things have happened, and we know, but this is not very high dose, but still we, on a precautionary side, we just wanted to check what are the levels, and accordingly we'll treat that thing also. So initially the parents were a bit into the worry, they were a little on a aggressive side. But once they understood that the hospital has taken all the possible care, they are involving the parents also into the things, and they are transparent. So gradually they settle down.
So initially, aggressive reaction is something very common, and we know that's how the human mind, functions, because they want to blame us for the error or for the situation, and then slowly, of course, acceptance comes in. But that phase, how do we handle? How do we manage? How do we interact? That plays a very big role in deciding ultimately, are they going to be, okay. So I remember one more case where the patient went into amniotic fluid embolism. So although it is not a error, it was a complication, but the doctor got so, uh, mm, very scared of the situation that she moved the patient to the tertiary care hospital, a bigger hospital sector, because she felt that she will not be able to manage it. Or maybe just to diffuse the situation, she moved the patient to a bigger or a higher setup. And over and above that, there was no explanation, and the death was inevitable in that case. Unfortunately, we lost the baby, we lost the mother. It was a double loss for the family. So even if it was not an error on their side, but the whole behavior was so absurd that the family was very, very upset with the doctors, and with a lot of mediation we could calm down the patient's family, because they had lost two family members in that process. So how you handle that situation, how do you react in that situation, that plays a very big role. And we have seen in a lot of hospitals, after the disclosure is done, the doctor is not even accessible, they are not even approachable, they don't try to meet the family. Maybe it could be out of fear, I understand, but all the more it aggravates the situation, because then the patient party feels that you are acting so responsible, you have made a mistake, and now you don't even want to meet the patient or the family. So if you remember, there was a case, it was in news, it was a case, I think, that happened in Bombay, long ago, almost, I think, and there exactly something like this had happened, and the doctor just stopped following up the patient. The patient died after that. But the husband of the patient was so upset with the doctor's behavior that he sued the doctor. And ultimately, after so many years, the verdict came in their favor. That and one of the reasons for the the lawsuit was that the doctor did not try to connect with the family, talk to them, or address their concern. And that's where your good behavior and good rapport plays a very, very big role. If also they have seen you as a very responsible doctor, very professional, very knowledgeable, and well connected, they are likely to, even overlook whatever has happened in the patient. Anybody else who would like to share their experience of any medical error that you have seen?
Yeah, so there was once we had this that a twin sharing room. Two different patients were there, and one of them was diabetic and the other were not diabetic. And when the staff went to give the insulin for, say, patient A, and went in to give it to B, and the patient was attentive, so she kept asking that, what are you giving me? I'm not supposed to get any kind of medication, and especially injectable. So the staff was a little junior, and she said, no, you have to take it, you have to take it, it is there in your medication. So then she raised a voice. I mean, there wasn't a medical error as such. I mean, it wasn't dispensed to the patient, administered to the patient, but almost reached the patient. And the patient came out, the relative came out, and then the senior staff intervened, and then they cross checked. So the patient complained it to the consultant, and the consultant was in a little shock how to react. But then she calmed down that, no, we will take care, because you're adjacent patients. So, she, of course, the patient had a doubt that henceforth, how do I,
Yeah.
understand that the correct medicine is being given to me. So a lot of explanation and counseling had to be done on both the part. And then, especially for her, a senior nurse was deployed to administer the medicine.
That's true, actually. See, a lot of errors happen when we assume that we are doing everything right. And if we just make it a habit to double check or at least listen to the patient's point of view and then, consider that and then decide, I think a lot of errors can be prevented. That's so true. Yeah, Dr. Emma, you wanted to share your experience. Go ahead, please.
Yes, ma'am. Thank you, ma'am. Actually, I'm an ophthalmologist, and we usually dilate to see the fundus. So, I mean, during my initial days of practice, I have asked, I mean, there's a condition called primary angle closure suspect where we won't dilate. We have to constrict and do a laser procedure. So, for that, I have written in the case sheet. You have to you have to constrict the patient. So the optometry students only will do the procedures like either dilating or constricting. So there is some miscommunication. So as a routine, they took the patient to the dilatation room instead of constricting. So I was waiting and searching for the patient. Every 15 minutes, I have to check whether the pupil is constricting or not. So after 15 minutes, I went. There was no patient in the constricting area. So I cross-checked, and the student said the patient was here in the dilatation area. And I actually scolded the student for not seeing the case sheet properly, what I have written and explain that to the patient, as the patient is not aware of dilatation and constricting. The patient not created much, but she was tensed. So I explained everything and I mean consoled her. And after the dilatation effects has settled down, we will do the procedure like that. I had proceeded. So that is one I
Fortunately, in
encountered.
your case, fortunately, in your case, it was reversible. So
Uh,
you could reverse this condition and you could, manage it well. But a lot of time, we make mistakes which cannot be even corrected. For example, I know a case where a patient had to undergo, kidney removal. And unfortunately, in that patient's case, one kidney was doing well and the other one needed to be removed. And they removed the healthy kidney. So that's a very sad kind of error that sometimes, we make in the patient care. And most of the times, I think we don't follow the protocols. We don't follow the checklist, and that ends up into, these kind of errors. So, for example, even in your case, like you said, if the optometry patient had seen the case sheet and done the, decided whether the patient needs to be dilated or to be constricted, we could have prevented that error. So that's something that, again, ultimately, I think disclosure of medical error finally comes to the doctor, whoever is the treating doctor, they need to do it. But a lot of time, if the error has happened by the nurses, they are asked to, go and admit to the patient that this error I have made, and then they are. So we all have to learn how to go about doing it. Let me share the video, the presentation with you and take the discussion further from there. So I've deliberately mentioned it like when things go wrong, I think that's where the real, tough challenge comes in. How do you go about handling that situation? So this is a recent case. I think we all have seen that this was a flight from Delhi to Srinagar, I think. And unfortunately, because of hailstorm, the front portion of the flight got damaged, and as a result, the flight was literally, very in a very turbulent state. So everybody in the flight was scared and they were worried. So if you were in a flight, something like this, which had almost like a near miss crash, and some passengers were slightly injured, what would you like to know and from whom and when? Whom would you like to update you? If you were in that flight?
You lost the cabin crew,
You would want to know it from the cabin crew or from the captain. After you landed, then you want to know what exactly happened, what was it, and what.
So you will ask the higher authorities of that airlines.
Yeah. So you would want
what
to know,
went wrong? Yeah.
So you would want to know from the highest authority what exactly went wrong and why did that happen, whose fault it was, and you would want to know as soon as possible, immediately after landing up. So same way, a lot of errors happen in patient care. For example, this case, Rakesh Tyagi, I've deliberately changed the name, but this case was in the news, so you may be knowing it. This patient was mistaken for another patient who had a broken leg, and he underwent surgery to repair a fracture that he had not sustained. So, in such cases, how will you really explain to the patient party? Another case where a 51 years old physiotherapist, she was admitted with high blood pressure and ECG changes. So it took longer for the treating doctors to, diagnose the case. It ultimately, delayed the treatment, and finally the patient actually had cardiac arrest and she died. The family were really upset that why was a timely diagnosis not done and why was the patient not really managed on time. Yet another case, this lady came for some minor complaints of, abdominal pain, and she underwent arteriovenous shunt for dialysis because she was mistaken for another patient. So this is a recent case. I'm sure you all also must have seen this in news. So this is a father had come with his son for son's operation, and because of the mistaken identity, the patient's father was operated. Imagine the kind of errors that we are doing. So medical errors like wrong side surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient, they're very common. They're very common. I discussed earlier also that almost, medical errors are the third commonest cause of death. 250,000 patients die in US. I don't know how many patients die in our country because of the medical errors we make. So the question is, of course, we should make all effort to prevent these errors and ensure patient safety. But how do you go about doing it? That's something that we have to. Should we do this role play if somebody is ready to do the role play of doing the disclosure of medical error? If somebody is willing to take the responsibility of, handling the patient's family. This is the same case. This is a real life case. So, any volunteers? So, those who have not participated in any role play, they can volunteer now. I don't know, others are sleeping or up. A lot of them there. So, Dr. Archana, Will you be willing to handle
Oh.
this case?
Yeah.
Okay, great. So you will be the doctor who will announce.
So I am what? I'm doctor or I'm victim?
So we don't require the patient here. It can be patient.
Okay, fine. Yeah.
Family. I know Dr. Girish will be ready to handle this, but I don't want to. I want some, because ultimately everybody should get that confidence up with. I'm sure he can do it very well, but I want some more people to come forward and participate. So, Dr. Reema, if you want, we can change the case. So we can take that you were to operate on one side and you have operated. In cataract, I know this happens very often because both the eyes are more or less, in immature cataract. One is little more than the other, and we have seen where the patient has been operated on the other side. So will you be willing to take this case, Dr. Nima?
Yes, ma'am. But I would like to slightly change the scenario, where there'll be two patients who had same name, same age, same eye to be operated, but the lens was different. One patient has to undergo a payable lens. Another patient has undergo a normal rigid lens, which can be done under the non-paying section. So there is some mistake in changing the patients in the theater. So the lens got exchanged because the same, the staffs may have wrongly shifted the patient.
Wonderful. I think this is a good case. So we can take this case. So Archana, you be the patient because you said, and Dr. Reema will be the doctor who has operated. And then maybe Dr. Tushar, you can be, relative of the patient. So both of you can be together. And Dr. Reema can be the one who is talking to both of you. Is that okay?
Yeah.
Sure.
Okay, great, wonderful. So let's all switch off our videos. Yeah, you can go ahead, please.
मेरे को पता ही नहीं.
I will say.
Dr. Archana will be the one who undergone surgery in the free section, but has implanted the payable one. So, okay.
So, doctor, how did my surgery go?
Dr. Reema. So that would be, I think, easy because then they'll say, okay, if you have, put in.
No, ma'am. She has to ask her. She has to ask us a payment also, na.
So do you expect them to pay?
No, ma'am.
No. Then no. But then the case has to be that the patient has paid for the surgery, but you have put in rigid lens, which we use normally for the non-payment kind of a case, free cases. So, and now you have to explain to them that we were supposed to put in, especially if it was a multifocal lens or something like that.
No. We have mute, put up the video.
Is that okay, Dr. Ima?
Ma'am,
both.
Have I made your task difficult?
No, actually, I would like to talk with the patient who who I have implanted the rigid lens.
So who had to be given free lens and you have put a lens that you were supposed to use for the paid patient? Is that you're saying? Is that what you're saying?
Yeah, I would like to. I would like to tell the patient that we will refund the amount who had.
That's what I was saying. That if you have not put in the lens that they had paid for, so that will be their concern. I think now we are on the same page. Yeah, go ahead. Yeah.
So, doctor, how did my surgery go?
Hello, Mrs. Archana. How are you now? How are you feeling now?
So, my vision is not that clear, ma'am.
Okay.
There is no discomfort, but my vision is not clear.
Okay. Firstly, I would like to I would like to say sorry that a medical error was happened because there was two Archanas have admitted in our hospital, and they have to be operated on the same eye as you. She also admitted for right eye cataract surgery, and you had also admitted for right eye cataract surgery, but she is in the.
तो क्या प्रॉब्लम है डॉक्टर साहब?
Sorry?
ऑपरेशन तो हो गया ना?
Yeah, operation went well, but the only thing, both had the same name and the same age and the same eye to be operated, but only the lens has got exchanged instead
Oh
of.
my God, that's a blunder. I mean, this is my precious eye. That's not my problem if two patients of same name were admitted.
Okay. Yeah, I will, I'm understand your anxiety, but let me explain you. The only thing, the material of the lens will be different, but the outcome of the result will remains the same in higher cost lens or lower cost lens. All
नहीं
remains
डॉक्टर
the.
साहब, डॉक्टर साहब ऑपरेशन से पहले आप मिले थे, तभी आपने तो बोला था कि ये ऑप्शन है और हमने उसमें से ये. ओके.
Sorry, sir, can you speak in English? I don't know Hindi.
Yeah, no problem, ma'am. Actually, when we met before the operation, you only explained us that these all options are available, and you have when we chose the best one, you told this is the best one. Now you are saying both the lenses are same.
Actually, the comparing, the outcomes of the lens of various ranges of prices lens will remains the same, but only the material will change.
No, but what it causes some problem in my eye. How will I tackle it? And will you again do the surgery on my eye? Again, I will have to go through the whole procedure.
No, actually, it is not possible to re-exchange the lens once it has been placed, because the second surgery can cause more complication. Whenever we do re-surgery, it has its own complication. So if we place a lens one time, it remains lifelong, and
No, but madam,
the cost of the lens.
It's not about the cost. When we chose a particular kind of lens, we wanted that lens only. You had explained to us and we have selected one.
and even I have discussed with my cousin brother also. He is also doctor in somewhere in Maharashtra, and he told that this is the best lens. I think like you put it in, you take it out and you put the new one. That's it. That's it.
No,
You don't
actually,
want
it
to
is not.
compromise. You have already played with my eye.
No, we will refund the amount that to be, you have to, you had paid because we have placed the lens, normal lens, that is rigid lens, which is not payable. So we will refund, but there won't be any compromise in your vision. It going to be the same, even if the
But
higher.
then why this lens is cheaper? Why this lens is free? I had gone for an expensive one.
Yeah, only the material.
So what
Based
it
on
can,
the material,
what it
it is,
can, what effects my eye can have because of the material change.
so in the cheaper lens, we will make a larger incision. In foldable lens, we make a smaller incision. So the post-operative, um, um, like what you say, astigmatic power will change. That's all, but the outcome remains the same. The visual outcome will remain
Power
the
change.
same only.
Power
See, that
change
means
means
you have made a huge nick in my eye. What if I get land up in some complication, and why I should compromise with a cheaper quality lens?
Actually,
Doctor, the money is not the problem. Money is not the problem. The refund and all these things are a very secondary thing, doctor. But I just wanted to know how this has happened, and
yeah,
I just wanted to reverse the things. I just wanted to reverse the thing.
But exchanging of the lens is not possible because since it has the surgery has done well, the lens was correctly in the position, and what visual outcome we are expecting remains the same only. So it is.
Doctor, you know that I can sue you.
And we are going to sue you because you have really done a huge blunder.
This is negligence, doctor. I can sue you. I will record everything, whatever you are talking, and I can use that thing.
Actually, if any I made a mistake, I accept it. But the only thing, if it affects your vision or any serious illness occurs, you can proceed with what you can. But what I have done is correct. Only the lens has changed, but the outcomes.
How can you say you have done correct? You have done a huge error where you have got confused between two patients of same name.
This is your responsibility,
How you
doctor.
can say you are correct?
Yeah, it and the staffs in between has not followed the protocol correctly. If the patient has same age, same name, we have to verify the second name, the husband's name. They have missed that. I mean, following the protocol. So I have to take action on them, and I'm really sorry for not cross-checking while. When the patient has same age, and I have also rechecked the other second name also.
Doctor, we came because we have faith in you. So you have been referred to us by somebody known, and now whatever things has happened, it's very disturbing. Yeah, you are putting all these things blame on your staff, but the problem has happened with my patient.
Oh, I'm also taking my responsibility also. I should also rechecked. So I'm also taking the responsibility.
Can we stop?
Yeah.
Thank you, Dr. Ima, and sorry to have put you in at that time.
Sorry, we were like being really difficult. Sorry.
But I could see how difficult it is to.
Rima was actually scared. Her expressions were scared.
Actually, it was really happened in a hospital when I was in PG. So, yeah.
Okay.
But they have managed very well the hospital, and they explained both the patient and they have refunded. Since the visual outcomes are good, both the patient didn't underwent any resurgeries.
You said sorry only once.
Sorry, sir.
Sorry only once, and that you at the fag end of the talk. I think I told that in the beginning itself.
So it's actually difficult to say sorry. And especially if you feel it wasn't your fault, it was fault of your team member who gave you the wrong lens. You were in this surgery, so you could not check it. And we all don't normally follow surgical safety checklist. All the more a reason for us to, make mistake in patient care. That's very, very, very common. But thank you, Dr. Ima. I think you did your role well, and we could also see the apprehension that you had, the feeling of being, being judged and not able to handle that situation and answer their questions. All that was very clearly visible in the role play that you did. And I know it's a very difficult situation. It's not easy. Although in your case, it was still something. At least the patient had vision. What if the patient was implanted some lens which was not even of her actual power? In your case, you are saying that it was the same power, only thing is we mixed up the lenses. But what if the patient had needed another power lens and you have implanted another one? I think it would have been further more complex and difficult for you to handle. But I think your role play has really showcased how difficult the whole task is. So thank you for doing that role. And thank you, Dr. Archana and Dr. Tushar, for playing a good,
Sorry, Rema.
No, you did well. you did well. And we all have to learn to handle such situations because there is no escape route. There is no escape route. Everybody should know how to handle that situation. More you learn, better it will be for all of us. Okay. So a lot of clarity is also required in terms of definition, because what happens, we consider everything as an error, even if it is a complication or it is something that hasn't been done, willfully. We consider this as a complication. So it's important to know clearly what medical error exactly is. So medical error is something that is a preventable adverse effect of care, such as incorrect diagnosis, treatment mistake, or a lapse in healthcare delivery. So regardless of the fact that it led to harm or not, but it is an error. So for example, if you identified one patient, it was a mistaken identity, and you gave the wrong treatment, it is a medical error. That's very clearly. Then the second is omission, where you fail to perform an expected, action, and you don't take the necessary care that needs to be, taken, leading to potential harm or negative outcome. So something that was required to be done and you did not do, then again it's an error at our end. For example, there's a patient who complained of excessive bleeding post delivery, and we did not take the complaint seriously. The patient actually ultimately ended up into PPH, so it's an error on our side. Third is complication, when an unexpected problem that arises during or after the treatment, worsening the patient condition or creating new health challenges. So that's a complication. So, for example, a woman undergoes cesarean section and develops postpartum hemorrhage due to uterine atony, and that requires blood transfusion and ICU care. So this is not something that you have created, but that's one of the possibilities in any treatment modality. And then unanticipated outcome, where an unexpected result from the medical care that differs from what was intended or predicted, leading to potential harm to the patient. For example, this case of amniotic fluid embolism. So this was something that was not anticipated. So again, if that happens, it becomes a complication. Now let's look at how patients define problem. See, the patient's definition of error is very broad. It includes everything, even non-preventable events. So whatever we have discussed till now, complications or unanticipated outcome, all that is also seen as an error from the patient point of view. They even include poor communication or poor service as a error from our side. Whereas our definition of error is very narrow. It's only when we are deviating from the accepted standard of care, we consider that it is an error from our side. When it comes to disclosure, the patient's expectation of disclosure is that all error should be communicated, even near misses, where actually no harm has happened and actually error did not happen, even that they want to be communicated. Whereas we clearly want to communicate only if there is a significant harm to the patient. Now, coming to how should the disclosure of an error happen? Patients prefer it should be done truthfully and compassionately, whereas we want to give minimum disclosure and only what is important. So we don't want to talk about irrelevant things. Now, when to have the conversation? Patients want immediately, as soon as possible, whereas physicians think that it should only be communicated when I have all the facts with me so that I can give complete information. Role of apology. Patients expect apology, whereas we are concerned that apology will create a legal liability, so we are skeptical about apologizing to the patient. There's a huge disclosure gap. 90% of the doctors support the principle of disclosure, but only 30% actually disclose. So you can very well see that there is a challenge in actually doing the disclosure. Studies suggest that two-thirds of the errors are not reported. Even if the disclosure happens, it never meets the patient expectation. And trainees often do not learn to disclose. We all have seen that there is no much training done to actually talk about all this. What do patients expect? Write in the chat box, what do you think the patients expect from us? If an error happens, what do they expect?
Honesty from the doctor.
Absolutely. Transparency. Compensation. Yes, Dr. Rima, that's one of the things they ask for. Immediate disclosure. Absolutely. Agreed. True facts of events. Yes, that's true. And then for the doctor to accept, this is very important, Aparna. They really want us to accept that error has happened. The more we try to avoid, more they want to force us to say, yes, an error has happened. Accountability, yes, that's what is also expected. And then, yeah. So you will see patients normally expect us to agree and give statement that yes, error has occurred. Till you agree, they will keep asking you, "Galti to hua hai na? Galti to hua hai na?" That means they want to ask. They want us to accept that error has happened. Then they want to know the details of what exactly happened, and they desire full disclosure of all harmful images. Also, the implication to their health. What is going to be the ultimate impact of this error to the patient's health? Also, who is responsible for it? They want to have a face, they want to have an identity for who has caused this harm to the patient, and then why it happened. How will the reoccurrence be prevented? And apology. This is the common expectations of most of the patients. Then, why don't we disclose? Why don't we disclose? Write in the chat box. Why don't we disclose? I'm sorry I had to take that call. That's why I was not able to read your comment. So I can see a lot of things. Self-doubt, we start doubting our own skills. Fear of losing faith, yes, absolutely. Then job insecurity, compensation that we may have to pay. Fear of being judged, yes. Then scared of the consequences. Then we avoid bitter confrontation. Fear of being sued, yes, that's another concern. We fear litigation, absolutely. Then accountability. It is difficult for the doctor to accept the mistake and immediate disclosure. Yeah. So that means, yes, we all know that we are scared of the consequences. A lot of us are actually even skeptical of the benefit. What is the point of telling? What is the need to tell? Ultimately, we have to manage, we have to, kind of handle the situation. So why tell them, and why actually bother them? And if we tell them, it will cause unnecessary distress to the patient and family, so they feel that there is no need to disclose. A lot of us also think patient is unlikely to find out, so as a result we think that if they can't find out, where is the need to tell them? We also fear retribution from patient and the colleagues. We know somewhere it will actually bring poor name to us. Definitely, legal action and financial judgment are also one of the concerns. And then, of course, we know it's difficult to handle patients' emotions. A lot of time we believe that the disclosure is more like a factual conversation, and there is no need to, take it very seriously. Then, of course, belief that the outcome is not related to the action on the part of the person. So, in any case, it had to happen. The patient's outcome has not changed. The patient was in bad condition. Patient had to die, and even if patient has got affected by the treatment, the outcome would not have changed. And then lack of training in error disclosure. So a lot of time, these are the reasons why we don't want to talk about medical error. But then we all know, usually we are very scared to talk about it. We don't know how to do it. We have not learned the right way of doing, and we know the patient will never get to know, and we try to avoid disclosing. So when we talk about the benefits of disclosure, I want to ask you: do you think there is any benefit in disclosure? And if yes, then what are the benefits? What are the benefits of disclosure? Write in the chat box.
Patient pardoning.
Patient?
Patient might pardon.
Patient will pardon. That's one of the benefits. Trust is one thing that somebody has written. Trust of the patient will be earned. Yes, true. Patient will pardon ultimately, especially if you have always acted very responsibly. So they will know that you have not done it willfully, and they will trust you. Yes, trust is one important factor. Trust of the patient. That's there. What others? What are the other benefits of disclosure? So, as I have mentioned, it promotes transparency. Can I request you to put your device on mute mode?
Even if something adverse event happens and the case goes into the court, the court will take a side of doctor that yes, they transparently disclose the thing.
Yeah, if you have done it transparently, and if you have followed the protocols of proper documentation and taking the corrective action, ultimately even that is believed that you have done your best possible to the patient. Then one of you have written trust of the patient, and then self-conscious. Yes, you are at least peaceful that you have done your job. It also enhances patient safety, preventing future incidents. See, if you will share with your team and with your department people that this error has happened and we have to do RCA and do CAPA, so automatically you will be preventing the future incidents from happening. So, but if you don't share, if you don't tell, and if you cover up, nobody will get to know, but everybody will keep doing this, making the same mistake. So ultimately, the patient harm will not, go down. It will continue to happen. And especially when you use this approach of RCA and CAPA, automatically the errors will go down. One of you have written, we'll be cautious not to repeat the error again. Yes, if you admit that error has happened, so you will act more responsible in the future cases. It also meets the legal and ethical requirement, and it prevents litigation. So if you have, kind of communicated to the patient, you have met the legal requirement, and tomorrow, even if this case goes to the court, you have met the legal requirement, and that will you give upper edge. It will also strengthen your relationship with your patient because now you have been transparent and you have disclosed it honestly. It facilitates healing and recovery, especially it provides support to the patient and the family, especially if you have informed the patient that this has happened. Now, this is the precaution you need to take, and this is the care you need to take. So, automatically, the patient recovery and healing will be definitely better. Actually, only 3% of the cases sue the doctors or hospitals for the error. Studies have suggested a skillful conversation and follow-up can reduce the risk of litigation, and only 3 to 5% of the cases actually sue the hospital or the doctors for negligence. Studies have also shown that patients and their family members, they don't sue the hospital or the doctors for negligence, but they want to sue if they feel that they have not been communicated effectively, or there is lack of empathy and a feeling of being mistreated by the hospital, and there is a withholding of essential information. So that means somewhere if they feel that they have not been given complete information, they decide that, okay, let me sue the hospital, we'll get all the information from the hospital. So it's important to remember that communication again plays a very big role in reducing the number of such cases. So there are lots of studies that showcase how a couple of or many hospitals have actually implemented full disclosure policies and how that have helped. So this is one case I'm sharing with you. This is by University of Michigan, 2002, where they implemented full disclosure policy. In that, there were three components. The first one was if the patient was harmed, they acknowledged it and compensated those patients quickly and fairly. I think this is the first step. If you know that a harm has happened, rather than covering it up, you accept it and you compensate them quickly and fairly so that you can close the case then and there itself. If they felt there was no error, they aggressively defended the case in the court. So that means if they were sure that we haven't gone wrong anywhere, so not to be taken for granted by the patient, they would not mind fighting tooth and nail in the court to prove that there hasn't been any error on their side. And third is if there was any adverse event, they studied how to avoid such, harm happening in the future so that they can minimize the number of such cases. So these three components were implemented in the hospital, and the results were very encouraging. Their annual litigation cost almost became 1/3. Also, the average time to resolve those cases also reduced to almost like 40%. And number of claims and lawsuits also came down to less than 50%. Very clearly indicating that if you have a proper disclosure policy, you will see that you will be able to handle such cases effectively. So I am not sure how many of us can think of implementing something like this, but ultimately in the time to come, we will be forced to implement something like this, and you will see, nowadays what we are doing, even if there is no error, but just to avoid litigation, we are ready to compensate. But then if you have clear policy to implement disclosure of medical error in the right way or managing these cases in the right way, I'm sure slowly we will have a proper protocol in place. So I'm just sharing the guidelines for disclosure of medical error. It's quite similar to breaking bad news because there also we have to, follow all those communication protocols, but there's little more to it than this. So this is based on Canadian Patient Safety Institute and UK's National Patient Safety Agency. So before you actually start the conversation, it's important to know the information, check yourself, how are you feeling? Are you ready to, deal with the situation? Because there is going to be a lot of, emotional confrontation between you and the patient party. So prepare yourself for strong emotions coming from the patient party, and even you will experience something like this. So there is no harm seeking assistance from your trusted colleagues and having them on your side. So when it comes to performing, it's always good to start with saying, yes, error has happened. A lot of time when we don't want to accept it and the patient party is just bent upon making us agree that error has happened, the conflict starts right there. So once you agree that yes, error has happened, you are in a way disarming them because there is no conflict between you and the patient party. And then you start describing how did that error happen. Like in the case that we did a role play around, very clearly when you say that, see, there were two patients by chance by the same name, and both of them had to be operated on the same eye, and they had the same lens power. So this is something when you explain them in simple and non-technical language, you are kind of letting them know how the error happened. And then state the nature of the mistake, where you explained, where Dr. Rima explained that the only error, I mean, the error that has happened is that we have put a different lens than what we had chosen for you. And this is what has happened in your case. You state the nature of the mistake and consequences and corrective action. And she kept insisting on this, that we cannot take out that lens and we cannot put a fresh lens, because they were frequently saying that can we put the other lens, can we remove that lens and put another lens. So make sure that you use frequent pauses, because this comes as a shock to the patient and the family. They will take time to assimilate. They may have questions to ask. They may want to, clarify something. So give them a chance to ask question or clarify things and answer their questions with honesty, because that's where again the direction of your conversation will go. If you are not giving them complete information, if you are covering it, if you are not telling them the truth, they can sense it that you are hiding something, and then slowly they start thinking that how they can take out all the information from you. So apologize, I think this we have discussed, but studies have shown that apology works. When you say sorry, and especially when you express personal regret and focus on patients' welfare, they are usually able to accept your sorry. We have talked about the meaning of apology and how apology fails, but we have to remember that apology has to be unconditional. And then take responsibility, use I statement. Please do not blame your team members for the error. We all have a tendency to say, my staff did this, my resident did this. I mean, accepting that, yes, it's my fault, it's my team fault, we have, like, I'm responsible for it. That also showcases that you are ready to take responsibility of what is happening. Invite questions. So that will show you what they are thinking. So when you ask them, what are your concerns now? What questions do you have on your mind? So that will give you an idea about what they are thinking or what they are worrying about. After you have had a discussion, it's important to make a follow-up plan where you kind of explain them what you are going to do to minimize the damage, and then what are the corrective actions and preventive actions you are going to take for the future. For example, if it was a different case where the patient needed, hospitalization, or patient needed ICU transfer, so naturally the family would want to meet the patient, would like to see the condition of the patient. So there you will have to discuss how you're going to meet their need. So for example, you say, okay, we have moved the patient to the ICU, but let us stabilize the patient, and then I will, ask you to visit the patient so that you can meet the patient and feel satisfied about the patient. So you have to discuss now whatever their needs are, how you are going to meet those needs. Plan for the next update. As I said, this is a very important step, because a lot of time we do not, update them after once we have given the information, and we are also not accessible. I think these 2 points are very important, because if you continue having a conversation with them, if you continue connecting with them, they will not feel being deserted. A lot of time we don't talk to them, we don't connect with them, we don't answer their concerns. So they feel, oh, they have already done whatever they have to do, and now they have left us hanging in between. So it's important to kind of remain accessible, or at least give them a number of somebody who will be around, who can update them and who can answer their questions. Once everything is done, again, it's very important to document the incident. Make sure that you report the incident and actions taken. Rationale for the clinical decisions, or whatever clinical actions you took, what were the reasons for that, you need to document. The outcome and further plan of care needs to be documented. Discussion that you held with the patient and the family. With whom did you interact? What were the relationship of the people who were there? Their names, then questions they asked, and the answers that you gave. All that needs to be, documented. And then, of course, your name and your signatures and contact details. After the situation is over, it's very important to reflect on what exactly happened. See, real learning lies here. Sit back to self-check-in, how you felt, what was difficult, what was it, easy, what could have been done differently so that you could handle it more effectively. Discuss with colleagues. You learn a lot from holding such discussions with people who have experienced something like this. Read material to update yourself, and then, of course, attend programs to learn crisis management, conflict management, because these are difficult situations, and we need to really learn how to go about doing it. So to summarize, I think it's important to prepare yourself for the discussion. State what happened simply in a very honest and clear manner. Apology is helpful. Take responsibility. Don't blame others, and then invite questions that will give you an idea about what they are thinking. Make a follow plan together, and then document and reflect. So 2 3 slides more just to quickly see how these errors can be prevented. I'm sure many of you must have read about Swiss cheese model. So it's very important. See, there are so many checkpoints to avoid those errors. For example, the lens was brought in, and who checked the lens? Who handed over the lens? Who ultimately, implanted the lens? So if everybody had checked, probably this error could have been avoided. So similarly, if, let's take this example that's given in the picture. So a patient was sensitive to a drug, was allergic to a drug. The prescriber, did not collect that detail. As a result, he wrote the medicine that the patient was allergic to. The pharmacist also failed to check the patient allergy status. The nurse gave the patient a drug to which the patient was allergic, and the patient actually experienced harm because of taking the medicine that the patient was allergic to. See, there were so many checkpoints, and if everybody missed that point, ultimately it led to harm to the patient. So it's very important to create multiple checkpoints and also follow those checkpoints. So check, check, and check wherever you can check. And then communicate with the patient, with your team members. You can actually prevent those errors. Practice patient safety measures. There are a lot of protocols available. If you implemented them, I think you can prevent a lot of errors that happen in patient care. And then effective documentation, very important. So some of the practices can change the errors that happen in patient care, provided we follow them, we implement them. So this is in nutshell about disclosure of medical errors. So I want to show you 2 videos. Again, these videos have been done by Indian doctors, so you will be able to relate with them and you will understand. So primarily in the videos, I want you to focus on the behavior and the verbal and non-verbal communication of the doctor who is disclosing the error. So actually, it is not even an error; it's a complication. But I want you to focus on the verbal and non-verbal behavior. Give me 1 second to.
There's no audio.
Who's with Mrs. Kumar? I'm Mr. Kumar. Yes, hello. I remember meeting you earlier in the OPD. This is Mr. Girish, my brother-in-law. Hello. Please sit down. There are a few things I'd like to discuss with you about the operation. I'm afraid I have some bad news. We ran into some complications early into the surgery and we've had to shift Mrs. Kumar into the ICU. What happened? What complication? Oh no. Is she going to be all right? Well, she lost a lot of blood during the surgery and we couldn't realize where the bleeding was coming from. So we've had to open her up and it took us some time to find where she was bleeding from. In the meantime, her blood pressure was low and we've had to give her a lot of blood. Finally, we managed to control the bleeding. This was supposed to be a simple Routine operation. How can this happen? Well, Mr. Kumar, you remember the 1% bleeding complication risk that we spoke about? Unfortunately, Mrs. Kumar has had bleeding. We're doing everything we can to help her. We're giving her blood and IV fluids to support her. So now we have given the blood and bleeding. She's going to be okay, right? Well, she's lost a lot of blood and her blood pressure was low. So we don't know how long she'll take to recover. We'll just have to wait and see. Watch how she does. What do you mean? Well, we just have to wait and see how she does. She's going to be okay, right? When can we see her? The ICU doctors are working hard to stabilize her. At the moment, she's not stable, so you can't see her, but we'll let you know. When she's stable, you'll be allowed to see her. I don't understand. This is supposed to be a simple procedure.
Okay. So, how was it? What do you think was inappropriate in the disclosure or discussion or conversation?
Too blunt. So there was no reassurance to the family. And it was only like we will wait and see, I mean, the efforts were not really seen. He told the OT efforts, but later, there was no reassurance. They were not reassured at the end.
So he didn't introduce himself if he is one of the OT, that person. Another thing, he didn't saw that there are other patients also there. It's an open area.
In an open area, he was counting.
And going after and talking directly without making them realize what has happened. Has that time been passed, and what was how much effort we have put into to make her stabilize. So all these things then put a questions into their mind.
It's very abrupt, actually.
Very abrupt.
Plus, he got up at the end. He didn't even wait for a complete conversation. He just got up.
He seemed to be in hurry to rush to close the conversation and go away.
Yeah.
And see, there were two people. He was communicating with only one. So if you do not communicate with both the parties, what happens when you don't pay attention to both of them? What can happen? What
They
can
might
happen?
feel that the doctor is hiding something, is not very transparent.
And the other person can become more difficult.
Yes, they can
The one
create
who's
more
not
challenges.
being paid attention to.
Absolutely. So they can actually feel offended that they were not addressed, they were not included in the discussion, their questions were not answered. And all in all, if you saw, it was more like, sharing factual information. I had told you, and this has happened in your case. That's all. But imagine if the patient was taken for a very simple surgery and the patient ends up into an ICU. For the patient, but the family, it will definitely come as a shock. So, are you giving them that much of time to assimilate and understand what is the situation, and then how are you going to really help them in that?
And ideally, he should have communicated to the family in between the surgery also.
Could have.
Like when there was bleeding complication, one of the team members could have come out and could have communicated to the family.
Yeah, true. But even otherwise, I think whatever communication happened, that appeared more like matter of fact rather than actually making a sensitive communication. Yeah,
absolutely.
Yeah. So let's watch the second video. Could he have communicated in this manner? Let's see the.
Who's with Mrs. Kumar? I'm Mr. Kumar. Hello, I'm Dr. John. I had met you earlier in the OPD. I don't believe I've met you. I'm Girish, his brother-in-law. Hi, Girish. I'm Dr. John. There are a few things that I would like to discuss with you about the surgery, but I would prefer that we do the discussion in a more private place. Is that okay with you? Okay. Please come. Unfortunately, I have some bad news to share. We've run into some complications into the surgery and we've had to shift Mrs. Kumar to the ICU. What happened? What complications? Oh no, is she going to be all right? I understand that this is not news that you expected to hear, and I'm very sorry about this. There is a lot of information that we have to share with you, and please feel free to stop me if I'm going too fast or if you need any clarifications. Now, Mrs. Kumar had some bleeding early on in the procedure, and we did not exactly find out where the bleeding was coming from. That's the reason we had to open her up, and it took us a long time to find where she was bleeding from. In the meantime, she lost a lot of blood and her blood pressure was low. And eventually, we did manage to find the blood bleeding point, and then we thought we have to shift her to the ICU to monitor her blood pressure. But this was supposed to be a simple operation. How could this happen? Well, in order to do this operation, we first have to put a needle into the abdomen to blow gas before we put the camera in. When I put the camera in, all I could see was blood. I could not see where the bleeding was coming from. And that's the reason I decided to open her up. Where did that blood come from? The bleeding was coming from a major artery inside the abdomen, and it appears that the initial needle insertion was responsible for the bleeding. Who put that needle? I put the needle in, and I'm very, very sorry about it. This just was not expected. We are trying our best to minimize the effects of the bleeding. Is she going to be okay? I wish I could tell you, but it's too early. I just don't know. I certainly hope so. She is on life support medications right now, life support systems for breathing. She is getting blood to keep her blood pressure up and powerful medications to keep her blood pressure up. We're doing all we can. When can we see her? Well, the ICU doctors are working hard to stabilize her, and as soon as she is stable, you could see her. I will let you know. Do you have any questions for me? Really don't know what to say here. I can understand that. If there are any questions, please don't hesitate to ask. In the meantime, I'm going back to the ICU. I will keep you updated on her status. Is that okay?
So honestly, I'm not going to question on whether he should have disclosed this or not. But my focus was primarily on the verbal and non-verbal communication part. If you could sense the empathy, understanding the seriousness of the situation, giving them time to assimilate and respond and ask questions. I think that's what I wanted you to focus. And I'm sure when you do this in this manner, the patient party can sense that you haven't done anything willfully, but you feel sorry for what it is or wherever we are. So this is about you can say breaking bad news or disclosure of medical error or letting the patient know about the complication. And these are all difficult conversations. They require a lot of practice, a lot of deep understanding of human reaction, human behavior, human psychology. That will help you to really prepare yourself for something like this. So, any questions about whatever we have discussed till now? No questions?
I think the whole session was very good, quite informative. We loved it. It was very nice.
Thank you so much, and I really appreciate all of you, attending the program with, such dedication, keeping your camera on, and being around throughout the session. I know it's not easy. It's not easy, but all of you showed a lot of patience and great interest and sincerity. I think that is what I would say. I'm going to share feedback form in the group right now, and I request all of you to kindly give your feedback for this session. And give me 1 second to copy the link and share with you. I'm sharing it here as well as sharing in the WhatsApp group. Yeah, please check if it is working. Dr. Pooja has asked a question. Are errors should be disclosed or not to patient relative? So, Dr. Pooja, if you can unmute and ask your question, it will be better so that I can answer your question. If you are comfortable unmuting your device and asking your question.
Hello, ma'am. Like regarding to medication error or any error, we can disclose to patient's relative also.
Yeah, actually, see, a lot of time, see, if we go by the rule book, the patient has right to the information. But at the same time, we know in Indian context, it is the family who are very deeply, engaged in the patient care. So there is no harm discussing with the patient's family and informing them and keeping them in the loop, definitely. So I've received one response to the questionnaire. I request everyone to complete it. Thank you everyone for your comments and feedback in the chat box.
Thank you so much, ma'am. It was really a wonderful session. We learned a lot and it was really informative and very interactive. Yeah.
Thank you so much. Thank you so much.
Yes, thank you, ma'am. It was really interactive, especially the role plays were really interesting and wonderful.
And there are great ways to learn, how to get into this situation, because unless we get into that situation, we don't get to experience other person's emotions also. So sometimes when you act as a patient or as a family member, even that gives you a deep sense of how the other person must be feeling or experiencing in that situation. That's the beauty of role plays. Yeah. Thank you so much. So we have around 5 responses. I request everyone to give their feedback. If you want, I can also share the feedback form in the group also, so that.
I already shared it.
Oh, great. Thank you. Thank you, Jessie. Thank you so much.
Okay, ma'am, we'll take your leave then.
Thank you so much. Thank you, everyone.
Thank you so much. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you.